actually discussed about this in great detail individually about all the causes of amenorrhea. We've discussed about PCOS, we've discussed about Mullerian agenesis, and of course about ovarian failure and Kalman syndrome. All over the app, these discussions have been done. But yes, it makes good sense to have all of this together in one flowchart so that we can recall about it easily. All right. So let's say something about amenorrhea, the causes of primary and secondary amenorrhea. So when we say amenorrhea, that is no periods. Okay, that means a person is not having periods. Now it can be primary amenorrhea if a woman is not having periods ever. I mean, she is a young girl who has not even started to have periods. Or it can be secondary amenorrhea, a woman who had periods is not having periods for the time being. Now what is that time being? That is defined as no periods for 3 cycles. She's missed 3 cycles, or you can say for 3 months. You can say either way. Some books even say 6 months. So that's the definition of secondary amenorrhea. Primary amenorrhea, of course, is no periods ever. Now we also have to know, since periods is part of the process of puberty, let us also finish off the definition of delayed puberty once more. Of course, we've done that discussion in the app of puberty, but let's have another look at it. So we say puberty time is 10 to 12 years. That's what is the normal time for puberty. But if it is no periods till 13 years, then it is delayed puberty. Or if there is secondary sexual characters, if they are present, then no periods till 15 years. She's 15 years now and she's got no periods, then we say it is delayed periods. So we can say very vehemently and very strongly that 13 is without secondary sexual characters, and if she's got some secondary sexual characters, you can wait up to 15 years to say that the patient has not had periods so far, to call it delayed periods. Now this definition of 13 and 15 is correct, and I know some of your guidebooks and some of your other health books are telling you 14 and 16. That is ancient. It's way beyond ancient now, because the current edition of Novax is saying this, which is the edition of 2020, but the edition which came before this, the 15th edition, had said this 4 years, 5 years back. Okay, so just for your benefit, I'll show you what is written in the books. See this? This is the definition. All right, this is straight from Novax. Primary amenorrhea is defined as the absence of menses at 13 years when there is no visible development of secondary sexual characters, or age 15 years in the presence of normal secondary sexual characters. So please, this discussion finishes here. Okay, so if a person is not having periods, then how do we go about investigating and what all we should be doing? So any woman who is having no periods, whether it is primary or secondary, we would always do a urine pregnancy test. If the pregnancy test is negative, then we do the other things. See, it's a very unfortunate association, because anybody who's not having periods, any young girl who's not having periods, can theoretically be pregnant. And I say this because I've given you this example that I've myself operated on a very young girl of 13 years who was pregnant, and she was actually a case of primary amenorrhea, and she was abused by her uncle. And this happened as when I was a second year postgraduate in my college. So these things do happen. I've seen many cases in the literature about these also. So these are things which are unfortunate events. So never think that a woman cannot be pregnant because she's too young or she's too old. Okay, so do the pregnancy test. After that, we would do the examination of woman. In the examination, I would see her build, her nourishment, if she is not chronically malnourished, because that can also be a cause of amenorrhea. So in the examination, apart from the general features, I would see the developments of the breast, of the secondary sexual characters like the axillary and pubic hair, and I would look for the vagina, if it is on inspection, if it is looking normal, or if it is looking bulging, or if it is looking imperforate, isn't it? I would then do a per-vaginal examination, and I would look for the uterus, if it is present or absent. And once this is done, then I will do the tests like the luteinizing hormone, follicular stimulating hormone, and thyroid stimulating hormone, prolactin, and even the karyotype if required. So, these are the basic set of investigations I would do for a case of amenorrhea, whether it is primary or secondary. But yes, I would have these investigations and then I'll have a flow chart in my head. Okay. So, let's see one by one what all are the problems which can cause a primary amenorrhea or a secondary amenorrhea. All right. So, we'll start with primary amenorrhea. Of course, we've done the pregnancy test and the pregnancy test is negative. Now, we'll look for the secondary sexual characters, and if they are present and the woman is not having periods, it could be because that there is an anatomical defect like the uterus is absent. So, if there is absent uterus, then we know that is the Mayer-Rokitansky-Kushner-Hauser syndrome. That is the classical Mullerian agenesis. We have discussed a lot about this in the chapter of Mullerian abnormalities. She'll never have periods, isn't it? And if she has to have a sexual life, then we'll have to do a vaginoplasty just before she's planning her sexual life. Now, if the uterus is present and she is still not having periods, then it still could be an anatomical defect. Like if there is a uterus like this, the cervix is formed, vagina is formed, but the outflow channel, the hymen has not cannulated, imperforate hymen, or there could be a transverse vaginal septum like this, or rarely the cervix itself could be absent like in a cervical atresia. So, that also can cause a problem of periods. So, imperforate hymen, transverse vaginal septum, and cervical atresia. Mind you, all these three can be corrected surgically and we can make such women have periods regularly. Okay. Now, if the uterus is present and still the person is not having periods, let's take it from here, then we've already done the LH and the FSH like I told you in the previous slide, and the thyroid stimulating hormone, prolactin levels, all of these have been done. So, if these all have been done and still the person is not having periods, then we must see if there is a problem of hypothyroidism or a hyperprolactinemia. These can actually present with primary amenorrhea. Or is there a hypergonadotropic? That means the gonadotropins are made in a good amount, the hypothalamic and the pituitary axis till there things are okay. Hypothalamus is stimulating the pituitary to make the FSH and LH gonadotropins. So, hypergonadotropic, that is increase in LH, increase in FSH and still not having periods, then that is a pure gonadal dysgenesis. And if there is a hypogonadotropic hypogonadism, that means LH and FSH are low. Now, LH and FSH low in a young girl can be because of nutrition problem. She's a young girl who is having secondary sexual characters but not having periods because of a severe chronic malnourishment. Or she's having a chronic illness, or she's an anorectic. So, yes, correction of this can help her have periods, and these are the problems when a person is having sexual characters properly but not having periods. Now, let's move on and see why somebody will not have periods, because there is presence of secondary sexual characters of the asynchronous type. Now, asynchronous, that means the sex of a person is one, but the secondary sexual characters are of the other sex. Classically, we would see that in a case of androgen insensitivity syndrome, also known as the testicular feminization syndrome. You know that when you look at the person, it looks like a girl and she's got all attributes of femininity, but when you examine, you see that there is a blind vagina and there is no uterus. Seen on ultrasound or a per rectal examination, you don't find a uterus. So yes, androgen insensitivity syndrome or a testicular feminization syndrome, like we call it. Now, the secondary sexual characters, if they are present, we have discussed. If they are asynchronous, we have discussed. What if the secondary sexual characters are absent? Now, if the secondary sexual characters are absent, now we have a problem. We have already done, like I said, the LH and the FSH. Let's go by this again. And if they are high, that is hypergonadotropic hypogonadism, again, that is high FSH and LH. That means the hypothalamus and the pituitary are doing the work, but the ovary is not responding. Now, in the presence of secondary sexual characters I have discussed, in the absence of secondary sexual characters, high LH and FSH means a primary ovarian failure. Can also be seen in gonadal dysgenesis, like the Turner syndrome, and it can be seen in conditions where there is a FSH and LH receptor defect. It can also be seen in galactosemia. Galactosemia, the galactose, high concentration of galactose and its metabolites are detrimental to the ovarian stroma and the ovarian follicles, and that can also cause the patient to have a ovarian non-responsiveness to the high amount of LH and FSH which is present. Now, in the condition of absent secondary sexual characters with high LH and FSH, we discussed. But if the LH and FSH is low, that is hypogonadotropic hypogonadism, low LH and FSH. Now, that could be because the hypothalamus and the pituitary axis is taking time to mature in a young girl. So, that could be a physiological delay also. Or it could be because of a Kallmann syndrome, which is a classical case of hypogonadotropic hypogonadism, low LH and FSH. And it could also be because of CNS tumors. The hypothalamic or pituitary tumors can also present with primary amenorrhea because of low LH and FSH. All right. So, let's go and see what could be the causes of a secondary amenorrhea. So, in a case of secondary amenorrhea, of course, we have done the pregnancy test here also, and the pregnancy test is negative. I would want to check hormonal problems because she was having periods so far and now she's not having 3 cycles or 3 months she's not having periods. Then I would do the TSH, and if she's got a hypothyroidism or a hyperprolactinemia, I would correct that and she would get a periods. Now, in spite of having a normal thyroid and a normal prolactin, she is not having periods, then I must see that why is she not having periods. Let me give her a progesterone challenge. That is, a woman, let's say she is around 25 years, she isn't having periods always, regularly, now she is not having periods and she is not pregnant. Hypothyroidism is ruled out, hyperprolactinemia is ruled out. All these things are normal. So, maybe she is having a problem with her hormones. Let's go step by step. So, I give her a progesterone challenge. I assume that maybe the estrogens are formed and maybe she is not ovulating properly. So, she is not having progesterones, and because of not having progesterone, there is no secretion, and when the progesterones fall, women have periods, isn't it? So, let me give her a challenge. I give her a challenge, and progesterone challenge test is classically that I give her medroxyprogesterone acetate, any progesterone tablet, okay. So, I give her progesterones for 5-6 days, and after giving the progesterones, I abruptly stop them. So, if there was estrogen primed endometrium, MCQ for you, if there was a estrogen primed endometrium and I give progesterones to make it secretory and abruptly stop it, she will get periods. So, if she gets periods, if the progesterone challenge test, if we give and she gets periods happen, then we know that it's a case of polycystic ovarian disease. Okay. Classical example for you people. Of course, in the chapter of amenorrhea, I am not giving an endless list of possibilities in both primary and secondary amenorrhea, because the list is actually very big, and those vague syndromes generally don't come in your exams, and they are so rare that even you don't see them in your general practice. I mean, if you see them, then going by these algorithms, you will be able to derive those rare syndromes also. So, let us go by the common things which are generally asked in your exams. So, yes, if the periods come after progesterone challenge test, we know it's a case of a high estrogen situation without progesterone. That is classically seen in the cases of polycystic ovarian disease. Now, when you give the progesterone challenge test and that comes negative, that means no periods. So, now you have a problem that maybe the estrogen itself is not forming properly. So, then we give her a estrogen and progesterone challenge next. So, next is to give a estrogen plus progesterone challenge. So, I give the exogenous estrogen to make the proliferation and I give the exogenous progesterone to give the secretion. Let us say I give estrogen for around 16 to 21 days, normally give for 21 days, and then for the last 5-6 days I add progesterones. So, estrogen and progesterone should make an endometrium grow and become secretory and menstruate. In spite of that, it does not happen. Suppose after the estrogen progesterone challenge, there is no period still, then that means this uterus is having a destruction of the lining. This endometrial lining is so damaged that estrogen and progesterone is not making it grow. That happens when there are these, yes, adhesions, synechiae, which is classical of the Eschermann syndrome. Okay, so estrogen progesterone challenge, no periods, then it is Eschermann syndrome. Now, estrogen progesterone challenge you get and she gets periods. If the periods come after the estrogen progesterone challenge. Now, what could be the possibilities? That only after giving exogenous estrogens that the uterus responded. Could be because of a condition where there is high LH and high FSH and the ovary is not responding at all. So, those are the conditions where there is premature ovarian failure. Yes, LH and FSH high and the patient is not getting periods. That's classically in menopause, isn't it? But now she's a young girl of, let's say, 25-30 and she's not having periods and her LH and FSH is very high. That means the ovary has lost the capacity to respond to this hypergonadotropic condition with hypogonadism, we call it. So, hypergonadotropic, ovary not responding, hypogonadism, premature ovarian failure. That can be one of the causes of this. Yes, it can also be because of a patient having ovarian injury because of, let's say, radiotherapy or let's say because of chemotherapy. It can be a surgical menopause, a oophorectomy has been done. Sometimes patients will come to you and say that they're not having periods, and then you take the history and find out that she probably had a surgery in which the ovary was removed. Maybe she had only one ovary and that ovary was removed, or maybe she had both the ovaries removed because she had a ovarian tumor on one side and the doctor thought it's best that we remove the other ovary also, and that was not discussed with the patient. That has happened so many times in our practice, we've seen such cases. So, yes, there's oophorectomy, or there's an ovarian injury, or there's a premature ovarian failure. When do we call it premature ovarian failure? A patient not having ovarian function before 40 years. After 40 years, it's assumed around 47 to 48, most women will have menopause. So, around that time 45, 48, 50, 55, if somebody is having menopause, it's okay. But if she is having ovarian failure before 40 years, it's too early. to say menopause. So then we call it premature ovarian failure. We have discussed that also in detail. So yes, these will tell us that it's a hypergonadotropic hypogonadism. Now, it could be hypogonadotropic. That means reduced FSH and reduced LH and patient not having periods. That comes in conditions where the central nervous system has taken a beating. There could be CNS tumors, there could be chronic illnesses, or it could be the classical Sheehan syndrome, the postpartum pituitary necrosis, where the pituitary is not having the capacity to respond to the hypothalamic stimulation and there is no LH and FSH. That's why the person is not having periods. All right. So that's the list of conditions which you have to rule out when there is a secondary amenorrhea. Now, having said both these lists of primary and secondary, let me remind you, we have already discussed these conditions in great detail in the app. But yes, most of you want to have a flow chart to think how these things are thought about when there is a patient of amenorrhea. And let me tell you, there is no strict compartment that okay, primary and secondary. We always don't think in such strict compartments because there is a lot of overlap in these things. Okay, let me show you this. Primary amenorrhea, secondary amenorrhea, the conditions like I discussed, but quite a few of them come in the common etiology. Like I discussed with you, disorders of sexual development, gonadal dysgenesis, Mullerian agenesis, and androgen insensitivity, physiological delay, transvaginal septum, etc. Then we discussed pituitary lesions and Sheehan syndrome just now. Of course, one more lesion is the cervical stenosis. Yes, if the cervix has stenosis secondarily because of some infections or repeated DNCs, then cervical stenosis can also cause a secondary amenorrhea. So, primary and secondary, they are the causes which are, attributable primary to these headings. But some of them could be common etiologies. That's why I was saying it's very difficult to put them into one compartment. Like pregnancy was there in both, hypothalamic pituitary tumors was in both, chronic illnesses was in both, similarly hyperprolactinemia and the other diseases like PCOS and thyroid disease. Yes, PCOS can come with primary amenorrhea, but what is your take home message? You know that PCOS is classically secondary amenorrhea, but yes, PCOS can present so early sometimes that the girl never had periods to start with. So yes, classically PCOS is secondary amenorrhea, but can have primary amenorrhea also. So I'll repeat that you cannot put them into such compartments all the time, but yes, there was a requirement that we should know a good flow chart to understand how primary and secondary amenorrhea manage. So that's what we've done in this. All right. I hope some clarity has come to you in getting all this information together in one place. All right. So before we see the revision of prolapse, let's quickly see the supports of the uterus. So if you see the uterus, it is right in the middle of the pelvis, and this is the vagina. If you see a coronal section from the pelvis, the round ligament comes from the fundus of the uterus. Now it goes through the internal inguinal ring and comes and settles into the labia majora in front, and some fibers go into the mons pubis also. So the round ligament, like we know, it's from the fundus of the uterus and goes and holds the labia majora in front like this through the inguinal canal. So that's why the uterus is anteverted, because of the round ligament. That's a very common question also asked. From the sides of the uterus, we see the McEnroe ligaments, and this is front view of the uterus. Now if you turn the patient like this and take a sagittal section and see the uterus from the side, so from the side you will see another support, another ligament to support, which comes from the back of the uterus to the sacrum, and that support is the uterosacral. So this is the uterosacral ligament, and this ligament from the side is the McEnroe ligament or the transverse cervical. All right, here. The transverse cervical. Now, mind you, this transverse cervical is the same known as the McEnroe's. Also known as the cardinal ligament. Now, these are the ligamentous supports of the uterus: the McEnroe's, the round ligament, and the uterosacral ligament. Now, out of this, which is the best support of the uterus? No doubt, the best ligamentous support of the uterus is the transverse cervical or the McEnroe ligament, also known as the cardinal ligament. So we are talking about the best ligamentous support so far. Now, do not get confused when they ask you about the best support of the uterus. It is none of these three. It is definitely not the broad ligament also. Please, the broad ligament is hanging from under the round ligament like this. This is the broad ligament area. And if you imagine, this broad ligament itself is hanging. It is itself hanging from the round ligament. So the broad ligament is no support to the uterus. It is itself taking support. This is the round ligaments. The broad ligament itself is taking support from the fallopian tube. So broad ligament is not a support of the uterus. Some of your books are saying that actually. It's wrong. Okay. So this three ligaments, the best support is the transversocervical ligament. Now, which is the best support of the uterus overall? To understand that, let us look at the pelvis from below. This is a pelvis which is upturned like this. Suppose a woman is standing like this and her pelvis you upturn and show you the outlet. So this is the outlet of the pelvis. You can see this is the symphysis pubis and this is the sacrum here. And this pelvis, the outlet of the pelvis, view from below of the pelvis, the uterus is somewhere here. The rectum is somewhere here. Alright? Can you imagine this empty space? The uterus and the rectum is going to come out every time, isn't it? Every time the one cups, the uterus is going to come out. So that's why we say there has to be some support. So just now I told you, there are some ligaments, some ligaments going from the sides of the uterus, and there's some ligaments which are coming from the front of the uterus, the round ligament, and something from the back. But those ligaments are just ropes. This pelvis, the base of the pelvis is so wide and huge that anything which is suspended by ropes also will still hang out of the empty pelvis. So this outlet of the pelvis needs to get filled up from both the sides. Yes, this pelvis needs to get filled up from both the sides with muscles like this. It will come, muscles will come and fill up the pelvis. So yes, muscles from the pubis to the coccyx. See, the pubis to coccyx, pubis coccyx, pubococcygeus. Muscles from the ilium to the coccyx, iliococcygeus, from both the sides. And then ischium to the coccyx, ischiococcygeus. So muscles from all the three bones will come and entwine the uterus and the rectum. And this will make a mesh of muscles which will avoid the uterus and the rectum to come out. So yes, let's see that in a picture here. This is that picture which I was making. If you see, this is the cut section of the uterus and this is the cut section of the rectum. This is the anterior part of the pelvis, this is the posterior part, and muscle. See this? See, this muscle is coming from this is the pubococcygeus. Then this part of the muscle is the iliococcygeus. Then the ischiococcygeus. They will all come from both the sides and entwine the uterus and the rectum. So this will make these muscles, which are coming from both the sides. I'm trying to show you like this. This will make, actually, if you turn the woman's and make her stand, this will make a floor of the pelvis. The floor of the pelvis made by these three muscles: pubococcygeus, iliococcygeus, and ischiococcygeus. So these three are the best supports of the uterus. Overall best support of the uterus are these three muscles together. So these are known as the levator ani. Okay, the pelvic floor, or the pelvic diaphragm also we call it. So pelvic floor, pelvic diaphragm, or the levator ani, it is no doubt the best support of the uterus. So this is like a trampoline, If you imagine the uterus and the rectum, they are like the two gymnasts sitting over this trampoline like this, uterus in the front and rectum at the back. So you see the openings of the uterus and the rectum, the two openings of this levator ani like this. But the muscles are coming from the sides and entwining these two openings. So that's why every time the woman cuffs, it's like like this. The muscles will go down, but they will bounce back. So this is a dynamic support of the uterus, the levator ani. This will support the uterus and the rectum and avoid them to come out best. Yes, out of ligaments, the best is the McIntosh, but overall the best support is the levator ani. Also the axis of the uterus, the axis of anteversion and anteflexion, that also prevents the uterus from coming out. Prolapse of the uterus, which is classified by the Shaw's system or by the Jeffcoat system or by the pelvic organ prolapse quantification system. So there are many classifications, many ways of staging the prolapse, 1, 2, 3 and 4 by Shaw's. Jeffcoat is 1, 2 and 3, and the degrees from how much from the usual place the cervix has come down minimally to the introitus or outside or totally outside. Like that, there are so many classifications of prolapse. They're not asking you about the classification of prolapse, but yes, one question which I saw in some exam was, which is the best way of diagnosing categorizing prolapse, and that best way of categorizing prolapse is the pelvic organ prolapse quantification system, because this is what is internationally accepted, and inter-observer variation is very less in this. That's why it is the most well accepted way. So yes, this is why you make a grid based on the marks on the anterior wall and the posterior wall and at the apex of the vault of the vagina. So based on that, we are making a full grid. So that's a little complicated. Some other forum we can discuss about that. For the time being, the classification of prolapse, the main systems I've told you. Let's move on and see how does the patient have prolapse. So yes, we all know the prolapse is basically because of the abnormal conduct of labor. Abnormal conduct of labor, or it can be because of connective tissue disorders like Ehlers-Danlos and Marfan syndromes, and so many other types are there. Then spina bifida and increased abdominal pressure. Increased abdominal pressure because of mass in the abdomen or ascites. So the abdominal pressure is too much, and that can cause the pelvic organs to move out of the pelvis. So yes, the main reason for prolapse is the abnormal conduct of labor, and all of you know abnormal conduct of labor means early bearing down, prolonged second stage, faulty instrumentations, multiple perineal injuries, and early resumption of work, and multiparity. There's so many features of abnormal conduct of labor, so many things which a person can do wrong in labor which can lead to prolapse later on. So yes, how does a prolapse present to you? So we always see, if I show you the woman's pelvis from the side in a sagittal section, so yes, this is a sacrum here. So if you see that if you slice a woman like this and show the pelvis from the side, then the peritoneum from the top of the abdomen comes like this, goes over the bladder, behind the bladder over the uterus, behind the uterus over the rectum. So you know this is the pouch of Douglas, and this is the uterovesical fold of peritoneum. So when there is prolapse, whether it is type 1, 2, 3, 4 of Shaw's, when the uterus is moving out, the uterus, when it moves out with the bladder and the rectum, because the bladder and the rectum is stuck to the uterus with the peritoneum. See, the UV fold is making the bladder stick to the uterus. The pouch of Douglas, this fold, the rectouterine fold of peritoneum, this is making the bowel stuck to the uterus. So when the uterus moves out and prolapse like this, what happens? The organs which are stuck to the uterus will also move out in prolapse. So yes, this bladder will move out in prolapse, and this rectum will move out in prolapse. If you see closely, this vagina, can you see this? These two lines, this is the vagina. So this vagina will also move out with the uterus. So yes, when the uterus comes out, it doesn't come out alone. Yes, the uterus has 2-3 friends with him. They're stuck to him. So when the uterus hangs out, he hangs out with his friends, isn't it? So this vagina comes out like this, the posterior vagina comes out like this, and then the bladder comes out, and the rectum comes out. So see, these are the parts of the prolapse. This is the cystocele, this is the rectocele, and this is the uterus coming out. Because of bladder coming out, what the problems? We know that biggest problem of a bladder, which is supposed to be like this, and the bladder goes out like this. The biggest problem is that the patient cannot urinate properly. What do all of us do? We increase abdominal pressure to urinate, isn't it? So when the abdominal pressure increases like that, then the bladder compresses and the urine goes out. Now look at this woman. When she strains to urinate, the bladder goes out like this. How will she urinate? She cannot urinate. So it's very, very demeaning and very, very embarrassing for her that she has to hold a uterus. And with this, she has to put the uterus back into her body like this. So with the hand inside the vagina and pushing the uterus, she has to urinate. And the urine part of it is falling over her hand. It's very, very depressing for her. And most of it stays back in the bladder and can cause retention, infection, stone formation. All right. So that's the problem because of bladder. Similarly, rectal problems like fecal formations can happen. And what we can do to give her relief, we can push the uterus back inside and hold it inside. Yes, we can push the uterus back inside and hold it inside with the pessary like this. That pessary will hold the uterus inside so that she can urinate and also defecate properly. So why do we use the pessary? Why don't we just treat the patient off? Because when the uterus is hanging out, it could be hanging out for many days or many years sometimes. And that's why the uterus, the blood supply of the uterus is not very good. So if I do a surgery of cutting off the uterus, see if I do a surgery of cutting off the uterus, what is this? This is the vaginal hold on the uterus. If this uterus and vagina is hanging out for a very long time, the blood supply is very badly compromised. So these cut ends I'm going to use, the uterus is out, but the cut ends I'm going to use for stitching. Those cut ends won't be having a very good blood supply, and that's why the healing of the wound won't be very good. So very important, when you see a prolapse and the prolapse is congested, you all remember in your gynae days that whenever a prolapse is hanging out for a long time, it will be edematous, it will be swollen, and some of these women will also have some ulcers on the cervix. Why those ulcers form? Because they see this uterus, vagina, and if this uterus is hanging out of the vagina like this, this vagina will be compressing the blood supply of the uterus. So what does this compression of the vagina do? It stops the arterial? No. Arterial flow is 120 by 80. Pressure is too much. It will definitely reach the uterus, but the venous return will be compromised. When there is venous return compromise, there will be venous congestion of the uterus. Venous congestion is what blood? Deoxygenated blood. So that deoxygenated blood, the uterus is all deoxygenated and it is hanging between her legs. When she's walking, it rubs between her thighs. She sits on a chair, it rubs on the chair. So it causes small ulcers, small erosions, and those will not heal because the blood supply, the blood here in the uterus is all deoxygenated. So that's why these ulcers won't heal and they'll become chronic, non-healing decubitus ulcers or dependent ulcers. So yes, that's why we say push the uterus back inside with the ring pessary. When you put a ring pessary like this, the decubitus ulcer will become healed because the venous return will be good, arterial supply will be better, and the healing will be there. And also the micturition and the defecation problems will be taken care of. So pessary treatment is a good treatment, but it's temporary treatment. It is not a permanent treatment. What is a permanent treatment of prolapse? You know that prolapse happens only to mostly to older women around 55 to 65 years of age. So what would you want to do for a uterus which is hanging out of the vagina like this? What would you want to do? Obviously, an old lady, you don't want to take it out. One of the simplest surgeries is to take out the uterus from the vagina. Yes, of course, for a practicing gynecologist. So this uterus has come out in the surgery. This is the vaginal hysterectomy. Now, vaginal hysterectomy has been done. So I'll write here vaginal hysterectomy. Now, when the uterus is out, that part we did not want, but the bladder and the rectum we want. So we'll push the bladder back inside. We'll push this vagina also back inside. So let me draw this again. Now I'll push the bladder back inside. The vagina was hanging out. I'll push the vagina also back inside. Similarly, posteriorly also I do something similar. I push the rectum back inside and I push this vagina also back inside. So now you see this. This was the normal uterus had gone out I remove the uterus. Now I push the bladder back inside and the vagina back, and I push the rectum back. But there is a hole in the vagina here. I suture this hole. Now this is known as the vault of the vagina. This is known as the vault, the highest part of the vagina, or the vault. And yes, this anterior vagina, which was hanging out like this, has been pushed back inside. So this is a loose vagina. The bladder will hit on it and come out again in a few days. The posterior vagina is also loose. The rectum will hit on it and come out again. So what is done? What we do? We make sure this vagina doesn't go out. So we tighten the anterior vagina. We tighten the posterior vagina. So yes, that is what is the repair of the bladder. The bladder should not go out. The cystocele should not go out. To make sure that the bladder or the cystocele not to go out, we tighten the anterior vaginal wall. And for making sure the rectum doesn't go out, we tighten the posterior vaginal wall. So the vaginal opening, is so big in prolapse, we close the anterior wall and close the posterior wall like this. So the vaginal opening stays the normal size. So yes, anterior vaginal repair, vaginorrhaphy. Vagina is also known as colpos. So yes, for cystocele we do the anterior colporrhaphy, and for the rectocele we do the posterior colporrhaphy. But remember, posteriorly there is also the perineal body here between the vaginal opening. Look here, I'll show you here. Between the vaginal opening and the anal opening, what is this area? This is the perineum. So anterior colporrhaphy, posterior colporrhaphy, but posterior also perineorrhaphy. So posterior colpoperineorrhaphy, posterior colpoperineorrhaphy. So what am I doing? What am I doing when I'm doing the anterior wall repair and the posterior wall repair? I am repairing the anterior vagina and the posterior vagina. This anterior vagina and the posterior vagina is essentially a defect. Yes, it's essentially a defect in the pelvic floor. So what is the conclusion regarding the chapter on prolapse? Please remember, when you're doing a Ward-Mayo surgery, or otherwise also known as vaginal hysterectomy with pelvic floor repair, please be very, very careful that if you're not doing the repair of the enterocele, she can have a prolapse of the vault in around 3 to 4 months. And if you do not do the proper colporrhaphy, vagina anteriorly and posteriorly, if you're not doing that repair properly, what else can happen? So if you see the uterus, the anterior vagina, posterior vagina, and the urethra on the top, abdominal wall. So suppose I've done the hysterectomy here, and after doing the hysterectomy, you close the vault. I'll show you. You close the vault. You've done the anterior colporrhaphy. You've done the posterior colpoperineorrhaphy properly. But if you've not done a good surgery and you've not repaired the anterior wall properly, this anterior wall, look at my hand, this anterior wall will slacken. This anterior wall can slacken like this. It may come down like that. So if this anterior wall comes down like this, then the urethra, which is above this, the urethra will also come down like this. Alright. See, the anterior wall has come down. I'll show you in a different color if there's a confusion. See, the anterior wall has come down and the urethra, which was sitting above it. See, the urethra is supposed to be like this. But if the urethra becomes straight like this, see, straightening of the uretrovesical angle, the angle which can cause a stress incontinence. Yes. So you've done a surgery, you've done the anterior repair, but you've not done it properly. So a patient after hysterectomy can also have a stress incontinence. After a surgery, you've done the surgery. Probably before the surgery, she did not have anything like a stress incontinence. But since you did not do a proper repair anteriorly, she can have a stress incontinence, and this can come in within 2 to 3 weeks. You don't have to wait as much as 3 to 4 months in a case of a wall prolapse. A stress incontinence, if the anterior vaginal wall repair is not done properly, can present to you in 2 to 3 weeks. Alright, so let's see a couple of surgeries for the stress urinary incontinence. I'll try to show you in a diagram this way first. So stress incontinence surgeries, I'm not trying to say that stress incontinence always happens as a complication of prolapse. No, as a prolapse surgery complication, it is one of the reasons which causes stress incontinence. Stress incontinence might be an isolated event because of pelvic muscle weakness, and she may not have a prolapse but just a stress incontinence. So let's see surgery. I'm just talking only about stress incontinence. I have moved away from the prolapse topic for the time being. So let's see, this is the pubic symphysis, and suppose this urethra is down. This suppose, I mean, in this diagram I made it very straight, but suppose this urethra is a little down like this. So you want this urethra to be pulled up. That is what is this straightening of the uretrovesical angle. This straightening of the angle I told you is the cause of the stress. So you want to pull up this angle like this. So to pull it up, you can take a rope on top from the urethra and pull it up like this, isn't it? You can pull a rope and do this. Or you also know that this urethra is sitting over the vagina. So something can be taken into the vagina and the vagina can be lifted up. So yes, either you can take a rope which can go from above the symphysis below the bladder neck and go up like this, and we can tie it up like that. So when you pull up this rope, the bladder neck will go up. Or you can take another rope which goes below the vagina and you can take it up like this. So the red rope is pulling just the urethra. The purple one is pulling the whole vagina up. So needless to say, if this is the antivagina and you pull up the antivagina, if you pull up the antivagina, then the urethra will also go up. So yes, the first surgery is the one in red, is the needle suspension. Is the needle suspension procedure. The one in purple is the colpo suspension. It goes by various names. The colpo suspension surgery goes by the Birch colpo suspension or the Marshall-Marchetti-Krantz colpo suspension. And you've been asked questions on these. Don't think these are out of course kind of things. Okay, please. We are having a revision. I'm trying to tell you as many surgeries as possible here. Or you can also do the Kelly stitch. What is a Kelly stitch? Kelly stitch is bladder neck plication. What do you mean by plication? You know, I was trying to tell you this bladder neck is straight. So if you want to, this bladder neck which is straight, if you want to pull it up like this, then you can take a rope on the top, or you can push the vagina up like this, or the paraurethral tissues. See, I'm showing you like this now. The paraurethral tissues at the bladder neck, you can pinch them below the bladder neck. See, again I'll show you. Paraurethral tissues you can hold and pinch. Pull them down below the bladder neck. So the neck will get lifted up. Plication of the bladder neck. That is a Kelly stitch. You must have, in your internship, you must have seen the surgery happening many times along with the basic vaginal hysterectomy. Kelly stitches possibly almost 70-80% of, at least 50-60% of the vaginal hysterectomies, we put a Kelly stitch so that the bladder neck gets elevated a little bit. And the last in this is the regularly asked one is the tension-free vaginal tape. Now, what is this? I'll try to show you from the front of the woman now. So this is the bladder, this is the urethral opening, this is the vaginal opening, and this is the clitoris here. So from the obturator foramina, what do you have to do? You have to take a tape. You have to take a tape from the vagina into the obturator foramina, and from the inguinal canal you have to come out like this. Both ways you have to do this surgery. So this tape, which is going from the vagina to the side of the vagina and through the obturator foramina into the inguinal canal, and comes up like this and comes up like this. So this tape, if you pull it up like this, it lifts the vagina. That vaginal lifting will also lift up the urethra. Same principle of pulling up the urethra. So let's see what I mean by this tension-free vaginal tape. I'll show you in some pictures. All right. So if you see this surgery, look, the same tape I'm trying to show you from a model of a pelvis. From this the bladder here, this the bladder here, and from under the bladder, this the bladder and this the urethra. From under the urethra, you see this blue tape is going. So this is obviously in the vagina. We've gone on the side of the vagina through the obturator foramina and we've come up. And similarly from the obturator foramina we've come up. So if you lift this, the urethral neck will get lifted. I'll show you in yet another diagram. See, this I'm showing you in a sagittal section from the left. So if you see, this is the bladder and this is the uterus here. And if you see the urethra here, this is the urethra. So there's a tape which has gone from below the urethra. See this white color tape, it has gone like this, and from the other side also. See, this is the urethra. I'll make it dotted. So below the urethra, this is gone. Okay, I'll take this out. Below the urethra, this white tape is gone. So when you pull this white tape, the bladder neck will get elevated. So these are the this is the tension-free vaginal tape, and I'll also show you the colposuspension procedure, one which I had just now drawn. The colposuspension, let's say the Birch colposuspension. What is that? You lift the antevaginal wall. So I'm showing you pelvis from the top. You know, if you slice a woman, you know, like this, you slice a woman and show the pelvis from the top. So this is the anterior part of the pelvis, this is the posterior part, and this is the uterus, and this is the bladder. So if you see the bladder, can you see this elevated one tube-like structure going out from the bladder? That's the urethra. And what is behind, what is below rather, this urethra? This is the vagina here. This is the vagina on the sides. So that urethra is sitting over the vagina, we can see. So there are some ropes we take. See, we take some ropes from the vagina and we pull up the vagina. So when we pull up the vagina, the bladder neck will get pulled up. So we tie to the Cooper's ligament here. See those ropes? We tie up those ligaments like this. From the vagina, we've taken the ropes and we tie these ropes to the Cooper's ligament so that the vagina gets lifted up and the urethra gets lifted up. So that is the Birch colposuspension. So these are the procedures by which we can treat the stress urinary incontinence. The question asked of you people in one of those exams was, which one of these 4 procedures is going to have the best long-lasting results? Yes, that's a question. Out of stress incontinence surgeries, needle suspension, colposuspension, Kelly stitch and transvaginal tape, which one of these surgeries will have the best long-lasting results? So the answer to that question is the mid-urethral slings. Just like we described now, the mid-urethral slings can be the tension-free vaginal tape or the transobturator tape. So these 2 types of tapes which are used for mid-urethral suspension, the transobturator tape was actually made so that it has lesser complication as compared to the tension-free vaginal tape or the transvaginal tape. So it was supposed to have lesser complications, but the complications are not much lesser in TOT as compared to TVT. So either of these can be used as the mid-urethral slings for the best results now, because yes, I have all myself taught till so many years that the best results have been achieved by ventral suspension. But now we have overwhelming evidence. Even in Novak's Gynecology, the 2020 edition, it says categorically that for the last 17-18 years, so much of data has been accumulated for the transurethral slings. And this data shows that the survivors of this surgery are so well that the method of choice, the gold standard from ventral suspension, have now gone towards the tension-free vaginal tape and the transobturator tapes, or simply said the mid-urethral slings. Let's see CA vulva. Now CA vulva, in CA vulva, very important is the stage 3C. In stage 3C only the lymph node involvement is discussed. Whenever you read CA vulva, remember, we must think of the lymphatics as the major discussing point. The lymphatics from one side of the vulva can drain into the other side. From the cancer, suppose, is on the right labia, the left lymphatics can be involved. There's crossing of the lymphatics in vulva. So yes, stage 1 is limited to the vulva. And stage 1, remember the salient lines which I'm going to, salient features, okay? It's a very confusing staging, it's a little detailed staging. Let's remember just the very, very basic things. That stage 3 is when the lymph node involvement will start coming. Stage 1 and stage 2 has no lymph node involvement. That's one point. Now stage 1A, it is limited to the vulva, we know, less than 2 centimeters size and less than 1 millimeter depth of invasion. And stage 1B, more than 2 centimeter size and more than 1 millimeter depth of invasion. Okay, so less than 2, less than 1, more than 2, more than 1. That is stage 1 of CA vulva. Now stage 2. Stage 2 is involvement of the adjacent organs. Stage 4 is involvement of the adjacent organs. Stage 2 and stage 4 are similar that way. In stage 2, there is any size of tumor with extension to the adjacent perineal structures. So if you imagine the vulva, what are the organs around the vulva? Above the vulva, you have the urethra. Behind the vulva, there is the vagina. Below the vulva is the anus. So adjacent organs are involved in, say, vulva, then it is stage 2. So whatever the size of the lesion, adjacent organs are involved. So what are the adjacent organs? The lower urethra, the lower vagina and the anus. Now same logic, remember, in stage 4, adjacent organs are involved, but the upper part of the adjacent organs. So that's how I remember this staging. So the adjacent organs are involved in CA vulva, the lower urethra, the lower vagina and the anus. What are the adjacent organs? Upper part, upper urethra. Urethra is a very small organ in a woman, so upper urethra is basically the bladder. So upper urethra and the bladder, upper vagina, and then upper anus. Now there's nothing called upper anus, so it's the rectum, isn't it? So that is stage 4. You can see that upper urethra, upper vagina, and it will also involve the bladder mucosa and the rectal mucosa. So that is what is stage 4. We'll try to remember it that way. That stage 1, there is less than 2 and less than 1. 1B is more than 2, more than 1. Stage 2, adjacent organs are involved. Stage 4 also, adjacent organs are involved. But in stage 2, the lower part of the adjacent organs, and stage 4, upper part of the adjacent organs. These are the basics. And what's the other basic? That the inguinal lymph nodes are involved only in stage 3. So stage 2, tumor of any site with extension to the adjacent perineal structures, lower 1/3 urethra, 1/3 vagina and anus with no nodes. Stage 3, any site, any extension, but positive inguinofemoral lymph nodes. Positive inguinofemoral lymph nodes. Alright, so let's see. Let's take out all of this and try to see it without any clutter. So stage 3, the lymph nodes are involved. 3A, 1 lymph node, more than 5. 1 to 2 lymph nodes, less than 5. Now you would say, if the growth is in the lymph node and the lymph node is bigger, then it should be higher staging. In CA vulva, the logic is more the number of lymph node involvement, worse is the prognosis. So if you are getting confused, let's take out the confusion now itself. It's not the size. If there is one inguinal lymph node which is more than 5 millimeter in size, that is a very early stage, stage 3A1. But if it is 1 to 2 lymph nodes less than 5 millimeter, it goes into stage 2A2. All right. Now let's see what is stage 3B. 3B is 2 or more lymph nodes of more than 5. See, as the numbers increase, the staging goes higher. Or 3 or more lymph nodes, but less than 5. So as the numbers increase, less than 5, but the number is 3 or more, then that is becoming 3B2. Okay. So yes, I know that stage 3C, only thing they will ask you in stage 3C, I know very well in CA vulva, they'll ask you inguinofemoral lymph node involvement. What is the stage? You have to say stage 3. That's the end of it. They will not ask you these minute details. But yes, if you're reading, you must read completely. So I'm telling you that inguinal lymph node and inguinofemoral lymph node involvement, the more is the number, higher is the staging. So don't get confused by the size. More than 5 millimeter is lesser stage and less than 5 millimeter is a higher stage, because when it is less than 5 millimeter, the number is more. Now let's try and decipher stage 4 once more. Stage 4, I told you, is the stage where the cancer has spread from the vulva to the adjacent organs, but the upper part of the adjacent organs. So read stage 4A. Stage 4A, tumors invades any of the following. Tumor invades any of the following: upper urethra, upper vagina, bladder, rectum. This is what I already told you as the introduction to the cancer of vulva staging, that when the upper part of the adjacent organs are involved. Then, very important, fixed to pelvic bone. The growth is fixed to the pelvic bone. Okay, that is 4A1. Now 4A2 is fixed or ulcerated lymph nodes. Do not get confused. If the growth on the vulva is involving the adjacent organs and the upper part of the adjacent organs, it is stage 4. Now that growth is fixed to the pelvic wall, that is stage 4, but that is stage 4A1. It's the growth stuck to the pelvic walls or the pelvic bone. But yes, if it is fixed or ulcerated lymph nodes which are coalesced together, fixed or ulcerative lymph nodes which are coalesced together, that is stage 4A2. Okay, so fixed growth ulcer. See, if this vulva is having, see this, there's an ulcer here. This is the cava vulva. This growth is fixed to the pelvic bone. Now that is stage 4A1. The growth is fixed to the pelvic bone. But if there are many lymph nodes which are fixed to each other and they are ulcerated, now that becomes 4A2, fixed or ulcerated inguinofemoral lymph nodes. Okay, and stage 4 is the worst stage. Any distant metastasis or involvement of the pelvic lymph nodes. See, this word has come only now. Pelvic group of lymph nodes is not a primary group of lymph node involvement in cava vulva. The inguinofemoral group of lymph nodes, as we know, are the sentinel group of lymph nodes in cava vulva. So if the cava vulva is having involvement of the deep pelvic nodes, it's the worst case scenario. You know that cava vulva is a very grotesque surgery. It's a huge cancer removal and huge amount of skin pulling and undermining of the tissues to approximate them is required, and breakthrough of the wound and infection of the surgical wound is a major problem in cava vulva. A lot of us don't take much confidence in cava vulva surgery. It's nothing which a person with a slightly weak heart should be trying to do also, because it involves a lot of surgical skill, a lot of bleeding can happen, and in spite of best of your surgical skills and good opposition, wounds can break through because of the patient having a poor healing capacity. So yes, cava vulva, the major problem is the surgery, and the second major problem is the lymph node involvement. All right, please remember about cava vulva that it is one of the most morbid surgeries. The surgical morbidity of cava vulva is almost 40%. So 40% of mortality of cava vulva is because of the surgery itself. Large, grotesque, incisions and pulling up of tissues and releasing skin and pulling them in the midline and suturing them up. That causes a lot of breakdown of tissues. So that's why we say cava vulva, please try and limit the surgery. That's what we try to do, limit the surgery. So if a woman has cava vulva, then we know that if there's a ulcer here and this can be removed. We can do a simple vulvectomy in stage 1 and simple excision of this tumor, and do not have to take out the lymph nodes if they're not involved. But yes, in stage 2 onwards, what we do, we want to look if it is having lymph node involvement, because lymph node involvement makes it stage 3. So from stage 2 onward, we start thinking in terms of wide excision plus minus lymph node excision if there is involvement. So how to look for the involvement in CA vulva? That we put a dye into this, and that dye, if suppose I put a technetium 99 dye here and it find its way into the inguinofemoral lymph node, and this is also having the same dye, then I know that this woman, suppose this is the thigh here, and this lymph node is positive. So yes, if this is positive, then the tumor is spreading to the lymph nodes. Then we have to do, along with a wide excision or a radical vulvectomy, if I do, along with that, I will have to take out the lymph nodes also. So along with the radical vulvectomy, I will also have to do the lymph node excision. So yes, what is the impetus? Stage 1 and stage 2, we just remove the tumor and the vulva and leave the lymph nodes. But if the lymph nodes are involved, then becomes stage 3, and those tumors we have to do a radical lymphadenectomy also. That lymphadenectomy is the reason for more grotesque and more morbid procedures, and subsequently the cause of death. That is one point about CA vulva. Please remember, the lymph node involvement of CA vulva starts in stage 3. We've discussed in the staging just before. And also important is that there is crossing over of the lymphatics from this right side. Suppose there is a tumor, it may involve the lymph nodes of the contralateral inguinal area. So there is crossover of the lymphatics, and the pelvic group of lymph nodes, the deep pelvic group of lymph nodes are not draining the vulva. So if they are involved, if the pelvic group of lymph nodes are involved, I've told you in the staging, then it becomes a stage 4 tumor. And we should also remember the basics of CA vulva, which we regularly asked in the exams, that yes, it is classically seen with women who are beyond 65 years of age, and it is older women, of course, and it is classically presenting with itching, the itch scratch cycle. If a patient has some irritation and she scratches, and the scratching releases some histamine, more itching, more scratching, and classical presentation of CA vulva is itching. And yes, it is not associated with HPV. The one which is associated with HPV is seen in the younger model, the younger women, and it is associated with HPV and smoking, and it is a multifocal lesion. And that's what is the basaloid variety. The basaloid variety of the vulval cancer, and the one which is seen in older women associated with itch scratch cycle and the lichen sclerosis. This is the keratinizing variety. So yes, the classical variety of CA vulva, the classical presentation is an older woman with itching, and it is not generally seen with the HPV. The HPV association is with the young woman and the basaloid variety. What is seen in almost 1/5 of the women in this world. 15% of women, or 1/5 of the women in the world, that is every 5th woman in the world is having PCOS. That is the kind of incidence this disorder has. It is the most common endocrine disorder of women of the reproductive age, and this is also the most common cause of hirsutism. Now, please don't say that idiopathic hirsutism is the most common cause of hirsutism. Idiopathic is only 25% of the hirsutism. Remaining 75% of that, the most common cause of hirsutism is PCOS. So if a girl is hairy, think of PCOS first. Of course, it can be congenital adrenal hyperplasia, it can be ovarian or adrenal tumors making androgens, or it could be even Cushing syndrome. But the most common cause is PCOS. Alright. Now, when we talk about PCOS, what is the syndrome of PCOS? So classically, the diagnostic criteria used to be known as the Rotterdam criteria. It is still used. It was a conference in 2003 in Netherlands. Rotterdam was the city, and this criteria is now being used by all the societies. The ESHRE criteria or the ASRM, ESHRE is European, ASRM is American, the Indian criterias or the androgen excess society criterias, all of them, they now say that if any of these two are present, that is anovulation, hyperandrogenism, or ultrasound features of PCOS. Any two of these, if they are present, then we say the woman has PCOS. Now, hyperandrogenism can be either she could be clinically hirsute, or she could have lab parameters increase of testosterone. So it needn't be just hirsutism. It could be that she's looking all right, she's not having obvious hirsutism, but the clinical parameters are not there, but the lab parameters are showing that there are high androgens. All right, so 2 out of these 3 is enough to call PCOS. Now, speaking about the ultrasound features, when we say PCOS, one mistake with all of us was, I mean, at least me, I always thought when I was in my MBBS that polycystic means many cysts in the ovary. So, polycystic ovary, just literal meaning of that term, polycystic. So, in polycystic ovary, this is exactly what you don't see. Don't say that polycystic ovary has many cysts in the ovary. Polycystic ovary, when Steele and Leventhal coined this term, they said that there are multiple follicles in the periphery and these follicles are not increasing in size, and they termed them as cysts. But now we know that to say a cyst in the ovary, a lesion has to be at least more than 3 centimeters in size. So that's why in modern times, this polycystic ovary, the name sounds like a misnomer. So please remember, polycystic ovary has no cysts. Please, polycystic ovary has a slightly enlarged ovary, and that slightly enlarged ovary has a chain of, a necklace of many small follicles. Can you see? A necklace of pearls. There are so many small follicles in this ovary. Can you see? This is one section of the ovary, then the same ovary in another section you see. So there is a necklace of follicles. There's a chain of follicles. All right. Now, these follicles are pearl size. We classically say it's a necklace of pearls or a chain of pearls or a ring of pearls. So, necklace of pearls or ring of pearl appearance is there. These follicles are around 20 per ovary, and earlier we used to say 12 per ovary. Now, you must be careful. We say 20 or more follicles per ovary, and these follicles are generally 2 to 6 millimeters in size. When we say 2 to 6 millimeters in size, these are known as the antral size follicles, and these are never more than 9 millimeters. They're less than 9 millimeters. All right. There's a thick stroma. The stroma, the follicles are like this, chain of small follicles like in this picture, and then the stroma is thick. This is that thick stroma which is seen here also. This is that thick stroma here. All right. Now, the ovarian volume is a little increased, more than 10 cubic centimeters, and the criteria of this, ultrasound criteria of this, if it is seen even in one ovary, we can say that the woman is a PCOS morphology on the ultrasound, even one ovary having this. Now, what are the PCOS phenotypes? There are 4 PCOS phenotypes. The basic 3 diagnostic criteria which I told you are the hyperandrogenism, PCOS morphology on the ultrasound, and the anovulation. Now, if all those 3 are present, that is the most common phenotype of the type 1. Type 2 phenotype is hyperandrogenism with anovulation. Type 3 phenotype is hyperandrogenism with PCOS morphology, and type 4 is anovulation in PCOS. In that, there is no hyperandrogenism. So these are the 4 types of PCOS morphology which we know, and the most common type of this is the type 1. Type 1 morphology is the most common PCOS morphology. Now, what is the syndrome of PCOS? Before going to the syndrome of PCOS, now let us quickly revise what we discussed about the normal menstrual cycle just a little while earlier. So we discussed about the pituitary hormone, the FSH, the ovarian anatomy, how it is growing because of the high FSH, and with the growing follicle, how the estrogen is increasing, how the endometrium is proliferating, and when the follicle size is 15 to 20 millimeters in size, it makes enough estradiol, that is 200 picograms, to cause the LH surge. which rupture the follicle residue site and make a colpocidum, which makes the endometrium secretory and stabilized, and the colpocidum degenerates after 10 days, and that causes shedding of the endometrium and periods. So that is what is the normal menstrual cycle. Now, what happens in a PCOS cycle? In the PCOS cycle, the ovary has multiple small follicles. But now, how many such follicles are there in the ovary? There are at least 20 follicles per ovary, and 2 ovaries means there are 40 or more follicles in the woman. So these multiple small follicles are not very small primordial size. These are the size of antral follicles. So antral follicles are 2 to 6 millimeter in size. Like I told you, and mind you, this has come as an exam question also. What is the size of antral follicles? Now, antral follicles are around 2 to 6 millimeter in size, and many such antral follicles are there. So all those antral follicles, 2 to 6 millimeter in size, although they are not increasing in size, they are so many of them, and each one of them is making some amount of estrogen, in fact. So the estrogen amount will actually increase. It will go on increase with the follicles making some amount of estrogen. That 40 such follicles in the woman, at least 40 such follicles. So with the increasing estrogen, what happens to the endometrium? Initially, of course, the endometrium is bleeding, and then when the estrogen increasing, with the estrogen increasing, the endometrium starts to proliferate. So proliferation happens, and when the estrogen reaches a sufficient amount, like 200 picograms, there is a elevation of the LH. So LH is actually high in a case of PCOS. In fact, there is no such surge in PCOS because there is a constant elevation of estrogen, and that constantly keeps giving a message to the brain that there is a follicle ready. This is fooling the brain actually. The brain thinks that there is one mature follicle because the estrogen is very high. So brain keeps sending the LH. So PCOS women classically have high LH. And what happens? It is a brain which has been fooled to send that LH, because one follicle should send the message of 200 picograms. But now what is happening? Many small follicles have got together and sending information to the brain, and the brain thinks that there is a follicle ready, I can send the LH. So that estrogen is high because of not one but many small follicles, non-mature follicles, making that high estrogen. So that LH is high. Now what happens next? So far it looks very much like the normal menstrual cycle. But now the LH is high. High LH should rupture the follicle, but the follicle here is only 2 to 6 millimeter in size, and it should be at least 15 to 20 millimeters to rupture, like we knew it. So the follicle stays small. When the follicle stays small, that is what is the anovulation. One part of the equation understood. Because the follicle is small, it will not ovulate. But since it is not ovulated, because the size is not mature, it is not ovulated, what hormone which was supposed to increase will not increase now. Progesterone was supposed to increase, it will not increase now. So when the progesterone does not increase, which hormone goes on forming from these follicles? The estrogen goes on forming from these follicles. So estrogen stays high and progesterone stays low. Now, which action on the endometrium should have happened and will not happen? Since there is no progesterone, she will not have any secretion on the endometrium. And what action will continue to happen? Since the estrogen is increasing, endometrium will go on proliferating. It goes on proliferating. So this is 0 day, this is 14 day, and you can say maybe 28 day here and 60 day here and 90 days here. The endometrium just goes on proliferating for months. Sometimes women have periods once in 3-4 months in PCOS. Many women have PCOS in 45 days. I know of patients who have been having periods once in almost a year with PCOS. So that kind of delayed periods can be there with PCOS because the endometrium is going on just proliferating because of the high estrogens. Now, estrogen is going on increasing, endometrium is going on proliferating. Let's say this patient has not yet menstruated for even 3 months. So that means anovulation, and it also is showing delayed cycles. Now, oligomenorrhea understood, amenorrhea understood, because if 3 months she doesn't get periods, we call it amenorrhea, and anovulation and infertility understood. Now, finally, how will she get her periods? This endometrium outgrows the blood supply. The blood supply is from the base to the top of the endometrial glands. So these top of the glands, the top of these endometrial glands, they'll start becoming ischemic, and these ischemic glands will start to shed, and there'll be a ischemic withdrawal. Okay. So this woman does not have a progesterone withdrawal like normal woman. This woman has a ischemic withdrawal, and because that she gets delayed cycles. Now, these are delayed. After delayed cycles, woman will be very happy. Okay, fine, I get periods. Okay, I'm not getting them on time. I'm getting them once in 3 months. At least they'll finish in 5 days. Even that does not happen. What happens? She gets periods in 3 months. There'll be some shedding. But now, these glands will start to grow. They will become ischemic after some time. Now, they will also shed after some time. So, this period which starts late does not even finish properly. This goes on bleeding for 10, 15, 20 days, sometimes even more than a month. Some spotting goes on happening because this ischemia goes on happening. So, that's why the syndrome of PCOS. The syndrome of PCOS, just now we discussed that the woman cannot ovulate. So, there is anovulation. It is associated with infertility. We know that. Then the period comes after 35 days. It is oligomenorrhea. Missing 3 cycles, regular cycles, or no periods for 6 months is amenorrhea. Now, why is the patient having hirsutism? That's the other part which we have to learn. So, this woman is having multiple small follicles and she's having a thick stroma. Now, this stroma is what is actually known as the theca cells. We discussed in the first part of the class that yes, in the menstrual physiology, we discussed that the theca cells makes the androgens and the androgens go to the follicles and the follicles convert the androgens to estrogen by aromatization under the influence of follicular-stimulating hormone. Now, let's get back to this basic. Where are the androgens made? In the ovary. Normal ovaries of every woman make androgens in the theca cells. And these androgens which are made in the theca cells are naturally because of these LH. LH acts on this and the LH stimulates the theca cells of the ovary to make the androgens. Normally also, now you see in this woman, LH is very, very high and the stroma is very thick. So that's why the androgens are very high. Alright, so high androgens cause the hirsutism. We know that. What is the cause of the high androgen? It is the thick stroma. And thick stroma is stimulated by what? By the high amount of LH. So high LH, and that is the cause of the woman having hyperandrogenism. Alright. So now we understand the androgens are high. So that causes the hirsutism. So hyperandrogenism and hirsutism also understood. Now let us look at the lab parameters. Lab parameters are very important because now we have seen that the woman in PCOS is having a high amount of LH. Why is there high LH? The purpose of LH was to make progesterones. Woman did not ovulate, so there was no progesterone. So purpose of LH is, remember the basic menstrual physiology class, purpose of LH is to make progesterones. There are no progesterones, no feedback to the brain of progesterone, so LH is very high. So high LH. What is causing the LH surge? You know, the high estrogen is sending the message to the brain to cause the LH surge. So LH is classically very high. There is high LH in PCOS. Now what happens to the FSH? Purpose of FSH, basic menstrual physiology class, purpose of FSH is to make estrogens. Now, this woman is making lots of estrogens and that estrogens from the ovarian follicle, the multiple small follicles making so much of estrogen, that will give a feedback to the brain and the brain will think that there is so much of estrogen, so I'll keep the FSH low. So, FSH is traditionally, classically low in PCOS. So, what happens to the LH and FSH ratio? It is more than 3:1. In PCOS, the LH ratio is increased. Now, this LH acts on the ovaries we discussed in the theca cells and increase the production of androgens. So, the testosterone is increased. Now, the sex hormone binding globulin, SHBG, sex hormone binding globulin is made from the liver and it is in limited amount. The liver does not make very high amount of SHBG just because there is high amount of androgen being produced. So, sex hormone binding globulin binds to the circulating sex steroids like the androgens and the estrogens. Now, these are limited in amount. So, testosterone goes on increasing, even androstenedione goes on increasing, and to bind them, the sex hormone binding globulin is limited. So, what is the net result of these two things? There is increased free androgens. Increase free androgens. All right. So that is the cause of the hirsutism and hyperandrogenism. Now, why is all of this happening in a case of PCOS? So we discussed PCOS very well just now, that all of this is because of the small follicles. The punchline of PCO is the small follicle. The small follicle which is not growing and causing anovulation, and when it is not growing, there is no enough size for the ovulation to happen. The LH is high, but in spite of that, the ovulation doesn't happen. When there is no ovulation, there is anovulation infertility, and when there is no ovulation, there is increasing estrogen causing the endometrium to be hyperplastic, and that endometrium sheds with ischemia causing delayed cycles, and this high LH will act on the stroma of the ovary and causing hirsutism. All of this is explained because of the small follicle. Now, why is there a small follicle? So the reason of that small follicle is what is known as the insulin resistance. Insulin resistance. We have to understand very simply that insulin is required everywhere in the body except brain and the RBC. My knowledge of biochemistry is not so strong as yours, but I think insulin is required everywhere in the body to pick up the glucose moiety and push it across the cell membrane inside the cell, isn't it? So for that glucose to get into the ovary, let's say I'll make a very simple diagram. Suppose this is the ovarian artery which has got enough glucose in it in circulation, and this glucose has to get into the ovary. But this ovary with thick stroma has something called insulin resistance on the ovarian receptor only. On the ovarian receptor, there is insulin resistance. Mark my words, I'm not saying the woman is a case of diabetes. I did not say that. This woman is having insulin resistance only on the ovarian receptor level. So the glucose which has to get into the ovarian stroma, ovarian follicle is less than adequate. So the less glucose present, there is less follicular growth, and less follicular growth means a small follicle. So that's why the woman has small follicles. So yes, small follicle, I told you, is the cause of the PCOS, and that small follicle is because of insulin resistance. And when there is insulin resistance, it is associated with obesity also. And when there is insulin resistance, what happens to the circulating level of insulin? So the fasting serum insulin levels are increased. All right. Now, in addition to this fasting insulin levels being high, we can use a ratio which will help us diagnose insulin resistance. So the fasting glucose to insulin levels. See, fasting glucose and the fasting insulin levels, the ratio should be more than 4.5. Now, this ratio, it's very obvious that if the insulin goes on increasing, fasting insulin levels are high, then this ratio will reduce. So, if this ratio is less than 4.5, then that is diagnostic of a patient having insulin resistance. Now, insulin resistance we discussed is the reason why the follicles are small. So, why is there now insulin resistance? What is the reason of this insulin resistance? So that takes us to the etiology of PCOS. So that is polygenic inheritance. You can say it is familial predisposition to have PCOS, or there could be a genetic influence. There could be some environmental factors. So many things together will go on to cause a woman to have PCOS. So yes, it does run in families, but there are women whose mothers are PCOS, but this girl does not have, because it could be some other reasons. So that's why this insulin resistance is basically polygenic. All right. Then one more thing you should understand about PCOS is that there is overexpression of the 17-hydroxylase enzyme. So what is this 17-hydroxylase going to do? So I have always told you in my classes that please concentrate on this steroidogenesis, adrenal steroidogenesis. This whole chart together, all these enzymes and these substrates together, we must know. So I've just given you a quick revision here. See, when the cholesterol is broken down in the adrenal glands, the purpose is to make steroids, the mineralocorticoids and the glucocorticoids, and to make androgens. And one of the important enzymes here is the 17-hydroxylase. This 17-hydroxylase breaks down the pregnenolone to androgens and the progesterone to the androgens. Now, if there is 17-hydroxylase, if it is overexpressed, if there is more of 17-hydroxylase, there will be more production of DHEA and androstenedione, and ultimately more testosterone. So that's why androgen production is also increased in PCOS. Now, another thing which I want to tell you in PCOS is the metabolic syndrome. Just now we discussed the syndrome per se, all the things which are seen. I told you the diagnosis of PCOS, 3 parameters, 2 out of these 3 is PCOS. Then I told you the complete syndrome of PCOS. Now, if a woman has PCOS and she has this metabolic syndrome, what is this metabolic syndrome? We also call it the syndrome X. Hypermetabolic syndrome X, we call it. So this syndrome X is what? A woman having a waist of more than 35 inches, a triglyceride level more than 150 milligrams per deciliter, high density lipoproteins less than 50 milligrams per deciliter, blood pressure more than 130/85, and a fasting glucose of more than 110 to 126, or a 2 hour 75 milligram GDT showing a value more than 140 to 199. Out of all of these parameters, if 3 or more are increased, then this PCOS woman has increased risk of coronary artery disease later in life. Remember, in addition to having coronary artery disease, PCOS later can have diabetes mellitus and CA endometrium also. So diabetes mellitus, CA endometrium, and even ovarian cancer, along with increased risk of coronary artery disease. So it's important to take care of PCOS in a very, very sincere way. It requires a lot of counseling. I've always maintained that the amount of time we take you to understand PCOS, even in a rapid revision, I take at least this much of time for the patients also in the OPD to understand, because it's a lifestyle management. You have to change the lifestyle of this patient to give her relief in PCOS. See, you cannot say that 15% women in this world are abnormal. See, 15% women have PCOS. So yes, some women have regular cycles, some women have irregular cycles, all right? It's just as simple as that. So we can give them a normal life, a regular life, and a life where they can have pregnancies, regular cycles, everything will be normal, but they must come to us and discuss with us. We will counsel them. So the first line treatment is always the lifestyle modification. Lifestyle modification would consist her to exercise and go on a diet and lose weight. All of this will be required for her to understand that she is going to be better if she gets into this basic lifestyle management exercise. Now, I have seen that women with just loss of weight can go on to ovulate in at least 30% of cases. So let's see individual parameters which we have to take care of in a case of PCOS. Irregular cycles, major problem. We can do the drug of choice of this is combined oral contraceptive pills. Please understand, combined oral contraceptive pills are given as long as she wants regular cycles. Now, this is also one misconception amongst hundreds of medicos, that whenever I ask a question in a class that how long, especially my intern friends, how long do you want to give OCPs to women who are having PCOS? And the pet answer everybody says, sir, 6 months, or some people say 3 to 6 months, because the postgraduates are teaching them that. And a lot of people think that if you give PCOS combined oral contraceptive pill treatment, the cycles, if you're giving them for 6 months, the cycles will become regular for life. Please, that does not happen. The cycles will be regular only as long as you're giving the combined pill. Please, you're not treating PCOS with the OCPs. OCPs is giving a artificial cycle, like we've already discussed in the classes. Please, OCPs does not give a natural cycle. It's an artificial cycle. So when there are these artificial cycles, they are getting these cycles regular only as long as you give the pill. So please remember, combined pill as long as she wants regular cycles. She's a 19-year-old girl. She's having irregular cycles. She's PCOS. She's come to me. I'll give OCPs for, let's say, 4 years, 5 years, 6 years. Then she decides to get married and now she wants to have children. Then I'll give her ovulation induction treatment. So very important, please treat according to the presentation. There is no one drug which is the drug of choice for PCOS. Don't say that this one drug is the drug of choice for PCOS for all the problems of PCOS. There is nothing like that in PCOS. Okay. So for the regular cycles, the drug of choice is OCP pills. Also, we can give progesterones in the later half of the cycle. later half of the menstrual cycle, we can give the progesterones. Now, how does this work? So we know that the endometrium is proliferating and only proliferating. Let's say this is the 0, this is the 14, and this is the 28 day. A case of PCOS. Now she would go on proliferating even beyond this. So what we can do, we know normally a woman will have ovulation on the 14th day, and the corpuscle works for how many days? For 10 days. So we can give from the 14th day to 24th day, we can give her progesterone tablets, and that will make all of this endometrium secretory. And when you stop the progesterone tablet, she has a withdrawal and she gets her cycles on time. So yes, this is a withdrawal induced because of progesterone. So this will also give her regular cycles. Sometimes we act even more smarter. What we do, we don't give it for 10 days. So 14, 28, we give this only from the day 20 to day 24, 5 days only. We give it only for 5 days. So when we give only for 5 days, this tablets which you give for 5 days will make the endometrium secretory in the later half of the cycle, and when I stop the tablet, there will be a progesterone withdrawal and she will have menstruation. So we can give her regular cycles even by giving her just progesterones, and a lot of girls like this better than giving them OCP, which will suppress the production of estrogen and progesterones both. But here, giving only the progesterone, it is not a 21-day regime, it is just a 5-day regime, and she gets regular cycles. So she's much happier taking just a 5-day tablet than a 21-day regime. All right. Now let us see the management of anovulation in a case of PCOS. So the first thing which we do always is lifestyle modification. So loss of weight, just loss of weight by 5 to 10%. Suppose she's a lady of 90 kgs and she comes down to 80 kgs. That itself will cause 30% cases to ovulate. Just by losing weight, they can ovulate. Now, the next thing they can do is we can give insulin sensitizers, because we know that the patient is having insulin resistance as the major cause of anovulation. So insulin sensitizers like metformin can be used. That is another 30% women shall ovulate with this. But let us see some specific drugs. So quick revision of what all we discussed about PCOS, that in a case of PCOS, the normal menstrual cycle has altered a little bit, because we know the hypothalamus is stimulating the pituitary by the GnRH, and the pituitary is making the FSH, and the FSH has to make the follicle grow. But the follicles are so many from before itself that they're making enough estrogen. So that enough estrogen which is there, it is giving a feedback to the FSH already. The brain gets a message that there is so much of estrogen. So the FSH is actually very, very low in a case of PCOS. And we've discussed that since the estrogen is very high, there'll be a positive feedback to the brain to cause the LH. So LH will be very high, and the LH has to act on the ovarian to cause the ovulation, but the ovulation does not happen because the follicle size is small. So there is no progesterone, and when there is no progesterone, there is no secretory action. So when there is no secretory action, there is only proliferating action. This we have discussed earlier also in this chapter. Now quick revision was done. Now let's see. So what specific drugs we can use now? So we say that we can use a drug called clomiphene citrate. You know, it's a selective estrogen receptor modulator. It's a SERM. It has got estrogenic and anti-estrogenic properties. It is a racemic mixture of N-clomiphene and Zuclomiphene. N-clomiphene is the major part, 62%. Zuclomiphene is 38%. And the anti-estrogenic action is what we want to use. So the anti-estrogenic action of clomiphene citrate is used. How does it work? It goes and blocks the hypothalamic estrogen receptor. Hypothalamic estrogen receptor blocker. So when there is a block to the estrogen action in the brain thinks there is no estrogen. So what is the purpose of FSH? To make estrogen. And now the brain thinks since there is no estrogen, the brain will increase the FSH. You know that FSH is low in PCOS. So now the brain will increase the stimulation to the ovary by increasing the FSH, and that high FSH will make one follicle grow bigger than the others and ovulate. Maybe sometimes two will ovulate and cause twins. All right. So hypothalamic estrogen receptor blocker will cause increase in FSH and that causes ovulation in as many as 80% cases. It causes pregnancy in as many as 40% of cases. It causes twin pregnancies in 8 to 10% of cases, and side effects are headaches. Most common side effects are the headaches. Then it can cause flushing, and it can also cause some visual scotomas. The dose given is 50 milligrams per day to up to 250 milligrams per day for 5 days. We give it from the 2nd to the 6th day of the cycle, that is 5 days. So when we give it in the initial days of the menstrual cycle, it is going to cause the feedback to the brain of the estrogen is reduced and the FSH increases, and that's when you want the FSH to increase in the initial days of the menstrual cycle. That will cause the woman to have high FSH and the ovulation happens. Now, another strategy is to give letrozole. Now, where does letrozole work? We know normally that the androstenedione, the androgens are converted to estrogens by the aromatase enzyme. Now, letrozole is an aromatase enzyme inhibitor. So what happens when aromatase enzyme is inhibited? There is very less estradiol. When there is less estradiol, there is lesser feedback to the brain. Now, what is the purpose of FSH? Once more, the purpose of FSH to act on the follicles to make estrogens. If you reduce the estrogen, brain thinks there is not enough estrogen in the body, brain will again increase the FSH. So the net result of even this letrozole is to increase the FSH. But this increase in the FSH, now letrozole has more pregnancy rates. Now, why more pregnancy rates compared to what? Compared to clomfencid? Because we know that the clomfencid has an estrogenic and an anti-estrogenic action. We are using the anti-estrogenic action to give a feedback inhibition to the brain, and the brain increases the FSH. That is clomfencid anti-estrogenic action, which is useful in the induction of ovulation. But the same anti-estrogenic action happens even on the endometrium, and the endometrium in almost 50% of cases of clomfencid, the endometrium stays thin. So that's why the pregnancy rates are lesser. So ovulation happens in 80%, pregnancy happens in 40% cases of patients who are using clomfencid. Here, the pregnancy rate is higher than 50% in the case of letrozole. So increased pregnancy and better endometrium and lesser twins, around 3% only. Clomfencid has 8 to 10% of twins, and also lesser anomalies. Look, all of us like twins, but you must also think of the parents. All of us will accept twins happily, but then those parents who don't want to have two children together, for them twins becomes, and even triplets becomes, a complication of infertility management. So don't say that it's okay if you don't have children, you have two now. That logic doesn't work. Okay, try to give singleton pregnancies, and that is what is better. So lesser twins and better endometrium and lesser anomalies when you use letrozole. Now, what is very important? The next slide. Please understand that the drug of choice is which one? Is it clomfencid or letrozole? The drug of choice is letrozole. What is this drug of choice for? Drug of choice for ovulation induction. So far, what are we discussing? I'm telling you the treatment of PCOS, and I said there is no one drug for the management of PCOS. For irregular cycles, I said you can give combined pills or progesterones. And for ovulation induction, I told you letrozole or clomfencid. For ovulation induction, what is the drug of choice? That is what is letrozole. Now, what is another thing which we saw? When I give letrozole, you increase the FSH. When I give the clomfencid, we increase the FSH. So why don't we just give injections of FSH? So we can also give injections of FSH. Sometimes recombinant FSH is there, sometimes urinary FSH is there. We can use either one of these, and we can also give injections of human menopausal gonadotropin, which has equal amount of FSH and LH in it. So human menopausal gonadotropin made from the, yes, you guessed it, post-menopausal women urine. Yes, it is very well understood that LH and FSH is very high in menopausal women. So in their urine, LH and FSH is high. From the urine, we fractionate the LH and FSH, and it can be used as injections for young women to cause ovulation induction. Now, the other thing which we have to take care of is the hirsutism. Now, hirsutism, please remember, it doesn't get treated overnight. So, always think of cosmetic treatment as a possible management. Okay. Most women, I can easily say all women will, who are having PCOS, they'll hate their hirsuits and hate the excessive body hair and the facial hair. Yes, I know to give cosmetic treatment, some sects of people may not be very comfortable listening to this information, but I can say at least 90-95% of women will be happier by getting a cosmetic treatment of this excess hirsuits. So cosmetic treatment by electrolysis or by laser epilation of these hair roots, all of that is very good treatment for immediate relief and good relief to the lady. But drugs which we can use, which will show results in almost 6 months to 8 months, they will not have the pilosebaceous unit will have to change. So it will not show results overnight. The pilosebaceous unit has to be taken away from the androgen dominance and given lesser androgen dominance, and then the new crop of hair will become better in 6 to 8 months. So we can give the first line drug we give for hirsutism is the spironolactone. You know, it's a diuretic. But it also has the anti-androgen properties. So we can give 50 milligrams to 100 milligrams twice a day treatment schedule. It is the first line. And mind you, the side effect of spironolactone, the most common side effect is metorrhagia, which is mid-cycle bleeding. All right. Of course, if you give spironolactone in men it is known to cause gynecomastia. All right. So don't say gynecomastia is a complication here. Okay. We are talking about women. So here the complication is metorrhagia. Now, patients who are having hirsutism also respond very well to this progesterone, which has got a anti-androgen action, which is cyprotronstate 100 milligrams per day. Now, after all of this treatment, sometimes we see that whatever drugs I give, it does not give any results or any response in PCOS. I give a letrozole or clomiphene citrate, HMG injections, FSH injections. None of them cause ovulation induction, and she has no response. That sometimes happens because of this thick ovarian stroma in PCOS. This thick ovarian stroma, this is having such high amount of androgens locally. So high local androgens. These high local androgens are detrimental for follicular growth, folliculogenesis. This follicular growth does not happen because of this high local androgens. So the surgical treatment of PCOS has to be done sometimes. And surgical treatment of PCOS is that we do a laparoscopy, and with that we enter the ovarian stroma. And with this laparoscopy, when we put a needle into the ovarian stroma, that's how we enter the ovarian stroma, that we get into the abdomen with a laparoscope, put a needle, unipolar cautery, which is in a needle form, we put it into the ovary and we burn the stroma. So when we burn this stroma, we reduce the androgenic stroma. Yes, we make around 4 to 6 holes. So we are burning the stroma. So when we are burning the stroma, around 4 to 6 holes we make. So then what happens? The local androgenic stroma reduces and the local androgen amount reduces, and these follicles have lesser androgenic influence. These androgenic environment had made the follicles hard. So when the androgens reduce, these follicles now respond better to my treatment of ovulation induction. They respond better to my ovulation induction protocols. All right. So 4 to 6 holes are made by unipolar cautery, and that reduces local androgens and better folliculogenesis happens. All right, so that is the surgical treatment of PCOS. What is that? Laparoscopic ovarian drilling. Laparoscopic ovarian drilling. Now, after discussing all about PCOS, now let us see this one question which keeps coming in your exam. It is about a young girl of 22 years who's got two problems. She's got irregular cycles and she's got hirsutism. Or they'll ask you a manifestation of hirsutism, that is acne. 22-year-old girl, irregular cycles and acne. You know that because of your basic dermatology knowledge, that acne is more in women who have got more circulating androgen levels. So, either of these questions can come. The treatment is the same. So, you would say make a formulation which has combined pill which can take care of the irregular cycles and give an anti-androgen drug along with the combined pill which will take care of the anti-androgen action. Here what we're doing, we're giving a very smart combination. We're giving cyproterone acetate with ethinyl estradiol. You know that cyproterone acetate is an anti-androgen. You know ethinyl estradiol will cause the proliferation. But where is the progesterone to cause the secretion? So yes, look, this estrogen is going to cause the proliferation. The cyproterone acetate, which is an anti-androgen, but it is an inherent progestin. It has a progestational action also. So, cyproterone acetate is going to give the secretion on the endometrium, and it is also going to give the anti-androgen action. So, this cyproterone acetate gives us dual benefits. One is the secretion and two, it gives the anti-androgen action. Also, it's an excellent formulation which gives three benefits. It gives the woman regular cycles. It takes care of the hirsutism, and it's a very good contraceptive drug also. Contraceptive action is also very good. So that's why this is a favorite amongst girls. And remember, this is that one combination of estradiol and cyproterone acetate where it is given as a reverse sequential regime. See, the cyproterone acetate is given from the day 5 to day 15, whereas the estradiol is given for a longer time, day 5 to 26th day of the menstrual cycle. So it gives good regular cycles and also a good contraception along with the anti-androgen action which we were discussing. Another method of doing this is that we discuss estrogen and cyproterone acetate combination. Another combination which is going on and fairly common in the market is estrogen plus drospirenone. The newer generation progesterone, drospirenone, it has got progestational action along with the anti. Can be due to postpartum hemorrhage, can be because of antepartum hemorrhage like abruption and placenta previa, vasa previa, and it can also be because of abortions. So when we talk about obstetric hemorrhage, the maternal mortality of our country, maternal mortality rate, which is now around 97 per 1 lakh live births, this is much reduced. You know, when I was an intern 94, 95, I remember it used to be 556. And of course, the policies of the government and the healthcare workers and the doctors, the gynecologists, obstetricians, they've been working very hard, but I'm still not satisfied. It should be less than 10. And that's what should be the ideal target. The Western world is having maternal mortality mostly because of thromboembolisms. Some of these are amniotic fluid embolisms, and those are things which are not under control. But yes, what is manageable and what is under control is postpartum hemorrhage, and that is the most common cause of the obstetric hemorrhage. So most common cause is obstetric hemorrhage, and that postpartum hemorrhage should be controlled so that we lose lesser women in delivery. All right. So most common cause of maternal mortality in a country is obstetric hemorrhage, the three types which I told you, and most common obstetric hemorrhage is postpartum hemorrhage. This causes the maximum maternal mortality in a country. Now, PPH incidence is around 5%. Some books says 5 to 8%. Some books say up to 10% also, mild to moderate types. But yes, the severe PPH is 1% or lesser. Now, what is significant PPH? Now, this is the definition which is mostly asked in the exams now. 1000 ml of blood which is lost after delivery, whether it is normal delivery or cesarean delivery. Yes, there used to be an old definition that 500 ml in normal delivery and 1000 ml in cesarean delivery. That is not asked anywhere anymore. So now there is a further classification that what is mild, moderate and severe. Mild PPH is up to 1000 ml of blood loss, and moderate is 1000 to 2000 ml of blood loss, and severe PPH is more than 2000 ml of blood loss. But what is massive obstetric hemorrhage? That any bleeding which reduces the hemoglobin of a patient by 4 gram%. The hemoglobin reduction. It is not in amount, it is in the hemoglobin loss So if a person, let's say, has a hemoglobin of 12 gram per cent when she's delivering, and after delivery her hemoglobin is 8 or less, then that is called massive obstetric hemorrhage. Now, what is the basic fundamental of postpartum hemorrhage? So when we see the uterus with the placenta after the delivery, the placenta attached to the uterus, and what are we supposed to do? We are supposed to do a control cord traction. So we put a hand on the fundus and hold the umbilical cord and give a gentle tug, gentle pull on the cord and give a counter traction on the fundus. So when we do this is the control cord traction, also known as the Brandt-Andrews technique. So when we do this and deliver the placenta, what happens next? You see the base of the placenta has numerous blood vessels, and those blood vessels will start bleeding and the patient will pour. And you know that 700 to 750 ml blood comes to the uteroplacental circulation. That is the physiology of pregnancy. So around 700 to 800 ml of blood will be lost every minute if you don't control this bleeding properly. So this base of the placenta, which is bleeding profusely, how does this bleeding stop? Naturally in any human. So this wall of the uterus we see, now this wall has got contracted, and see these blood vessels here, these blood vessels have got squeezed. So what happens? If you imagine this pen as the blood vessel and this crisscross muscle fibers, these crisscross muscle fibers will squeeze these blood vessels when this uterus contracts. So contraction of the uterus is paramount for the control of postpartum hemorrhage. All right. So once we understand this, then we'll understand what is happening in our patients with PPH. So some more methods of defining PPH. PPH can be primary PPH, and primary PPH is within the first 24 hours of delivery. And the most common cause of this is the atonic PPH. Uterus is flabby. We'll explain more about that. Now, secondary PPH is after the 24 hours up to 12 weeks of the patient's delivery time. Earlier, they used to say after 24 hours to 6 weeks, but it is now standard that up to 12 weeks, it is secondary PPH. And this is because of the retained bits of placenta. All right. Now, when we talk about the causes of PPH, let's put that into a list. So what are the 4 T's of PPH? Abnormal tone, trauma, thrombin defects, that is coagulation defects, and retained tissues. So abnormal tone or atonic PPH. I told you that the uterus has to contract. If you imagine my arms as the uterus and my palm as the cervix, the uterus has to contract after delivery because there's a placenta here attached, and when the placenta moves, this base of the placenta is bleeding, so uterus should contract. So if the uterus doesn't contract, if the uterus is atonic, okay, poor tone, then that will cause PPH, and this is most common cause of PPH. Overall, any PPH when we're talking, of course, primary PPH is more common than secondary PPH. I already told you the distinction, but overall, the most common cause of PPH is atonic. This much you should not forget. MCI student, this is your bread and butter question. And of course, PG entrance students also know this by heart now. So, most common cause is atonic. Now, it could be atonic because of large size. It can be large size because of twins, or they can be polyhydramnios, or it can be because of a large baby. So, all of these can cause the patient to have PPH. Prolonged labor, uterus is too tired because of the long duration and there is electrolyte imbalance in the uterine muscles. And then there are infections which can cause atonicity. Trauma, injuries to any part of the genital tract. See, any bleeding in the genital tract after delivery is PPH. So, postpartum hemorrhage, any bleeding in the genital tract. So, we do not say that it's only bleeding from the uterus. It can be injury to the vagina, a vulval hematoma which bleeds a lot, or cervical laceration or a uterine laceration. All of that can cause bleeding. So that is the trauma which is causing PPH. Now, coagulation defects like von Willebrand's or the idiopathic thrombocytopenic purpura, for examples, can bleed a lot. Tissue, retained bits of tissue, which causes secondary PPH. This causes secondary PPH, and it is after 24 hours to up to 12 weeks. Now, this retained bits of tissue, what happens? Because of the retained bits, if there is a retained bit here of, let's say, placenta, then that can get infected. That can get infected and cause bleeding after maybe 2 weeks, 3 weeks, 4 weeks. She can vary in her presentation time. So, these are the 4 T's of the cause of PPH. Now, when we talk about the management of postpartum hemorrhage, always remember prevention is better than cure. And when we are talking about prevention, let us just quickly see where we can do the prevention. So let us quickly see the stages of labor. You know, from the onset of pain to the full dilatation cervix is stage 1, and full dilatation of cervix to the delivery of the fetus is stage 2, and delivery of the fetus to the placental delivery is stage 3, and observation for PPH after that delivery for that 1 hour. So that 1 hour of observation is the most important stage for our country. Otherwise, we have only 3 stages of labor. But this is extremely important stage added, because we know that women in our country die because of this. So we observe this woman in the labor room for at least 1 hour before we send her back to the ward. So these are the stages of labor. So if you want to do any intervention, we all know that if a woman delivers and she's having a placenta which is removed, and if she bleeds, we can give her oxytocin, methyl ergometrin, carboprost, all those things we know. But it's better that we take steps in the process of labor to prevent PPH eventually. So let me try and explain what I'm saying here, that from the time of the delivery of the baby and to the placental delivery, we start doing our interventions. So if this is the 3rd stage of labor, we do the active management of 3rd stage of labor. So when we are saying the active management of 3rd stage of labor, what is the 3rd stage? That is the delivery of the placenta. But the preparation of that starts in the end of during the 2nd stage itself. So what is 2nd stage? You know, from the full dilatation of the cervix to the delivery of the fetus. Look here, the head of the baby. If you see, this is the outlet of the vagina here, and the head of the baby is out, but the shoulder is inside. So what is happening here? We want, when the head of the baby comes out, if you see in the picture, when the head of the baby comes out, the shoulder is under the symphysis pubis. We hold the head and give a downward tug so that this anti-shoulder comes out. Why are we waiting for this moment? Because once the broadest part of the baby, what is the broadest part of the baby? Don't look at me. For me, the broadest part is my shoulder. The broadest part of the baby is the biparietal diameter. Once the head comes out, we know the broadest part of the baby has come. But sometimes the shoulders may be also big. Why? Because the mother has diabetes. So if the shoulders get stuck, that means the baby has not yet come out. So why do we wait for the anterior shoulder? So when the head comes out and then the next biggest part, the shoulder comes out, then we know that this delivery is going to complete. Then only we give the oxytocin. Okay. So give oxytocin at the delivery of the anterior shoulder. So once this shoulder, if you see here, this shoulder comes out on the symphysis pubis, we know that this delivery will complete. So then we give the oxytocin. Imagine if somebody gives the oxytocin before the shoulder delivers. So the baby is inside, you've given the oxytocin, and the shoulder gets stuck. There is shoulder dystocia, and the oxytocin starts to act. That will cause squeezing of the uterus and squeezing of the placenta, and the blood will squeeze out of the placenta. Baby will get hypoxia. So that's why we say give oxytocin at the delivery of the anterior shoulder, only after that. Okay, please understand. Then once that is done, delay the cord clamping for at least 60 seconds. Yes, traditionally the Western books, even if you see Williams Obstetrics, even now, if you see the latest 26th edition, it says go ahead and do an early cord clamping. It does not matter. But we say we should do delayed cord clamping, so that once the baby is out, if you see this baby is out, then we hold the baby a little lower than the level of the mother, so that we get some blood from the plasma into the baby, and the baby's hemoglobin improves by at least 1 gram per cent. So that's why pediatricians in our country and the obstetricians have agreed to wait at least 60 seconds and more. Of course, it is contraindicated if the baby is very sick. He's got birth hypoxia, birth asphyxia because of whatever reason. And then if the mother is HIV positive or HBs AG positive, or it's a case of Rh negative pregnancy. So if you wait too long, then fetal-metal hemorrhage will increase. So all those cases, it is contraindicated. Otherwise, do delayed cord clamping, wait at least 60 seconds. Then what is controlled cord traction? Like I told you, you have to give traction onto the placenta, but give a counter traction on the fundus. That is the ideal method, also known as the Brandt and Andrews. That's the method of delivery of the placenta, like I told you. And then we do the very important step that I put one hand in the vagina of the lady, one hand on the abdomen of the woman, and with my both hands, a bimanual grip, I give a gentle massage to the uterus, and that promotes contraction. Now, any labor room in the country, you see the protocols of PPH management, uterine massage is written there.
and we give uterine massage. I know you're going to quote WHO, you're going to quote a lot of your books which says don't give uterine massage. Please remember, uterine massage is very important, and I'm not contradicting WHO, but you understand WHO. Understanding WHO means that WHO is giving recommendations for countries like Ethiopia, Somalia, Afghanistan, where there are hardly any healthcare workers, doctors, nurses in the periphery. So for the lack of these healthcare workers, you cannot keep one dedicated doctor or one dedicated nurse for just one patient to give uterine massage. So all patients who deliver, because there's so many deliveries and there's so many villages, so many places where delivery attendants are required and there's a shortage of them, to give uterine massage to all the patients who deliver is very difficult. So that's why they say it's not a very important step. But yes, in our country, we have enough doctors and this is a paramount step. Please don't forget uterine massage. So let me explain this to you with only one reference. I'm not giving you references of all the Indian books and all the Indian colleges. I'm just giving you one important question which came in the INICET exam. Since this is rapid revision, I'll just tell you one reference. This controversy exists, I know that. So if you see the question which came in INICET, which is AIIMS, JIPMER and Vijay Chandigarh exam, and this was November 22. Whenever INICET exam comes, one controversial question gets settled, and this is one of them. So all the questions which I was discussing on the Prep Ladder Forum, they're supposed to be in a black slide, but I deliberately kept one slide white because I wanted to see this. This is that question which came in November 22, and in this question, they asked, what is the sequence of doing active management of third stage of labor? Put them in the correct order. And if you see this question now blown up, you see the choices. Check for the second baby, give oxytocin, control contraction, and uterine massage. And they've asked you to put this in the right order. Please understand, I'm not even discussing the question here. Just understand, if uterine massage is done, then only such important hospitals which conduct the INICET exam, they have asked me this question. All right. Now, let us see the drugs proper, which are used for the management of PPH. We know the drug of choice is oxytocin, which is given at the delivery of the anti-shoulder, 5 to 10 units IV or IM to prevent PPH. And the drug of choice for treatment also is again oxytocin. But when you give 10 to 20 units for the treatment of PPH, then it is given in an IV drip. Remember, too much of oxytocin can cause patient to have water intoxication. Side effect is water intoxication, because in high dose, it acts like ADH. High dose acts like ADH, antidiuretic hormone, which causes water intoxication, water retention, and that can cause the patient to go into pulmonary edema and even death. So be careful about too much of use of oxytocin. Now, carbetocin is the synthetic analog of oxytocin, and this has got more sustained action. Now, what is the meaning of more sustained action? That is, there will be more sustained uterine contraction because of use of carbetocin. 100 micrograms IV in 1 ml over 1 minute. This was a question which came 3 years back in your NEET exam. Now, carbetocin is slowly being replaced in quite a few hospitals. Maybe in a few years, I'll be teaching you that's the drug of choice, but so far the drug of choice is oxytocin. Now, methyl ergometrin, 0.2 milligrams you can give as slow IV, and it acts in 90 seconds. It's a wonderful drug. My personal favorite. But yes, of course, the drug of choice is oxytocin. The problem why it is not the drug of choice, because it cannot be given. It is contraindicated in patients who've got heart diseases and patients who have Rh negative pregnancy, because more blood, if there is sudden uterine contraction, there will be more fetal hemorrhage. And then patients, when there is hypertension, sudden uterine contraction will increase the blood pressure, and then it is contraindicated before second twin is delivered. So in all these conditions, we don't give methyl ergometrin. Remember, up to 5 injections. 5 injections can be given in 24 hours. So that the total dose, 5 injections, means 1 milligram in 24 hours can be given. Now, that is methyl ergometrin. Misoprostol is PGE1, and that is given 800 to 1000 micrograms rectally. It is a very good action, acts wonderfully to contract the uterus. It bypasses the first pass metabolism since it's given rectally, or we can also give orally at the cost of some systemic side effects, but that is 200 micrograms. Some people give as much as 400 micrograms orally, but it has got a lot of gastritis and cramping and this diarrhea as a complication. So, of course, the favorite method of giving misoprostol is rectally, 800 to 1000 micrograms. But remember, the go-to drug, if none of these drugs are working, then the go-to drug to contract the uterus and stop the PPH is the carboprost. That is PGF2 alpha. PGF2 alpha, and this is given IM only. IV carboprost can cause sudden hypertension. It is given IM only. Wherever carboprost is given in medicine, not just in gynae, it is given IM only. And this is, we can give up to 8 injections in 24 hours. That means 2 milligrams total dose. These are all important questions. Now, when we talk about the management of PPH, newer drugs are being discussed, and melatonin is that one new drug. You know, it is important for the sleep-awake cycle of a human. Then this is known to be an anxiolytic and also a uterotonic drug. So, prophylaxis, yes, anxiolysis and uterotonic action. Along with the oxytocin receptors, it has got some uterotonic action. That's why it is being purported as the next drug. 6 milligrams, it is given as a dose. Now, maybe this will have some use later on. So far, it is still in research. Vasopressin, we all know that it is given for variceal bleeding. We give vasopressin during myomectomies to cause contraction of the uterine blood vessels to reduce the bleeding while we making incisions on the myomas. So yes, that is also one method of reducing PPH. We can use vasopressin soaked mops onto the uterine bed when there is too much of bleeding, and that causes local vasospasm. So you can give it into the muscle of the uterus to cause vasospasm of the blood vessels which are feeding the bleeding, and you can also give it in a pack in the uterine cavity which will cause local vasospasm. Now, dofetilide is a class 3 antiarrhythmic drug, and antiarrhythmia drugs you know better than me, obviously. But then these drugs will act to cause uterine contraction by suppressing the HERG channels. So these are the 3 new drugs which are being discussed these days. So continuing our treatment of PPH, there are some other drugs which act by reducing the bleeding by promoting coagulation at the bed of the placenta. So we can give activated factor 7, 90 milligrams per kg body weight over 3 to 5 minutes in an infusion. We can give FFP and cryoprecipitate. Of course, cryoprecipitate is 10 times more effective than FFP for giving good fibrinogen, not 100, 10 times. Then we can also give tranexamic acid. Tranexamic acid is 1 gram IV. You know, it is an antifibrinolytic, so it will promote fibrin plug to persist at the site of bleeding and stop the bleeding eventually. Then, when PPH is not managed by the drugs and the procoagulants, then we can think in terms of using the surgical method. And the surgical methods, we can do a uterine artery embolization. We can embolize this artery here and the artery here. So that will reduce the vascularity of the uterus. Don't worry, there will not be any gangrene because there is a good anastomosis around the uterus. The ovarian arteries can feed the uterus very well. But yes, one of the desperate measures is to do uterine artery embolization using polyvinyl alcohol, PVA, polyvinyl alcohol particles. Then we can also do a balloon tamponade, the Bakri balloon. We can fill the balloon in the uterus, which causes a tamponade effect onto the uterine walls which are bleeding. So it is distended by 500 ml of normal saline, warm saline of course, because you should not give a cold shock to the patient by giving cold water, warm saline. Then we can also do some compression sutures. The uterus, the wall is very flabby. You want the uterus wall to contract and become like this, but none of your methods are working. All your drugs, all your massaging and all your procoagulants, nothing is working. So then we can physically hold down the uterus and give a suture to do that. So that can be done by a B-Lynch hemostatic suture. So with the B-Lynch suture, you can squeeze the uterus. See, you take it from one end of the uterus and go through the uterine wall. Nobody's asking you how you go through this. So you go through that and then you tighten this absorbable suture. When you tighten this absorbable suture, the uterus will be physically contracted. So that has saved many a hysterectomies. in management of BPH. So that is a B-Lynch hemostatic suture. Then, if nothing works, then we start going to the uterine devascularization. What's the meaning of uterine devascularization? First, we ligate the uterine artery, then we ligate the ovarian artery, and if that doesn't work, we go and ligate the internal iliac artery. Now, when we talk about the internal iliac artery, we must see that this is the common iliac, and then this divides into the interiliac and the extrailiac, and under the inguinal canal, further down, it continues as the femoral artery. Now, when we're talking about the internal iliac artery, we know that there are two divisions. There is this antedivision here and there is this postdivision here. So, when we're ligating this internal iliac artery, where are we ligating it? Are we ligating it here? Are we ligating here? Or we ligate it here? So, yes, where do we ligate the internal iliac artery? That is a very important aspect. Remember, we are ligating only the anterior division. Why? Because uterine artery is a branch of the anterior division. So, there is bleeding in the uterine bed. So, we want to take care of the bleeding and the blood flow of the uterine artery, not of all the other vessels of the posterior division. So, yes, please understand where the ligature is put and what is the importance of it. See, what is the simple question which comes in the exam? What are the branches of the anterior division? What are the branches of the posterior division? So, you have to mark them up. We can't help it. One help I can give you that the posterior division are only 3 branches. So, we have a mnemonic which is short gills. So, superior gluteal, iliolumbar, lateral sacral. These are the 3 dividing arteries of the posterior division. So, by exclusion, you can answer that question. INICET asks you very simple questions, and they asked you in this exam also, which came in 2023, that which artery is the posterior division branch. So, that is the easy one. But what is asked in NEET and even MCA exam is the principle of internal iliac artery ligation. So, number one, where are we ligating it? We are ligating it in the anterior division only, not the posterior division. Why? Because we have to take care of the uterine artery blood flow. Then, what is next? When we are talking about the principle, we are not totally obliterating the flow of the anterior division. We are putting a snug ligature. We are putting a comfortable ligature to reduce the flow, but not to stop the flow. Please remember that. Reducing the flow, in fact, reducing the pulse pressure. You know, the normal pulse pressure of an artery is around 100. So, from 100, we bring it down to 30 to 40. So, that of a vein. So, 40 millimeters of mercury now, or 30 millimeters of mercury now. So, the flow in this anterior division branches is now sluggish. Now, if there is sluggish flow in the uterine artery, the bed of the uterus is bleeding. So, now there is sluggish but not forceful flow. There is sluggish flow in the uterine bed. So, the small thrombi, small clots, the fibrin plugs which are forming at the end of these bleeding vessels, they will not get dislodged. When there is high pressure, these small clots get dislodged, and to prevent that dislodgement, we reduce the flow. So, reducing the flow but not stopping the flow is the principle of internal iliac artery ligation. Alright, and we ligate only the anterior division. Remember this, internal iliac artery branches, and the principle is a very important question. And if nothing works, the last thing we have to do is a obstetric hysterectomy. Yes, we have to do it many times, sometimes to save the life of the patient. It is a valid option, but this should be obviously your last option. Alright. Let us now read about antepartum hemorrhage. So, when we say antepartum hemorrhage, it is the bleeding in the genital tract before delivery. But we must remember after 28 to 37 weeks. Because when women go into labor, they will bleed a little bit. So, after 37 weeks at term, if they are bleeding, that's alright. But if they are bleeding before 37 weeks and they have not gone into labor, then we say that this is antepartum hemorrhage. So, after 28 weeks, because that is what is viability. Before 28 weeks, if somebody bleeds, bleeding before 28 weeks, all of us know that is an abortion. So, after viability, if a patient is bleeding, that is antepartum hemorrhage. Now, the important causes of antepartum hemorrhage are like abruptio placentae, placenta previa, and also vasa previa. Vasa previa we already discussed along with the abnormal placentas. There are many other causes of bleeding in the genital tract, like some injuries, some vaginitis, some vulvitis, but those are not the ones which generally bother us in the exams, because these are the classical antepartum hemorrhage causes which we have to read. Now, when we talk about the placenta previa first. Placenta previa means at the door. If something is at the door, we call it previa in Latin. So when the placenta is at the door, that is, the door is the internal os. So when the placenta is at the os, obviously if a fetus is above it, that fetus cannot come out without making the placenta tear away and cause torrential blood loss. So placenta previa is two types. One, either it is partly or completely covering the os. Two, it is in the lower segment but 2 centimeters away from the os, which is known as low-lying placenta. Once again, placenta previa is two types: covering the internal os partly or totally. This is one type. Partly or totally covering is one type. The second type is the low-lying placenta. Next screen I'll show you. So when we say completely covering, like that, partly covering, like this. Now, what is low-lying placenta? Placenta is in the lower segment, but it is not covering the os. It is within 2 centimeters. Within 2 centimeters of the internal os. Now that is low-lying placenta. So two types of placenta. Now the old classification of type 1, type 2A and 2B, type 3, type 4, all that is outdated. Now we only talk about partly or totally covering, that's one type, and the low-lying placenta. Now what happens that a case of placenta previa makes us so worried? We are worried about placenta previa bleeding. And that can be a lot of bleeding and the patient can get extremely serious, and it's a standard obstetrical emergency. But remember one thing, when we see placentas in the early pregnancy, many a times they are covering the os. Let's say a woman comes to me in the early time of her pregnancy, let's say around 12 weeks or 14 weeks, placenta might be covering the os or partly covering the os. But as the uterus becomes bigger in size and the cervix, I have told you that if the cervix gets effaced, then a placenta which was probably low-lying earlier becomes a upper segment placenta. So please remember, not all placenta previa stay placenta previa till term, because if you see this diagram, you can make out that the placenta is partly covering the os. But I have drawn this in isthmus. I've drawn this isthmus. All of you know from the anatomy class, isthmus is the area between the anatomical internal os and the histological internal os. So that isthmus, which is 0.5 centimeters, late in pregnancy at term, the lower segment is formed. So that lower segment is formed by this isthmus. So now this becomes 7 centimeters. So when you see the cervix gets effaced and the lower segment is formed, you see the placenta has moved up. Now placenta has not physically migrated, it appears to have migrated. So placental migration, it is called as a misnomer, because placenta is not physically moving up. It is not physically moving up. It is just that the lower segment is formed. So placenta has now gone in the upper segment, and this patient may also have a normal delivery now. So yes, I'm not saying, don't get confused, I'm not saying that placenta previas will deliver normally. Some placenta previas which become totally upper segment may deliver normally. I'm not saying do a normal delivery for placenta previa. I'm just saying some of these may go up so well that you may deliver them normally. So what is initially a placenta previa may not stay as a placenta previa at term. That's what I'm trying to convey. Now, what we are going to talk now is placenta previas diagnosed as placenta previas, persisting as placenta previas at term. That is what we are discussing. So let's move on and see that placenta previas is 1 in 300 to 400 pregnancies. It is associated with multiparities, and grand multipara women more chances, and twin gestations because there are two placentas, or a big large placenta if it is a single placenta. Then previous cesarean section, more chances. Placenta accreta association is present, and previous surgeries like hysterectomies and myomectomies. So those are the causes of placenta previa. Diagnosis is generally easily done by a 3D ultrasound along with a Doppler assistance. So ultrasound is the mode of diagnosis most of the time. Troubleshooting can be done with a MRI. Now, symptoms of placenta previa. Most placenta previas don't bleed, but if at all they bleed, please remember, if at all placenta previas bleed, it is painless bleeding, PV. And the thing which comes in your exams is, first thing I'm telling you, do not do a pelvic examination when you see a woman who is pregnant and is bleeding, especially a woman around term and has come with painless bleeding per vagina. Do not do a per vaginal examination, because already the placenta has dislodged and it's bleeding, and you put your finger, you're going to make this bleeding torrential now. So don't do a per vaginal examination. Treatment for plasma previa, bleeding at term. Now, this is situation 1. Plasma previa, bleeding at term. That is after 37 weeks, if there is a plasma previa bleeding. Obviously, give a rest and do a resuscitation. Resuscitation in all obstetric cases is the same resuscitation which you give in ruptured ectopic or in a ruptured uterus or a plasma previa bleeding, or maybe a, just like in orthopedics or in medicine. So treatment of shock, you should know, always 2 large bore IV cannula, preferably a 16 gauge, arrange for blood, give IV fluids meanwhile, and call for help and treat the cause which is causing the bleeding in the first place. So resuscitation steps we're not discussing now. Rest and resuscitation. And the best management for plasma previa, which is bleeding at term, is to do a cesarean section. Please don't do anything else. This is those simple questions which come in your NEET exam and INISCT exams many times, that plasma previa, bleeding at term. Apart from resuscitation, what is your obstetric management? Obstetric management of a bleeding plasma previa, nothing else but cesarean section. Definitely don't do a PV in the OPD. Now, if a plasma previa is at term, quite a few times NEET exams will ask you this question. A plasma previa presents to you at term. Mind you, when they say plasma previa at term, if they are not mentioning that the patient is bleeding, then don't assume that she is bleeding. That's a mistake which a lot of us do in the exams. When they say plasma previa at term, don't assume she's bleeding. They have said plasma previa at term, what's the management? I'm just writing for your benefit that till they write it is bleeding, don't assume it is bleeding. So yes, here for your benefit, I'm writing plasma previa at term, not bleeding. What is the management? So if it is totally covering the os, even if it is not bleeding, but it is totally covering the os, then you'll have to go ahead and do a cesarean section. Then, if it is partly covering the os, like in this example, and then the lower segment forms, suppose at around 30 weeks you saw the placenta was partly covering. Then as the lower segment is formed, maybe the placenta will move away. So you can understand that this baby can come through this very easily and she can have a normal delivery. So this patient, when there is a partly covering placenta and the patient is not bleeding, take her to the OT, which is known as a double setup examination. What is a double setup? That in my hospital, I have an operation theatre and I have a labor room also. So I take her to the OT, give her anesthesia, under anesthesia in the OT with a surgeon scrubbed up and ready for a cesarean if it is required in emergency. And I'll give a mild anesthesia, and in the OT, I'll do a per-vaginal examination. Mind you, patient is plasma previa and bleeding, don't do PV. When I can do a PV? When it is not bleeding and I'm trying to see if the placenta has moved away. Sometimes the ultrasound is not the best option to find that out. So I take her to the OT, and in the OT, I give anesthesia and I do a per-vaginal examination, and I do not feel the placenta. I move my finger, I put my finger in the os and I move my finger. My finger is roughly 5 centimeters. So this way 5, this way 5. So in a diameter of 10 centimeters, if I don't feel the placenta, that means a bipolar diameter of 10 centimeters can go through that os easily, because in a diameter of 10 centimeters, I'm not feeling the placenta. So this patient, in a double setup examination, when the placenta has moved away, I can do a normal delivery. Or another situation, that when I do a PV like this and I move my finger both ways and I feel the placenta, or maybe I injure the placenta, she starts bleeding. She's in the OT. Even if she starts bleeding, a surgeon is ready to do a cesarean section immediately. So yes, if it is still covering, then you know that this baby cannot deliver. It cannot deliver. So you'll have to do a cesarean section if it is still covering. So you can do this examination in the OT, which is known as a double setup examination. But that is for a patient which is not bleeding. Once again, placenta previa bleeding at term, go ahead and do a cesarean section. Now let's see another situation which generally comes in your NEET exam or the INISCT exam. PG entrance, they ask this: placenta previa bleeding, but before 34 weeks of gestation. That is, the issue of lung is raised here, because before 34 weeks, the fetal lung is not mature. Now the patient is having bleeding per vaginum. It's a known case of placenta previa, probably by an ultrasound you know. So if this situation is asked in the exam, what do you do? Obviously, you'll always do a resuscitation of this patient, give a rest. And in the hospital, you make sure that you're giving steroids to the mother so that the lungs of the baby get mature. So we can also give some sedation to reduce her anxiety and probably control her blood pressure. So what we do, we give her this management. But this is not obstetrics. What is the obstetric management of this patient who's got placental previa bleeding at, let's say, 32 weeks? When you're doing conservative management of placental previa, this way, this is known as the McAfee-Johnson regime. And this stops bleeding in 90% of patients. So McAfee-Johnson regime, just giving this, stops the bleeding in 90%, continue the pregnancy probably till term without any problems. So if bleeding continues like in 10% of cases, then do a cesarean section. So that is what is the management before 34 weeks, frequent MCQ. Please remember, no tocolysis just because she's preterm. Look, I'm not saying she's in preterm labor. I'm saying she's preterm and she's bleeding. She's not in labor. So unnecessarily do not give tocolysis in a bleeding placenta previa. The bleeding will only increase. All right. So no tocolysis in a bleeding placenta previa. Now, this conservative management, which is successful in 90% of patients, known as McAfee-Johnson, is contraindicated if the fetus is dead or fetus has anomalies, or if the fetus is alive but the mother is sick. Mother is sick because she's bleeding too much and she's about to die, which basically means that bleeding continues. So in these conditions, this conservative management is contraindicated. All right. So let's move and see abruptio placentae. When we talk about abruption, it basically means abrupt separation of the placenta. What is so abrupt about it? Obviously, when the fetus delivers, then the placenta separates and delivers. Now, the fetus is inside the uterus and the placenta has moved, has separated a little or sometimes even totally from its attachment. So that is very abrupt, right? So that's my method of making you understand. Probably not the logic behind giving that name. So abruption is a placenta separating before the fetus is delivered. It is also called accidental hemorrhage. Accidental hemorrhage. All right. Now, incidence is 1 in 200 pregnancies. It's the most common antepartum hemorrhage cause. Placenta previa was 300 to 400. Now, this is associated classically with hypertension pregnancy and in smokers, but most commonly hypertension pregnancy, also associated with elderly gravidas, multigravidas, patients who have premature rupture of membranes, because when the liquor starts to come out, it gives a negative pressure in the uterus and that can pull the placenta and cause a separation. And associated with infections like chorioamnionitis, previous abruption has a chance of recurrence, thrombophilias and twin gestations. All of these are associated with abruptio placentae. Now, when there is abruptio placentae, you can see this diagram. This placenta may have a retroplacental collection of a blood clot and it may not come out. You may diagnose this only on a ultrasonography. So this is where it is known as a concealed bleed. Or it may come out along with the membranes here and be revealed. And sometimes it bleeds into the uterine muscle. That's known as a bruised uterus or a covular uterus. Now you can very well understand if there's a bruise in the uterine muscle, when there is bleeding in the uterine muscle will get stretched and cause a lot of pain. That's why there is painful bleeding. Painful bleeding in abruption. Yes, we've been knowing this always, that abruptio placenta has painful bleeding. Why is the bleeding painful? It is painful because there is bleeding in the uterine muscle. It is also tender. When you touch, it is also tender, the uterus. That's because of the covular uterus or a bruised uterus. All right. So this is the presentations of abruption. Now, this pain due to the covular uterus, you can imagine. Look here. I'm showing you a picture of one of my patients here. See the uterus, it's got a bruise in the anterior wall and also going superiorly. So this dark red and blackish area, that's the bruise. Now this uterus, you imagine, you think it's going to contract very effectively and push the baby out very fast. So the labor might be protracted in abruption. And even after delivery, since the uterus is bruised, the uterus may not contract properly. So the labor might be delayed, and also the patient may have PPH after delivery. So abruption is a case which has bleeding before the delivery and also after delivery because of the PPH. So there might be a postpartum hemorrhage, and progress in labor may be protracted, slow progress of labor because of this bruising. And this bruised uterus may sometimes bleed after delivery, causing PPH. So this patient which I'm showing, we ended up putting a B-Lynch suture. So just before this chapter, I was teaching you postpartum hemorrhage, and there I was telling you that B-Lynch suture is this absorbable suture which we apply. We open the abdomen and apply the suture on the uterus, and physically we tighten that thread and physically compress the uterus with that suture, which is known as a B-Lynch. So this is what is a B-Lynch. We had to apply for a abruption patient who had a postpartum hemorrhage also. Now, when we are talking about the classification of abruption, classical classification, which is not mentioned in many books now, is the Sher and Page classification. It's got 3 grades of classification, abruption, and the worst, of course, is the type 3, and type 3 is associated with fetal demise and also with possible DIC. So problem is the abruption has this retroplasmic clot which can activate the extrinsic coagulation pathway. So you can go through this classification. I've not seen this classification coming much, so I've just mentioned this. Go through this and try to at least remember that the type 0 and the type 1 are the simple types, and they are not very troublesome, and type 3 is a worst type. You can see at least this much you should know. Now, when we talk about abruption at term, what is the management? So treatment of abruption, like all bleedings, I told you, do a resuscitation. Since it is associated mostly with hypertension, control the blood pressure. Now, what is the obstetric management? So anytime when you're talking about obstetrics, you should know, okay, this drug you will give, stabilization you will manage with this OPD procedure, but always think we are going to ask you the obstetric management in the exams. So what is the obstetric management of abruption at term? You will do a rupture of membranes here. You'll put an instrument known as the Cocker's forceps. We use the Cocker's forceps. It is there in the image-based discussions which we've been doing. So go inside and hold the membranes and pull them. So that will cause rupture of the bag of membranes, and that will release the liquor. So when the liquor is released and that irritation around the cervix, that is going to increase the prostaglandins, which causes induction of labor. It doesn't happen in a snap of your fingers, please. It is going to take considerable time. It's going to take 6 hours to 12 hours sometimes. So you do an artificial rupture of membranes and you will release some prostaglandins locally, which will help in induction of labor. Second benefit of ARM is that it will reduce the bleeding, because the uterine volume, see, when the liquor is coming out, the uterine volume will reduce. So this muscle, the contracting muscle, will press this bleeding placenta against the body of the baby. So there is this blood clot here, which is the abruption, and this blood clot, when the uterus is now reducing in volume, this uterine muscle will compress this blood clot and reduce the bleeding significantly. So that is the management. Do resuscitation and do delivery. So ARM plus oxytocin and do normal delivery. Now, I did not even mention cesarean section, so that's unfair. I'm not saying we don't do cesarean section. Abruption at term is not a direct indication for cesarean section. Cesarean section, if there is fetal distress, if there is fetal distress, when there is a fetal heart rate less than 100, or scalp blood pH. If the patient is in labor and having a abruption, scalp blood pH, if it is less than 7.2, that is acidosis. So if you see these things, then it is a distress. Go ahead and do a cesarean section. Otherwise, we will do a normal delivery of abruptio placentae at term. So remember, giving artificial rupture of membrane and then adding oxytocin is going to help us deliver this patient normally, and that's what we all do. If there is a fetal compromise in any type, go ahead and do a cesarean section. But remember, abruption by itself is not an indication for cesarean. It's the associated fetal distress. Now, The question which keeps coming in your exam is abruption before 34 weeks, where lung is the issue again. So you'll give resuscitation, you'll give rest, and you'll give steroids for the lung maturity. But remember, no conservation. Now, this is what is different. Remember, I told you when plasma previa is bleeding before 34 weeks, rest and sedation, McAfee-Johnson stops the bleeding in 90% of cases. Here, give rest and sedation, but do not conserve, do not, continue the pregnancy. Conservative management is a problem in abruptio placentae. Why? Because there is this retroplacental clot, and I told you this clot is mostly responsible for releasing the tissue thromboplastin into the circulation, which triggers the extrinsic coagulation cascade, and that is going to cause consumptive coagulopathy, and that is going to cause the patient to go into DIC, which can also cause the patient to die. So that's why we say do not do a conservation of a abruption. You will give rest, you will give steroid and sedation, but you will do ARM, and you will add oxytocin, and you will do a delivery. Please remember this for abruptio placentae. Termination of pregnancy is the best management and no conservation. So plasma previa we can conserve if she comes before 34 weeks and it is 90% successful. But abruptio placentae you cannot conserve. The only time when you think of conservation of pregnancy is before 34 weeks. But in abruption, we can't do that. We'll give steroids when we hope that the baby survives and the baby makes it. But to save the mother, delivery is the best option. Otherwise, she can go into DIC. All right. Now, let us see about a very important chapter in obstetrics, and that is the fetal surveillance. When we say fetal surveillance, remember, you may know the drug of choice for, let's say, hypertension pregnancy, it is labetalol. You know that the management of diabetes can be done with a drug called insulin. But knowing that is not obstetrics. That alone is not obstetrics, at least. Because if you diagnose a patient with hypertension at 28 weeks, you are giving labetalol, you're giving prazosin and maybe also hydralazine. You're controlling the blood pressure. Now, what is obstetrics part of the management? You want to continue the pregnancy as long as possible, maybe go till term, and then do a normal vaginal delivery, all the while making sure the baby is healthy and the mother is healthy. So how will you make sure that the baby stays healthy and alive? You cannot just say that take this antihypertensive drug and go home. You will have to examine the patient more frequently. Sometimes you may have to admit the patient and do more close surveillance of the fetus and make sure that the pregnancy continues without any fetal harm. So that is what is the most important part of obstetrics. Surveillance makes me an obstetrician. All right, please understand that. Just knowing the drug of choice is knowing pharmacology, but knowing how to manage a pregnancy with the knowledge of the drugs is what is obstetrics. And fetal surveillance is a very important part of obstetrics. So when we say fetal surveillance, it can be antepartum or intrapartum. Let us see antepartum, that is during pregnancy, how we can be vigilant about the baby's health. So we will be surveillant for all pregnancies. Remember, we tell that at least 4 visits in the antenatal time in India we should do, or 8 visits if it is the WHO recommendation. So we are doing that for surveillance and taking care of the examination of patient and the blood tests and giving nutrition and multivitamin supplementation, and of course ruling out other disorders and taking care of the baby. Immunization also. So that is surveillance. But in some patients like IUGR babies, PIH, antiphospholipid antibody syndrome, gestation diabetes, twins, heart diseases, epilepsy, systemic lupus erythematosus, there's so many conditions where the baby is more at risk for having an intrauterine death. So that's why we will do more surveillance for high-risk pregnancies. Yes, we are surveillant for all pregnancies, but more for those high-risk pregnancies. So when we say surveillance, antepartum surveillance, one of the easiest things we can do is the fetal heart rate assessment by stethoscope and by a fetoscope, the Pinard fetoscope. I'll be showing you a picture of the Pinard fetoscope later in the chapter. Then we can tell the mother to feel the fetal movements and tell us how many times she's feeling them. So if she's getting even around 10 movements in a day, 10 movements when she's up, we preferably tell the mother to count the movements after she's had breakfast, lunch and dinner. And if she's getting 10 movements in the waking hours, that is per day, if there is 10 movements, that is a good daily fetal movement count, or we also call it the Cardiff count of 10. Now, one of the important tests of antepartum surveillance is the non-stress test. Non-stress means no stress on the baby, no stress on the mother. We put a probe on the mother's abdomen, which is a Doppler probe, which sees the fetal heart rate. Now, the fetal heart rate is charted on a graph, and we are waiting for the baby to move. Moment the baby moves, there will be increase in the heart rate of the baby. Like you and me also, when we run, we increase our heartbeats, we increase our pulse rate. So there is a probe on the mother's tummy, it is catching the fetal heart rate, and when the baby moves, there should be increase in the heart rate. So that is, let's say, the normal heart rate is 120 to 160, and fetal heart rate of my patient is 130, and the heart rate is going fine, but there is a fetal movement here. Then the heart rate increases from its baseline, comes down. Then there's another movement here with the fetal movement, there's another increase, and then it comes down again. So with the fetal movement, the heart rate should increase how much? At least more than 15 beats. See, from 130 is gone to 150, we can make out, and it should last for more than 15 seconds. So more than 15 beats should be the rise, acceleration, and more than 15 seconds it should last, and this should happen at least twice, more than equal to 2 times in a 20-minute study. So if there are 2 or more accelerations like this in a 20-minute study, then we say it's a reactive non-stress test. Mind you, they will not ask you to write the definition, but they'll give you 4 definitions and you have to mark the correct one. So that is a reactive non-stress test, and no stress on the mother, no stress on the baby. Like that we say. It is done weekly for all the pregnancies after 32 weeks. You can theoretically do after 28 weeks, but mostly after 32 weeks, we do it on a weekly basis, and we do it twice a week for the high-risk pregnancies and daily for the diabetic pregnancies which are having uncontrolled sugars. So that is the frequency of the non-stress test. So this is how we do it. Look, be very careful. You will get a picture, and in the picture, if a pregnant mother has 1 probe, then it is obviously the non-stress test. Okay. If there are 2 probes, then it is not non-stress test. If there are 2 probes, then it is another test which comes in the intrapartum surveillance. So I'm not confusing you now. We're talking about antepartum surveillance. So this is how it looks when you do a NST. So that is the test which is being done, and you can see that this is the graph which is coming out of that, and that sound is of the fetal heartbeat. You see, with the movements, the heartbeat is increasing, and this should happen at least twice in a 20-minute observation time. All right. Now this is the graph which I was showing you. With the movement, there is increase in the heartbeat. All right. Now there's another test which is known as the biophysical profile. Now biophysical profile is one of the cornerstones of our antenatal surveillance, intrapartum surveillance, and it's an extremely important test. Remember, when we're doing the biophysical profile is assessment of many factors apart from just the NST. So NST, which we did in the previous screen, along with an ultrasound. In the ultrasound, we see the movements of the baby, and we see the fetal tone, how many times the baby, at least once the baby should flex and extend. So tone, and then the breathing movements. Now, fetal breathing doesn't really mean that the baby is, we are checking the breathing of the baby, because baby is not breathing from his nose and the mouth. Baby is getting the oxygenation from the umbilical cord. But the baby is swallowing the amniotic fluid, and every time he swallows amniotic fluid, his chest expands. So that looks like a breathing movement. So fetal tone, fetal breathing, and the amniotic fluid index, each one of these parameters are given 2 points each, and a perfect biophysical profile is 10 by 10. And this gives us an indication, continue the pregnancy. NST is fine, continue. Sometimes we do the biophysical profile. If that is fine, continue the pregnancy. If it is 8 by 10, then it is acceptable. We say, okay, fine, it's okay, we'll continue the pregnancy, provided NST and AFI are okay. In these, if it is 8 by 10 and NST and AFI is okay, we say it's all right, continue the pregnancy. But anything less than equal to 6 by 10, we are already planning a delivery. Anything less than that, okay? More or less these parameters, the way I've told you, they stand correct. Now, what is the modified biophysical profile? MCI students, this was a question in the Jan 23 exam. Modified biophysical profile is the amniotic fluid index and the NST only, and this itself is good enough to give us a assurance that we can continue the pregnancy. Now, what is the amniotic fluid index? Now, this amniotic fluid index, why we seeing? Because this amniotic fluid index is sometimes asked in the exams, and what we should know to calculate it. So, when we do the ultrasound, on the ultrasound, we'll measure depths of 4 vertical pockets, and suppose this depth is 5 centimeters, this is 3 centimeters, here again it is 3 centimeters, and this is 4 centimeters, for example. Then the arithmetic sum, 5 plus 4, 9, 9 plus 6, 15. 15 centimeters is the AFI in this example. So AFI here is 15 centimeters, amniotic fluid index. It is the arithmetic sum of the 4 pockets. Now, the Leica, when is it maximum? Hot shot MCQ, all of you want to know this answer. So yes, when pregnancy is at terms at 40 weeks, it is in fact only 600 ml. But around 32 weeks to 34 weeks, it is 1000 milliliters. And at 36 weeks, it is 800 ml. So peak around 32 to 34 weeks. 32 was the choice which came in your exam in December 21, and they want you to write 32 weeks. Any one of these will come in your exams as a choice. So it's maximum around 32 to 34 weeks. Mind you, it reduces after this. Don't say 38 or 40 is the maximum. Please, after 34 weeks, starts reducing. So at 36 weeks, it is lesser than 32, 34 weeks. What is the significance of this 36 weeks? If the fetus is at 36 weeks and the fetus is by breech. Suppose I'll show you this sanitizer bottle here. Suppose this is the head of the baby and this is the buttocks. Then at 36 weeks, it's a breech. I can turn the baby and now it can become cephalic. We can do an external cephalic version and the baby will stay turned. Why? Because the baby is now bigger and the head of the baby is harder. So when you turn the baby, when you do an external cephalic version, the baby will stay cephalic. Since the size is big, he cannot turn back and the Leica is reducing. So turning back to breech will be difficult. So that's why external cephalic version is done at 36 weeks or 37 weeks, ECV. So that is the principle of external cephalic version. Why can we do it? Because the Leica is reducing and the baby is now bigger. So I'll write that also. Leica is reducing, baby is bigger, and very importantly, uterus is relaxed. You can do it only in a relaxed uterus. So that's why you cannot do it 38, 39 weeks because then the uterus starts getting irritable. So that is the Leica play and you should understand the amount. Now let us see some more details about the amniotic fluid, namely the definitions of oligoamnios and polyamnios. Now when we say normal Leica index, so amniotic fluid index is 10 to 15 centimeters like we saw in the previous slide, and amount of Leica of 1000 ml is normal. In oligohydramnios, the index is less than 5 centimeters and the total amount is less than 500 ml to be called oligohydramnios. And in polyhydramnios, the index, if it is more than 25 centimeters and the amount more than 2000. Be very careful. 25 centimeters is not equal to 2500 ml. It is 25 centimeters and 2000 ml. Be careful on this part. Now, when we say a single pocket, any single pocket less than 2 centimeters in out of the 4 pockets which you measure, any one pocket less than 2 centimeters is known as oligoamnios, and any one pocket more than 8 centimeters is polyhydramnios. And polyhydramnios causes are so many like twins, diabetes mellitus, RH isomerization, which has hiatus fetalis, and there'll be also polyhydramnios. There'll be GI defects like gastroschisis and omphalocele, and swallowing defects like esophageal atresia, duodenal atresia, CNS defects like anencephaly. Oligoamnios, the causes are renal agenesis, since renal output, the renal, urine is the major contributor to the net amount of amniotic fluid. So renal agenesis causes oligoamnios. Hypertension in the mother, premature rupture of membranes, all of them cause oligoamnios. One of the interesting causes is amnion nodosum. When there are those There are nodular squamous deposits on the amniotic membranes, and that's what reduces the transmembrane fluid transport. So there could be oligoamnios. Right. So another test is the vibroacoustic stimulation test. We're still talking about the antepartum surveillance. There's a probe which is kept on the mother's abdomen and which causes a vibration on the mother's abdomen, and that startles the baby, and that startling causes the baby to move, and that movement increases the heart rate of the baby. So sometimes the vibroacoustic, there's a vibration probe on the mother's abdomen, and then there's an acoustic, there's a barking kind of sound which comes out of a noisemaker kind of instrument, and that gives the stimulus for the baby to wake up, and that startling causes the heart rate to increase. Now remember, VAST, like the vibroacoustic stimulation test, it is not part of biophysical profile. Rare question now, but it was asked in your NEET exam around 5-6 years back. VAST is not part of biophysical profile. Now another test in the antepartum surveillance, maybe the very the test which we have to fall to when we are not very definitive with the biophysical profile and the NST. So we go and do the Doppler ultrasound. We do the Dopplers of the umbilical arteries or the uterine arteries or the ductus venosus Dopplers. Ductus venosus Dopplers is known to be the most well correlating with the progress of the baby. So just let's see the umbilical artery Doppler here. So we know that the flow should always be there in systole and diastole towards the baby. So systolic flow will be high, diastolic flow will be less, systolic high, diastolic less. So this is what is normal. Now sometimes what happens, systolic flow and diastolic flow is good in amount, but there is a diastolic notch. A diastolic notch is the first sign. Diastolic notch is the first sign of compromise. Fetal compromise, obviously. Then there is systolic flow, but there is no diastolic flow. So this is what is known as a absent diastolic flow. Absent diastolic flow is severe compromise. Please arrange for delivery of the baby. Maybe 1 or 2 days maximum you can wait. So this is severe compromise. And the worst type is that systole there's a flow, but diastole there's a reversal. So this is what is the most ominous, the reversal diastolic flow. Reversal of diastolic flow means that blood is coming out of the fetus in the diastole. So he's very close to stopping his flow in systole also, in effect dying. So reversal of diastolic flow means do delivery now. And mostly if it is a baby beyond 28 weeks, to save the baby, mostly we end up doing a cesarean section if those patterns are seen. So these are the antepartum surveillance tests, and Doppler is one of the good tests we have to fall back on if other tests are not conclusive enough. Then after doing the surveillance of the fetus and trying to push the pregnancy as close as possible to term, suppose there's a PIH patient, I have now reached 37 weeks, she's controlled with 3 drugs, now I cannot continue the pregnancy anymore, I must deliver this baby. So when I'm delivering this baby at 37 weeks, even during labor, I should be very careful. That is what is known as intrapartum surveillance. So during the labor, see the fetal heart rate by the stethoscope or by the Pinard's fetoscope. This is that Pinard fetoscope, that conical instrument which traditional doctors use. The big conical part goes on the metal abdomen and the flat part goes to the ear of the doctor. And with that, we can catch the low intensity sounds. So yes, we can do the Pinard fetoscopy also, and we can do the fetal scalp blood pH. Now this is also an interesting test. When the patient is in active labor 4 centimeters, 7-8 centimeters, then the cervix is big, open enough for us to put a sharp instrument, a probe inside the vagina, and with which makes a small cut on the baby's scalp, and we can suck out some minimal blood, and on that blood we can do the pH. If it is more than 7.2, the baby is healthy. Less than 7.2 is acidosis. So that is intrapartum surveillance. But one of the best tests for the intrapartum surveillance is to do the cardiotocography. Now that is the test which regularly comes in exam. Cardiotocography, please see, we have put 2 probes. This patient of mine, she was feeling a little constricted by the second belt. So there are 2 probes. The first one is the same Doppler which is picking the fetal heart rate, but the second one is taking the uterine contraction. But she didn't want the belt, so I just stuck it onto the metal abdomen. So please be careful. If you get 2 probes on the abdomen, it is a cardiotocograph. NST is 1 probe. Interns, be careful. After internship, and especially in gynae, you get into the habit of calling all the anesthesies as CTG. You know, your resident will say, yaar uska CTG kar le jaake, bed number 4 pe uska ek CTG kar le. CTG is in labor. NST is in antepartum. All right. Now, how is this test done? This test is the two probes, both of them are charted on a graph. So, when we see these graphs, see the cardiography, the fetal heart, the cardio part here, and the tocography, the part of the uterine contraction. So, cardio tocography we call it. So, with the toco, I mean to say the uterine contraction, the graph of the uterine contraction. So, when we see the uterine contraction, see here, with the uterine contraction, what happens to the fetal heart rate? You see here in the first example, with the uterine contraction, with the peak of the uterine contraction, you see the lowest fetal heart rate. This is known as the nadir or nadir. So, the lowest fetal heart rate or the lowest point of the graph is known as the nadir. So, peak and the nadir coincide. So, this is what is known as the early deceleration. Look, I taught you acceleration. 15 beats increase from the baseline is acceleration, and two such accelerations is known as a reactive non-stress test. Remember, increase of heart rate from baseline at least how many beats? 15 beats is acceleration. Now, reduction of heartbeat from the baseline, 15 beats and more is deceleration. So, from 150, it has come to 130. This is a deceleration, not a distress. Please do not say distress is equal to deceleration is equal to same. No. Fetal heart rate, normal fetal heart rate is 120 to 160. Less than 100, more than 180 is distress. If you go by the WHO partogram, these are the limits given on that graph. So please, we are talking that the heart rate is 150, it's gone to 130 here. See, it's gone to 130 here. So there is no distress. The heartbeat is in the safe range, 120 to 160. A fetus can maintain his perfusion. So we are discussing this chart because it's in the range of 120 to 160. From 120, it goes to 130, 140, 150, acceleration. 150, say it goes down to 120, deceleration. It is still in the normal range. So we are talking decelerations. We are not talking distress. If there is fetal distress, less than 100, do a cesarean. So that is a different altogether definition. We are talking decelerations. Do not mix them up, guys. Okay. So heart rate is reducing with the peak of the contraction, early deceleration. It is seen in head compression. The fetal head compression, because the uterine contraction causes vagal stimulation and reduces the heart rate. So this is normal in active labor. After 4 and more centimeters cervical dilatation is active labor, and this is a normal pattern in active labor. Then see the second example. With the uterine contraction, the heart rate goes low. Again, from 150, it's gone to, let's say, 130 here again. But this is not coinciding. So this is what is a late deceleration. A late deceleration is because of placental insufficiency. See, when the uterus contracts, the placenta empties. Now, if the placental blood vessels are not very healthy, they are calcific vessels of, let's say, PH or IUGR placenta. Then, when the placenta is squeezed, the blood goes out of the placenta slowly. When the uterus relaxes, the placenta has to refill. The refill is also slow. So, recovery of the heartbeat is slower. Reduction is slower. The fall of the heartbeat, the deceleration of the heart is slower, and the recovery is also slower because the placenta is not very healthy. So, when there is late deceleration, it is placental insufficiency and it is not normal. All right. But we are discussing deceleration again, not distress. So, yes, early deceleration is normal, late deceleration is not normal. There's another deceleration we'll discuss after this. This is the graph of a cardiotocograph, which we are showing you here. You can see the uterus has contracted, and with the contraction, you see here the heartbeat had come down. Now, when the contraction is waning, the heartbeat is picking up. So that is what is the early deceleration. This is the cardiotocograph. You can see this is the fetal heart rate range here, and this is the uterine contraction here. All right. So now this is another graph. There you can see the uterus is contracted and now it is relaxing. After the uterus starts relaxing, there is the reduction of the fetal heart rate. So this is a late deceleration. So once the uterus contraction wanes off, then you see the deceleration of the fetal heart rate. These also keep coming as your questions. But this is a late deceleration and this is not a normal pattern. Although there is no distress, I will not tolerate a deceleration also. Then another type of deceleration is seen with the uterine contractions, which is variable. Now what is that? The uterus contracts, the heartbeat goes down, picks up, then goes down and picks up, goes down, picks up, goes down, picks up. So no great relation with the uterine contractions, and the decelerations are variable, but there is no distress. So these are known as the variable decelerations, and this is seen because of umbilical cord compression, and this is the most common deceleration. Most common deceleration. All right. The safest deceleration is the early deceleration. The most common deceleration is the umbilical cord compression causing variable deceleration. And please remember, this is also mostly safe. Umbilical cord is, a long a cord can go around the neck of the baby, around the chest of the baby, around the arms of the baby, and some stretching and some compression can happen, but the fetus is used to these compressions, and minimal reduction and then recovery is all right. So if the recovery is within 30 seconds, it is absolutely normal. So yes, mostly it is safe, but sometimes there could be overshoots. All right, then there is supposed to be a problem. Sometimes they can be shoulders like this. That is all right. Shoulders, these are shoulders. These patterns are okay, but sometimes after recovery there is an overshoot. Now this is the overshoots. Shoulders are normal, overshoots are not. If you see overshoots in a case of variable deceleration, that is not normal. But you see these shoulders, these are okay in the graph. And recovery, if it is within 30 seconds, that is also normal. So that is what is variable deceleration, the most common deceleration associated with umbilical cord compression. So that's about the antepartum and the interpartum surveillance. All right. Hi. Now let us see about abortions. Abortions can be spontaneous abortions. Those are the ones which come out of the body of the lady before 28 weeks of pregnancy. Now they could just perish in the body when we call it an abortion, or they can get expelled. Still it is called an abortion. Now do not get confused. If a woman is pregnant and she is, let's say, having a 24-week baby inside her uterus and the baby dies, it is not yet expelled, but we still call it an abortion. Please don't get in the concept that it is an abortion only when it is expelled out. A woman is pregnant and the baby is dead. If it is before 28 weeks, we said she's had an abortion. Now she's going to expel it, or you're going to take it out. That's what is the termination of an abortion. But any baby which is dead before 28 weeks, it is called an abortion, or a baby which is expelled before 28 weeks, live or dead, it is still called an abortion. All right. So when we say abortions, they can be spontaneous, the ones which I explained to you just now, or they can be induced, that some women don't want the pregnancy because of, they have enough children, or they probably don't want this child because it is enormous. We'll read about all of these things. Let's see what are the spontaneous abortions because of. When we say spontaneous abortions, it is loss of a fetus before 28 weeks, and of all human pregnancies, 50% pregnancies spontaneously abort. Yes, they can abort before the woman gets her next period. So she gets implanted on the 20th day of the pregnancy, and then by the time she's about to miss the period, she actually aborts. So the patient thinks that she's actually got a period, but in fact she's aborting. So yes, almost 50% of human pregnancies abort. Now when we talk about abortions, we are talking about spontaneous abortions now, and we are talking about induced abortions later. So when we say about abortions can be anembryonic. That is, there was no embryo, but the woman was pregnant, but whatever was growing inside the uterus was just a sac, and there were no embryonic tissue. Now let me explain what I mean by an embryonic abortion. Let's see what happens normally in a pregnancy. At 4 weeks, you see a gestational sac. At 5 weeks, you see a yolk sac, the one in orange I've made. And then around 6 weeks, 5.5 weeks onwards, in fact, you see a fetal node. That blue thing is a fetal node. And then in this fetal node, you'll see a cardiac activity also. Then the fetus becomes bigger, and this yolk sac, this yolk sac which I had made, this yolk sac gets pinched out of the developing amniotic sac, and now you can see the almost the shape of the body of the fetus coming in. So this is general or the normal way of pregnancy progressing. Now what happens sometimes that at 4 weeks you see a sac, 5 weeks you see a sac, and then 6 weeks, 10 weeks you just see a gestational sac. So there was a pregnancy, the woman did get pregnant, but the pregnancy did not progress beyond the state of being a sac. So this is a lady who is pregnant. She has a pregnancy in her body, but the pregnancy denatured or degenerated, or the embryo did not activate beyond the state of the gestation sac. So this is what is known as an embryonic gestation. An embryonic gestation, all right, which I told you is an embryonic abortion, or which is more commonly called as the blighted ovum. Blighted ovum. See, this is not actually an oocyte or an ovum. It's an embryo which has got degenerated. But yes, the Brits call it blighted ovum. The Americans call it an embryonic gestation. Indians are the best. We teach you blighted ovum. In the exam, we ask you an embryonic gestation. Well, never mind. Let's move on. What are the embryonic abortions? So we are talking about spontaneous abortions, the ones which can be without an embryo, the anembryonic one, like I showed you just in the previous slide. And now we are talking about the embryonic abortions, that the woman is pregnant with a fetus inside, and how does that abortion come out? So all these abortions, most of the times when they have presentations, most of the presentations are pain and bleeding. Now let's see an example of a pregnancy here. I usually give an example of a 8 weeks pregnancy. And when a gynecologist does a per vaginal examination of 8 weeks pregnancy, the size of the uterus is around size of an orange, average size orange. That's normal. Now let's see. A woman is at 8 weeks and now she's having pain abdomen and bleeding per vaginum. Pain abdomen, bleeding per vaginum. Moment a woman who's pregnant comes to you and says pain abdomen, bleeding, you think she's aborting. So you do a per vaginal examination. In the per vaginal examination, you see the os is closed and the uterine size is equal to the period of gestation. She's come with pain and bleeding. You do a per vaginal examination and you see the size of the uterus is maintained, because at 8 weeks, you want to see the uterus, the size of an orange. You see this as the size of an orange, and the os, the external os here, this os is closed, although there's some bleeding. Now, this is what is known as a threatened. This is what is known as a threatened abortion, and the treatment is rest sedation, and we can add progesterones to help the pregnancy continue. Next situation, a patient may come with pain, abdomen and bleeding per vaginum. You do a per vaginal examination and you see the os is open and these products are bulging out of the vagina. So the woman has not yet expelled anything, but she's saying pain and bleeding. You see the per vaginal examination, you see that there is some products bulging. So that is what is known as a inevitable abortion. Inevitable abortion, you'll have to take the baby out. We call it an instrumental evacuation, or loosely said, a DNC. That's what is going to come as a choice in examination. Inevitable abortion, you take it out. Mostly you'll get a choice as do it by, that is, take out the fetus, evacuate the uterus by a DNC. Then another situation, patient has pain and bleeding, and while she was coming to the hospital because of the pain and bleeding, in the car she probably passed some tissues, and she brings the tissues in her hand and she says, I have passed this while I was in the car and I was coming to the hospital. Then that means she has passed some products. You do a per vaginal examination and see the os is still open. See, os is still open and you still feel some products. These are the products which are still felt. So this is what is known as a incomplete abortion. And when it is incomplete, you do a DNC to complete it. You cannot save this pregnancy, obviously. Another situation, same story, pain abdomen, bleeding per vaginum. She passed some tissues when she was in the car, when she was coming to you in the hospital. And when you do a per vaginal examination in the hospital, the os is now closed, but the uterus size is a normal size uterus. Remember the pregnancy, this is an 8 weeks example which I'm giving you, and the size of the uterus should be at least the size of an orange. But when you do a PV of this lady, you feel the uterus is size of a normal uterus. Then you know that this is a complete abortion, which is a complete abortion, and you don't have to do any treatment for that. Obviously, everything is already done. Of course, most of these presentations which come to you, your diagnosis is not just helped by a per-vaginal examination. You also do an ultrasound to substantiate your findings. Most of the times, with experience, all of us are very sure that our findings are good enough. But yes, ultrasound is a very good adjunctive method to make sure that your diagnosis is correct. Now, let's move on and see. If a patient, we do an ultrasound, we are still talking about the embryonic abortions. And embryonic abortions, I told you, threatened, inevitable, incomplete, and complete. I'm trying to tell you another type of an abortion here. At 8 weeks, you do an ultrasound. On the ultrasound, you see a fetus, you see a developing placenta, a cardiac activity, everything seems to be going fine. She comes for a repeat ultrasound, let's say at 12 weeks, I'm trying to do a NT&B scan. At 12 weeks, 13 weeks, we do it. At 12 weeks, I see I cannot make out a fetus, no head or tail I can make out. It's a crumpled ball of tissue, and obviously there's no cardiac activity. So yes, this baby is obviously dead. Now, what do I call this? In between, there was no pain and there was no bleeding. So there was no symptoms of an abortion, but there is an abortion. The fetus is inside and it is dead. So what do I call this? I call this a missed abortion. Why? Because the uterus has missed an abortion. Of course, the patient and also the doctor has missed an abortion. Nobody knew that she's aborting. And when you do an ultrasound, you see a dead fetus. That is a missed abortion. Obviously, depending on the gestation age, the size of the uterus, you will do the evacuation. Yes, the treatment is to do an evacuation. Now, when you're doing an evacuation, it depends on the time of gestation. And we'll be discussing about that, how you take out fetuses when it is required. We'll see that also later on. Now, what are the causes of these abortions? Why do women lose their pregnancies? Women lose their pregnancies because of many reasons. I'm just enumerating the most common ones. First trimester up to 12 weeks, the most common cause is chromosomal. Please do not have any doubts about this. And out of these chromosomal, the most common are the trisomies. And the most common trisomy is not trisomy 21, it is trisomy 16. Also, monosomy X, that is Turner syndrome, also causes an abortion. So, chromosomal causes. Remember, most common chromosomal defect in humans is 45XO. Now, this line is very important. When I talk about abortions, most common in the first trimester are chromosomal. In chromosomal, trisomies and monosomies. But when we talk about human pregnancies, abortions and normal pregnancies included, what is the most common chromosomal defect in humans? When I ask you that question, then the answer is 45XO, because Turner syndrome can cause abortions, but there are a lot of Turner syndromes who are alive and kicking, and you encounter them in your OPDs many times. So yes, most common chromosomal defect of humans, if they ask you, that's a different question, and that is 45XO. Now, that is the first trimester. Second trimester abortions are anatomical mostly. And in anatomical, you will have the separate uterus, bicornate uterus, unicornate uterus, and also the short cervix. Yes, all of us know short cervix is any cervix which is less than 2.5 centimeters in length. And how does this present? How does a short cervix present? All of you know the cervix will open before time. Like if I always tell you that the cervix is like this, my arms are the uterus, and this cervix which is so long, this cervix should efface and become part of the uterus at term 37 to 42 weeks of gestation. Now, when the cervix is not so long, this cervix is half of its size, it is short. This short cervix will efface much earlier. So, if it is going to efface, let's say 20 weeks and going to open up, is going to abort a baby. It may also abort a baby at 26 weeks. It may also open up and push a baby out at 32 weeks. When it is pushing a baby out at 32 weeks, then we call it preterm labor, isn't it? So, a short cervix can cause an abortion, but it can also predispose to an expulsion of fetus after 28 weeks and before 37, then it is called a preterm labor. We'll discuss about short cervix in preterm labor also, but let me tell you here itself that for a short cervix, this is the presentation that the patient will have: painless expulsion of the fetus in mid-trimester. What is mid-trimester? The second trimester. Painless expulsion around 20-24 weeks is the classical presentation of this short cervix. All right. So what do you do for these? For a septate uterus, you do a hysteroscopic resection. And for a biconate uterus, you do a metroplasty. That is unification surgery. Generally goes by the name of Strassman's metroplasty. When you join the two halves, if you see the uterus is normally like this and a biconate uterus is like this, when you join the two halves and make one cavity, that is what is known as a Strassman's metroplasty. Now, what is a short cervix? I told you it is a cervix which is not going to hold a fetus very well because it is less than 2.5 centimeters. So I'm going to put a stitch here, and that is what is known as a cerclage. So the treatment of a short cervix is cerclage, and that is applied after 12 weeks of pregnancy. Before the second trimester, like 20-24 weeks is the time when they generally abort. So you apply it after 12 weeks and remove it around 37 weeks because you want the patient to deliver. The most common cerclage, you know, is the McDonald cerclage. Yes, sometimes we can put cerclages which are for mutilated cervixes. That is a Shirodkar. And sometimes we can put cerclages even before the patient is pregnant. Prenatal cerclages. Prenatal cerclages are like Lash and Lash and Benson and Durfee. It's a very interesting discussion. You must see the regular app for the more details. Now, let's move on and see. There's some abortions which happen because of so many other reasons, but they're not trimester specific. What are those? Diabetes mellitus, systemic lupus erythematosus, syphilis, thrombophilias, hypothyroidism, and Torch infections. Now, all these abortions which happen, which can happen because of these are not specific for the trimester. Diabetes can cause an abortion in the first trimester and in the second trimester, but all of us know that diabetes can cause the intrauterine death of fetus at full term. Sudden IUD at term, we always think in terms of diabetes. We've discussed that in rapid revision. So remember, so these are not trimester specifics. They can cause abortions anytime, and they can also cause intrauterine fetal death. So that's how we make a line that these abortions can be anytime. Now, let's move on and see what are the thrombophilias. See, all of us understand diabetes mellitus, systemic lupus erythematosus, syphilis, and thrombophilias. What I must tell you that affinity to thrombus formation. And why I'm telling you a little bit here, because it's a little in vogue to ask questions on this. Your medicine people are teaching you this much better, but I'm just introducing. Thrombophilias is an affinity to make thrombi. So when there are thrombus in the blood vessels which are in the placenta, obviously perfusion will stop and the baby will die. So it can happen in the first trimester. Sometimes these thrombi can happen in the late second trimester or early third trimester. Then the baby doesn't die, but he has an IUGR. Or the placenta, because of the microthrombi, will have poor perfusion. So mother increases the blood pressure to perfuse blood through these smaller diameter blood vessels. So there could be a hypertension in the early third trimester because of these thrombophilias. So there are many presentations of thrombophilias. So let us just briefly tell you a little bit about these thrombophilias. That thrombophilias are inherited and acquired, and the cause of these thrombi can be a factor V Leiden mutation, methyl tetrahydrofolate reductase gene mutation, prothrombin gene mutation, a deficiency of protein C and protein S, and antithrombin 3 deficiency. So all of these can, or any one of these, I mean to say, it doesn't have to be all these 5. Any one of these can cause the patient to have more thrombus. And then thrombus can be also because of acquired thrombophilias, that is lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. So all of you interns who have worked in the gynae clinics, I'm very sure that you would have seen this recurrent pregnancy loss patients coming and your resident writing the lupus anticoagulant and the antiphospholipid antibody test in the OPD. So these are the thrombophilias. Now, what I want you to see is that sometimes the patients have this syphilis causing an abortion. So what I want to tell you about syphilis, I want to just mention that it can cause an abortion, but next pregnancy, the outcome is slightly better. let me give you an example that suppose syphilis causes abortion this time in the 10th week of pregnancy. Next time it may cause an abortion, let's say around 24 weeks. Third time probably with the patient having syphilis and there is congenital syphilis, but the baby survives and there's a healthy full-term baby. So progressively better outcome with syphilis is known to happen. So yes, syphilis has this Kasowicz's law. Kasowicz's law, which says progressively better outcome in subsequent pregnancies. I'm sure you microbiologists will give the right spelling of that. But yes, Kasowicz's law is something which is regularly, asked in the exams. At least the last 3 years, I've seen it coming at least thrice. Now, recurrent pregnancy loss. What do I mean by recurrent pregnancy loss? Please remember, now we don't say recurrent abortions. We say recurrent pregnancy loss, and that is 3 or more pregnancy losses. We don't say recurrent abortions anymore, because if a woman loses a baby at 10 weeks or she loses a baby at 34 weeks, she has in effect lost 2 pregnancies. Whether it is an abortion or a stillbirth, for her it does not matter. She was pregnant twice and today she does not have a child at home. So she has lost 2 babies. So that's why we have, now made a new terminology, and that says recurrent pregnancy losses. So in your exams, you may not be asked recurrent abortions. So don't get confused. When we teach you about recurrent abortions, sometimes in our classrooms, in wherever colleges you are, we are essentially going to ask in the final exams, wherever this next exam is going to happen, we're going to ask you about recurrent pregnancy loss. That is the standard way of asking. Recurrent pregnancy loss, most common cause of recurrent pregnancy loss are chromosomal, okay, and not antiphospholipid antibody syndrome. And then it can also be, if you do not correct the anatomy, if there's a septate uterus, it is still septate, and it is a biconate, it is still biconate, you've not corrected that. If you don't correct the anatomical defect, you don't correct the short cervix, she's going to abort again, all right? So anatomical also causes recurrent abortions. And all of these, whatever I discussed with you in the previous slide, these can also cause recurrent pregnancy losses. But these Torch infections never cause recurrent abortions. Now, this is what you have to understand. Torch group of infections, when they cause abortions, next time the mother is immune to these infections. So, whatever I discussed in the previous slide can cause recurrent pregnancy losses. Most common are the chromosomal. All of these also can cause, but Torch group, the various parts of these labor durations, and then what can go wrong with this normal labor. So the stage of labor, like we know, there are 3 stages of labor, in fact, and that is from the onset of pain to the full dilatation of cervix, from the full dilatation of cervix to the delivery of the fetus to the external world, and from the delivery of the fetus to the delivery of the placenta. Those are the 3 stages. But yes, we also have an added stage, especially for the observation of this lady for 1 hour after the delivery, to make sure that she does not have PPH. So that is the 4th stage. So these are the 3 stages which are generally described, and Dr. Friedman gave us the various parts of these stages of labor, and the stage 1 and stage 2 have these parts which have been described in a graph by Dr. Friedman. So Friedman graph of labor is like this, and this is what is utilized when we are talking about the partogram sometimes later in the class when I'll be telling you. So the Friedman graph is basically the cervical dilatation plotted around with the time of the labor. And when we are talking about the time, we have to see that the first part of this labor graph is about the first stage. The first stage is still here, and this first stage is divided into the latent phase and the active phase. Then later half of the labor, when the cervix is fully dilated, then we say the second stage of labor, when the delivery of the fetus to the external world happens. So now when we look at this graph, let's see from the beginning of the cervical dilatation from 0 to 10 centimeters. So when we're talking about the dilatation of the cervix, as the labor pain starts, look, I'll try to tell you the other way around. One woman comes and says that I've got these mild pains. I'm around 38 weeks of gestation. You examine and see that she's around 1 centimeters and she's got these mild irregular pains. So that's why I say that she is getting into labor, but she's not into that very severe pains. So that is what is the early stage of labor, but it is still from the onset of pain to the full dilatation. So yes, she's already started dilating. She started already having some pain. So yes, from 0 to 10 centimeters, how does this pain progress? That is what is the stage 1 of Friedman's graph. So from the onset of contraction and the cervical dilatation, how the pain progresses. See, the latent phase of labor has mild irregular contractions, and they are very irregular and not very strong, and they may last around 3, 4, 5 hours. These latent phase contractions, they can go up to 8 hours. So this latent phase is generally till around 3 centimeters, till here. And after 4 centimeters, that is 4 and more centimeters, this pain, the pain which is now coming more and more regularly, that pain is now known as the active phase of labor. So yes, active phase of labor, yes, we are still saying 4 centimeters. I know there's a lot of controversy about WHO saying 5 and the American college saying 6, but all the medical colleges in the country are still sticking with the 4 centimeters. Yes, we in the college are also talking about these 5 centimeters, but once it gets accepted and is taught in your medical colleges, then we'll change what we are teaching you. So 4 centimeters and beyond is the active phase of labor. So latent phase till 3 centimeters, mild irregular contractions. And then when the cervix is dilated to 4 centimeters, see the contractions become very strong and regular. So that is the active phase of labor. Even in the active phase, there's an acceleration phase like this. Then there's a phase of maximum slope, and then there's a deceleration phase. Generally around 8 centimeters is the deceleration phase. So the active phase of labor, strong regular contractions. And then when the cervix is around 10 centimeters, we say she's in the second stage of labor, when the patient is going to push out the baby. So when we understand these phases of labor, let's see a little bit more about the individual durations of these phases of labor. So the latent phase, mild irregular contractions, 15 to 20 seconds contractions of around 15 to 20 Montevideo units. That's the units in which we describe the labor pains. And these are generally around 4 in 20 minutes or 8 in 60 minutes. So that is the latent phase of labor, and it may last up to 8 hours normally. It is called prolonged, MCQ. Latent phase of labor is called prolonged if it is more than 20 hours in a primary gravida and more than 14 hours in a multigravida. Now, when the patient is in the active phase of labor, you know these are strong, regular contractions, and these will be around 45-second contractions coming once in every 3 minutes. So we say in 10 minutes, if there are 3 good contractions like this, in 10 minutes, if there are 3 contractions like this of 45 seconds, then she's in good active labor and she's going to progress well. So yes, once in 3 minutes, 45 seconds, 3 to 5 such contractions in 10 minutes. Yes, more than 5, see, up to 5 is okay. More than 5 is what is known as tachysystole, too many contractions. So that kind of pain, which is coming more than 5 times in 10 minutes, that is too much of long contractions, and the baby won't get time to have a relaxed uterus and have good oxygenation. So yes, there might be fetal distress because of this tachysystole. So we generally have to stop the labor in such patients. We'll have to give some tocolytics to give some relief and stop the oxytocin. All right. So that is the definition and the duration of the active and the latent phase. Now, what is the second stage of labor? Second stage of labor is when the baby is pushed out. So after full dilatation to the delivery of the fetus is the second stage, and it is generally around 1 hour in a primary gravida, but only 30 minutes in a multigravida. It is called prolonged second stage. It is called prolonged second stage if it is more than 2 hours in a multi and more than 1 hour in a. So now let us see the second stage of labor. When we say the second stage of labor, that's the time when the fetus is expelled from, when the cervix is fully dilated and the fetus is expelled. So this should last not more than 1 hour in a primary gravida and only 30 minutes in a multigravida. We call it a prolonged second stage if a primary gravida is around 2 hours in the second stage, and we call it prolonged in a multi if it is 1 hour, and within 1 hour itself we call the multi to be in the prolonged second stage. Now, let us get into the discussion of preterm labor first. When we're talking about the normal labor durations, which I just now told you, suppose all of this happens before 37 weeks. We call it preterm labor. So when there is preterm labor, how to define preterm labor? So that's why it's very simple. The same things again happen before 37 weeks. So same latent phase and the same active phase, all of that you'll see before 37 weeks. So that is known as preterm labor. So when people are asking you what is the definition of preterm labor, we don't have to get confused at all. We just say, yes, she's getting into this latent phase, let's say at 34 weeks of gestation, How do you know she's getting to latent phase? Well, she's getting contractions of around 15 to 20 seconds, which are coming at least 4 times in 20 minutes or 8 times in 60 minutes. So I know, yes, she's getting into preterm labor. So why I told you these characteristics of normal labor? Because the same happened in a preterm labor, and that's what we should keep in mind when we're diagnosing preterm labor. So that's the definition, that she's getting these mild irregular contractions, and we measure this contraction, we know she's getting labor. Then we can substantiate our findings of preterm labor by doing a per-vaginal examination. And a per-vaginal examination, the cervix is more than 1 centimeter dilated and 80% effaced, then she is said to be in preterm labor. That's what is supposed to be the diagnosis of preterm labor. Then, how do we go about the discussion of preterm labor? The incidence is around 10%. We say 6 to 15%. Roughly around 10% is the incidence of preterm labor. The common causes of preterm labor are infections. Generally, whatever you know about the pelvic inflammatory diseases, all those organisms come in these infections and cause chorioamnionitis. In pregnancy, we don't call it PID. We call it chorioamnionitis. So, chlamydia, gonorrhea, mycoplasma, those are the infections. Then, over-distension of uterus, like with polyhydramnios or with twins. Okay, or a large baby, which you see in diabetes mellitus. So yes, diabetes itself is a cause of preterm labor, because the more infections in diabetes can predispose to preterm labor, and the large size of the baby can predispose to preterm labor. Then uterine anomalies like septate, Bacunate, and short cervix. I told you that a short cervix can predispose to an abortion, can also predispose to preterm labor. Duration wise, how do you define labor? Any labor before 37 weeks is preterm labor. That is now understood. But in this also, we have subdivisions. Like if a woman is in labor between 34 to 37 weeks, then I'm not too worried about this preterm labor, because 34 weeks, the lung is mature. So yes, I know it is not the right time. I want all babies to deliver only after 37 weeks. But if they deliver 34 to 36 plus 6, then that is what is known as the late preterm labor. And 32 to 34 weeks is the usual, we call it the preterm labor or the usual preterm labor. And before 32 weeks is known as the early or the severe preterm labor. All right. Now, when we are talking about this, let us see how we can predict preterm labor. We'll come to the treatment. Prediction of preterm labor. There are some signs and symptoms by which we can make out that the patient may go into preterm labor. So in the early part of the pregnancy, around 10-12 weeks, when we do a per-vaginal examination or we're doing an ultrasound and we see that the cervix is less than 2.5 centimeter. It's a short cervix. Like I told you, it can efface early and cause a patient to go into preterm labor. Yes, we also discussed in the chapter of abortion that a short cervix can expel a baby before 28 weeks. And that is known as abortion. If the baby is expelled after 28 weeks, then it is known as preterm labor. Okay. Now, around 29 weeks of gestation, 28-29 weeks, we do an ultrasound and you see funneling of the cervix. So what is funneling of the cervix? That if you see the bag of membranes, it starts funneling into the cervix. So yes, this is that characteristic picture which keeps coming in the exam. The cervix is generally a T shape. See, this is the T here. So T-shaped cervix is the normal cervix, and the bags of membranes start invaginating into the cervix and the cervix is opening. So the first sign of funneling of the cervix, the membranes funneling the cervix, is a Y-shaped cervix on the ultrasound. Then a more severe sign is a V-shaped funneling, and a much severe imminent delivery. Just before delivery, you will see the funneling which is U-shaped. So that's why they keep asking you what kind of funneling, what kind of a shape of funneling you will see before a woman is going into preterm labor, just before she is about to go into labor. That is U-shaped funneling. So that's how the the series of funneling alphabets are told you: Y, V, and U. Right? So this is going to help us predict preterm labor. Now, we can also predict preterm labor if we see some fetal proteins in the vaginal secretions, like the fetal fibronectin. So what is fetal fibronectin? We see that in early pregnancy, that the gestation sac is growing and it is about to fill the, I've made an arrow, it is about to fill the whole uterine cavity. So when the gestation sac, can you see now it has filled up the uterine cavity? The sac is attached to the uterine cavity with this I've made a blue color line here. This is fetal fibronectin. I don't know the color. I'm just saying that I'm trying to show you that there is a glue. There's a glue-like protein which is going to stick the fetal membranes to the uterine walls. So that glue is known as the fetal fibronectin. So when does the obliteration, see this sac is filling up the uterus. So when does the obliteration happens? 16 weeks, the cavity gets obliterated. And this fetal fibronectin from 22 to 37 weeks will not be seen in cervico-vaginal secretions. It will not be seen. All right. Then we predicted preterm labor and I told you the diagnosis of preterm labor. Now, when the patient comes to you with preterm labor, these are the drugs which we are going to talk about. But before I give you the drugs, I kept some empty space here. What is the purpose of giving these drugs? First, understand that we are trying to stop labor. We are trying to stop labor for what purpose? And how long can we stop the labor? Please understand that when I told you about these characteristics of the preterm labor, all of these characteristics of preterm labor, the patient who's gone into labor and now she's in the latent phase of labor and she's come to me, let's say at 32 weeks of gestation, and when she's in latent phase of labor, I want to stop the labor. Yes, sometimes she may come to me in advanced labor, active phase of labor. She may come to me at 7 centimeters dilatation. Now, before I tell you the drugs, please understand, I can stop only the latent phase of labor. Yes, when we are talking about this labor in the Friedman's graph, this latent phase of labor which has mild irregular contractions, this is the one which can be stopped if required. Yes, it can be stopped if required. That is the latent phase of labor. But when the patient gets into the active phase of labor, this active phase of labor cannot be stopped. So yes, when we are giving the drugs for the stoppage of preterm labor, I know the lungs are not mature. That's why I'm trying to stop the preterm labor. So yes, let us now understand how and when we give these drugs. So purpose is to stop preterm labor, get around 2 days at least. Look, when you stop preterm labor, if it is established preterm labor and you know it is preterm labor, not just cramps in the abdomen or some discomfort in the abdomen, you have diagnosed that the cervix is open and it is effaced, you have diagnosed preterm labor, then you will not get more than 2-3 days of stoppage time, even if you give the best tocolytics. Now, this is something which is missed by most of my interns. When you're giving tocolytic drugs, before I'm telling you the details, understand, by giving this tocolytics, I'm trying to stop preterm labor and get 2 or 3 days. You will not get more than those days. Okay. So purpose is to stop the preterm labor and get time for steroid action for the lung maturity. Yes, this is for the purpose of lung maturity. That is why we are giving these tocolytics. Now, when can you give it? We can give it when she is before 34 weeks. I just now told you based on the duration, the classification of preterm labor or the types of preterm labor, and before 34 weeks when the lung is not mature, then only I give these tocolytic drugs. And when the cervix is less than equal to 3 centimeters dilated, that is in latent phase of labor and not in active phase of labor. All right. So once we understand this, then only try to see. Otherwise, by rote, we keep remembering all the drugs. But remember the purpose. Purpose is for lung maturity. Try to get 2 or 3 days, and you can get these 2 or 3 days only when the patient is in preterm labor, and we'll give them only when the patient is before 34 weeks. All right. So let us see about the drugs now. So the drugs which we are talking, these are known as the tocolytics, and a lot of tocolytics which are used in our country in India are the beta agonists. So isoxsuprine, interns will know the trade name. It is sold as Duardilon. So that is one very famous drug. But yes, the problem with beta agonists is, so these beta agonists can cause tachycardia. They can also cause glycogenolysis, lipolysis, and increase the sugars. So that's why we avoid these beta agonists in diabetes when patients are diabetic in pregnancy. Now, calcium channel blockers, no doubt about them being the drugs of choice, and they are safe in heart diseases also because they have very less pulmonary edema chances versus all the other drugs. This, about all the drugs we're discussing, maximum pulmonary edema is by the beta agonists. So calcium channel blockers, nifedipine 30 milligrams stat and then 10 milligrams 3 times a day is the dose for the tocolytic action, and that is the best drug I've seen for tocolytic effect. Now, my personal favorite is always magnesium sulfate, which is a calcium antagonist. It is given 1 to 2 grams per hour. 1 to 2 grams per hour in an infusion, and this is the only neuroprotective tocolytic. That means the babies who have preterm labor and are born, but the mothers were given some tocolytics with magnesium sulfate. These babies, when they're born, they have lesser incidence of cerebral palsy versus the other drugs. So the only neuroprotective drug, that's why it's my favorite drug. But yes, it is known to cause neonatal hypotonia as a side effect. That's why it is not the drug of choice. But yes, that drug of choice is nifedipine. Now, prostaglandin synthetase inhibitors, NSAIDs like indomethacin, 25 to 50 milligrams 3 times a day is a good tocolytic action. But yes, all of us know that we'll not give indomethacin after 32 weeks because if we give it after 32 weeks, it'll cause premature closure of the ductus arteriosus. Now, progesterone is the safest tocolytic. Somehow, MCI people are asked this question a lot. Yes, progesterone and nitric oxide donors, both of these are good drugs. They are smooth muscle relaxants. And the safest tocolytic which we know is progesterone. But progesterone is more used as a prophylactic drug than a treatment. So more for prophylaxis, and the safest drug is progesterone. Now, atosiban is the perfect antagonist of oxytocin, and quite a lot of your books keep saying that is a drug of choice. Please, the only thing ever asked to a few people in the exams is what is the oxytocin antagonist, and they say atosiban. Now, India, there's a lot of push for atosiban in the private sector, and we are using it in the government also. But remember, atosiban is used a lot in Europe and in England. This drug is actually banned by the FDA in Americas. So a drug which is banned in America and a drug which is used a lot in, let's say in Europe, when there's these kind of controversies, we are never going to ask you this question in the exam that which is the best drug, and I'm not expecting you to write atosiban. Maybe I'll just ask you the pharmacology of atosiban. So it is a oxytocin antagonist. Now, why is it banned in America? Because what is the purpose of giving the tocolytics? That neonatal morbidity and mortality should be reduced, and there should be good tocolytic action to get this effect, that reduction of neonatal morbidity and mortality. For that, we need a good tocolytic action. So for all that, when we give atosiban is having no effect, no benefit. Atosiban is not having any significant effect on reducing the neonatal morbidity and mortality or giving some good tocolytic action. And let me tell you one thing personally, it is way more expensive. It is way more expensive. It's in thousands, 15 to 20,000 is the rate of atosiban compared to nifedipine, where I think you get 10 tablets for 6 rupees, and it's a wonderful drug, nifedipine. So that's why don't say atosiban is the drug of choice. Yes, it is very safe on the heart. It doesn't matter if it is safe on the heart. All I care is that a tocolytic drug should be able to reduce the neonatal morbidity and mortality and give relief in preterm labor. That action it is not doing. So that's why it is not the drug of choice, and they won't ask you about this. So what about the lung maturity bit? We know that the lung is mature at 34 weeks, and after 34 weeks, if there is preterm labor, we generally don't tend to stop it, and we don't give steroids also most of the time. So what happens in lung maturity? That after 34 weeks, the less than sphingomyelin ratio increases 2:1. Phosphatidylcholine, it is seen in the amniotic fluid, maternal serum, and the fetal serum. And phosphatidylglycerol is seen in the amniotic fluid only. Now, when we talk about, stop reading the other things, just let's talk about the phosphatidylcholine and phosphatidylglycerol. So when I talk about lung maturity, I am talking about the lung should be able to distend. Lung should be able to distend with every breath. So this action when the baby breathes should happen. So on the surface, there should be less surface tension. To reduce surface tension, the lung has surfactant. What is surfactant? It reduces the tension on the surface of the lung, as simple as that. So what is it made up of? Surfactant is made up of fats. If these fats are applied on the lung will distend and there will be less surface tension. Wherever in the world you want to reduce surface tension, we use fats, isn't it? So when you have a dirty cloth, I mean, there's some stain on your shirts, you use fat. When there is some grease, when there is some stain on your shirt, you will use some detergent and you will mix water and try to reduce the surface tension, and this dirt comes off. So that fat is required to reduce surface tension. Even in the motorbike's chain and the fans and the machines, wherever there is fat, it reduces the surface tension. So yes, something similar happens on the lung. The surface of the lung should have fat, and the best fat in the surfactant, and the 70% of the surfactant is phosphatidylcholine. 70% of surfactant. And the best part of the surfactant is the phosphatidylcholine. Then why are we even talking about phosphatidylglycerol? Because choline starts production in the body from 24 weeks onwards by the type 2 alveolar pneumocytes. So 24 weeks, I know no lung is mature. So that's why we say it starts coming in all these fluids. But the maximum amount of this phosphatidylcholine will be realized only around 34-35 weeks. So when it starts appearing in these secretions, it is not that the lung is mature. So how do we know and how do we calculate that the lung is now mature? So we don't calculate the choline. We very smartly look out for phosphatidylglycerol. Choline is fat, and fat production starts from 24 weeks from the type 2 alveolar pneumocytes. It slowly goes on increasing till 34 weeks. After 34 weeks, the required amount of fat, when it is already made, then storage form of fats are made by the body, and that is the sterols and glycerol. When storage form of fats, these type of fats start appearing in the body, that means the active form of fats like choline are already made. So when glycerol appears in the amniotic fluid, only when it appears in the amniotic fluid, then that is considered as a final indicator of pulmonary maturity. That's the final indicator of pulmonary maturity. Please understand, the best is phosphatidylcholine, but to know that the lung is mature, we should have phosphatidylglycerol in the amniotic fluid. So there are some questions which are asked in the exam. They'll give you a lot of these equations, and they'll say which one of these four is a mature lung. So look out for that equation in which they've written Pg present in the amniotic fluid. So that's a mature lung. Now we can also see lung maturity by the shake test and the tap test. When you have amniotic fluid, you take this amniotic fluid, you do amniocentesis, take the amniotic fluid, and in that test tube, you add some saponifying agents that like sodium hydroxide, lye, like it is called lye. So that sodium hydroxide, when you add, if they are fats, like what is lung maturity? It is fats. So if the amniotic fluid has fats, those fats will become soaps by the saponifying agents. And when you shake the tube, there will be bubble formation. So yes, bubble formation is telling that the lung is mature. Why? Because it is telling us that there are fats in the amniotic fluid. So if amniotic fluid has fats, which is shown by the bubble test here, that means there are fats in other parts of the body, like the lung of the baby. All right. So that is an indicator that the lung is mature. Now, similarly, there is a Nile blue sulfate test. Now, Nile blue sulfate test is again for the lung maturity only, but it is assessing the fetal skin cells. So don't say it is for skin maturity. What happens? The same amniotic fluid. So we do an amniocentesis from the uterus and take this amniotic fluid in a test tube and we spin it, we centrifuge it. And in the centrifuge, I'll get some fetal skin cells. Those fetal skin cells are plated on a slide. On that slide, I will add the Nile blue agent. And if the cells are making fats, then they will become orange in color because of the Nile blue agent. And if more than 50% cells are orange in color, that means there is enough fats made by the skin. That means similar fats are made elsewhere in the body, like the lungs. Okay. So yes, we are trying to assess the fats on the fetal skin, but essentially we're doing the assessment of fat production in the body. That means the lung is making the fat. Please, for God's sakes, don't say that this is a test for skin maturity. Like, unlike some of your guidebooks were saying it sometimes back, most of them have corrected what they were saying. Please remember, it is not a test for skin maturity. It is a test for lung maturity, Nile blue sulfate test. Right. So, how can we accelerate the lung maturity? Sometimes if a baby, if the mother is in preterm labor, so we can give to the mother some steroids. And before you see this, how will steroids cause maturity of the lung of the baby? So after giving the injections to the mother, this steroids will accelerate the fetal lung maturity by making more and more fats. So the injections which we give, injection dexamethasone 6 milligram 12 hourly 4 doses, or injection betamethasone 12 milligram 24 hourly 2 doses. If you see closely, 12 into 2, 24 milligrams, and 6 into 4, 24 milligrams. Both of these are given 24 milligrams. We give them both intramuscular, and both are equally effective. Earlier we used to say Dexa is good. Then good 5-6 years we were saying, in the early 2010s to 2016 we were saying that betamethasone is very good. Now it has been proven way beyond doubt that both of these are equally effective. All right. So that is the steroids to the mother. Now sometimes a baby is born premature. This situation, steroids to the mother, is when fetus is in utero. Now sometimes the baby is born premature. He's born at 32 weeks and the lungs are not mature. Now we cannot give steroids. We give the baby to save him fast. We are not going to accelerate fat maturity. We're going to give the fats. Yes, it's all about fats, like I told you. So give the fats to the baby and the lung will get mature. So how do you give the fats? We give the fats into the lungs. We want the lung to have a fat lining, a lung alveolus to have fat on the surface. So we have intubated the baby because the baby is not having a good mature lung. He's having respiratory distress. So we are helping him with the intubation and giving him ventilation. Now we detach the ventilator and through the endotracheal tube, we put the fats so that they go and line the lungs. So basically it is fats. All right. So what are those fats? Artificial surfactants. What are those? Survanta, Axosurf, Elec. Survanta is the most common one used in our country, but I'm sure your pediatricians will be the better informants of which is the better or the regular used artificial surfactant. This Survanta, which I've seen in my hospital, at least the most common one used, and this is given directly intratracheal, costs around 20 to 30,000 rupees one shot, but it is very effective. All right. Now, along with preterm labor, let's also see about premature rupture of membranes. So what do you mean by rupture of membranes? Ideally, rupture of membranes should happen when these membranes have assisted in full dilation of the cervix. If you look at these membranes here, these membranes which are ahead of the head of the baby, these membranes are going to help in the dilatation of the cervix. So when a patient is in labor, these membranes which are in front of the head of the baby, they will distend the cervix and dilate and help the baby come out. So ideally, when should the membranes rupture? Please, I don't know if you've seen an animal delivering, if you've seen a cow or a goat delivering anywhere in a village, you see the calf is always delivered in caul, that is with the membranes. You know, they have, you must have seen some, domestic cows delivering, but There are thousands of animals in the jungles. Who is going to deliver them? Are there veterinaries delivering each and every animal in the world? No, they just deliver in the wild. But why don't they have obstructed labor? Why don't they have problems of breech and transverse lie? Because all these animals, they will not have rupture of membranes, and no gynecologist is going to do a rupture of membranes and check if the liquid is clear or not. So they just distend their cervices with this bag, and that bag is making sure that even if the baby is by breech or the baby is getting the legs or the head, it will deliver because the bag of membranes is distending the cervix. So that's the theory behind the bag of membranes. It should be intact till the second stage, and then it ruptures and the baby comes out. So yes, if the bag of membrane ruptures before full dilatation, that is early rupture of membranes. That is rupture of membranes before full dilatation of cervix. All right. Now, what is premature rupture of membranes? That is rupture of membranes before onset of labor. And what is it called if the rupture of membranes happens before 37 weeks? So before 37 weeks, we call it a preterm PROM. So when there is rupture of membranes, the bigger problem is that if the patient doesn't go into labor fast, then she can have infections. Most patients, 90% of patients, will go into spontaneous labor within 1 day of rupture of membranes. But now we don't wait so long. Most these patients who have rupture of membranes, we'll want them to go into labor as early as possible. So if they don't get into labor in 1 or 2 hours, we start inducing them. All right. So that is if they are at term. If they're before term, then we'll have to make a good assessment how much before they are coming to us before term and how much time we can wait for starting. So can we give antibiotics and buy some time? Can we give some steroids if the baby is much before 34 weeks, etc., etc. The management keeps changing. So let's just talk about rupture of membranes. Give antibiotics and induce as early as possible when there is rupture of membranes before onset of labor. We're talking about rupture of membranes at term. So we give antibiotics and induce labor. That is a basic protocol. Now, if there is a doubt regarding the diagnosis of PROM, for the diagnosis, if there's a doubt, how do you make sure that there is rupture of membranes? Look, mostly what happens, a patient says, sir, I think I burst my bag of membranes. She'll come and tell you. Why? Because, sir, I'm gushing out fluid from my vagina. You make her lie down and you open the vagina with a speculum and you see a gush of fluids. That is rupture of membranes, you know, very easily. But sometimes a woman will come and just say, sir, I'm having some fluid kind of discharge from the vagina. And how pregnant are you? Sir, I'm 37 weeks, but I don't have any pain, but there's some fluid coming out. I don't know what's happening. Now, when you open the vagina with the speculum, you see the vagina is moist. It could be rupture of membranes, for which I have to give antibiotics, otherwise she'll go into sepsis, and I'll have to induce labor. But it could be just vaginitis. It could be just bacterial vaginosis. So then I don't have to induce labor. I have to just give her antibiotics and send her home because she's not in labor yet, and we can wait till 40 weeks for the delivery. So yes, if there is premature rupture of membranes, I have to deliver. If it is not, then the pregnancy can continue for some time. Sometimes they may come with PROM at 33 weeks, 34 weeks. Then also you will have to make sure there is rupture of membranes or not. So for those doubtful cases, we have the nitrazine paper test. There are many indicators, like sometimes we have the litmus paper test, we have the phenolphthalein indicator test for pH. Now the nitrazine paper, we put it in the vagina, or we take the secretion and put it into a paper, and then this paper will change color depending on the pH. So vaginal pH is acidic and amniotic fluid pH is alkaline. So if it becomes red in color, then that is acidic pH. All right. That means it is vaginitis, because bacterial vaginosis and trichomoniasis happen in acidic pH. And if the fluids are acidic, that means they are vaginal fluids, then it is not rupture of membranes. But if it becomes blue, then it is alkaline. All right. And alkaline is amniotic fluid. So that diagnosis, premature rupture of membranes. All right. So acid, red, alkaline, blue. One easy way to remember is that red acid, blue E, and alkaline E. I don't know. If you didn't like it, it's all right. You can remember even otherwise. So that is nitrazine paper test. Then fetal fibronectin. Fetal fibronectin, like I just told you in preterm labor, if it is seen in vagina. If it is seen in vagina, that is an indicator that the patient is having rupture of membranes and going to preterm labor. Now, increased alpha fetoprotein in the vaginal fluids and then ferning. These are also indicators that when you plate the amniotic fluid on a slide and allow it to dry, it will show a fern tree pattern. So that also is an indication that the patient has gone to in a rupture of membranes. Now, what is the Amnisure test? NEET PG students were given this question around 5 years back. Amnisure test is the assessment of the PAMG1, placental alpha microglobin 1, and if it is seen in the vagina, normally it is not seen in the vagina. It is around 2000 times in the amniotic fluid versus the vaginal concentration of this. So, if it is seen in a high concentration in the vagina, then we say the patient is having a premature rupture of membranes. So, yes, generally it is less than 2 nanograms per ml in vagina, and the cutoff we say is if it is more than 5 nanograms per ml in the cervicovaginal secretions, then that's a diagnosis of premature rupture of membranes. All right. Hi. So let us now start talking about the deliveries. In this chapter, we'll see about the normal labor and the abnormal labor. We have already discussed the stage of labor in 2 other places with the rapid revision itself. Now let's get into the proper delivery. So when I'm talking about this chapter, it's a gist of all the labor process, the normal and the abnormal one. And needless to say, in rapid revision, things will be a little fast. So please stay concentrating on this chapter and right time to put your WhatsApp off. All right. So when we're talking about the normal labor, before that, let us see some definitions. So what do you mean by a presentation? So a human baby has 2 major poles, that is the head pole and the buttocks pole. So the head and the buttocks, the cephalic and podalic. So when the head is in the lower segment, we call it a cephalic presentation. And when the breech is in the lower segment, we call it a breech presentation, or the podalic pole. When it is in the lower segment, it is called breech. Now, when the shoulder is in the lower segment, we call it a shoulder presentation. Please, we don't call it a transverse lie yet. When I'm asking about a lie, then say vertical lie in cephalic, vertical lie in breech, and transverse lie in shoulder presentation. So lie is different and shoulder presentation is different. Look, it is basically the same thing, but when we are asking about presentation, say cephalic, breech, and shoulder. When I ask you about lie, then say vertical, vertical, and transverse. So when they give you a picture like this in the exam and ask you what presentation is this, say shoulder presentation. Don't say transverse lie yet. Lie, if we want, we'll ask you specifically. All right. So when these 3 come in labor, then what do you do for this first one? First one will deliver. This is the normal way deliveries happen. Breech will also deliver, but in a institutional setup under a trained obstetrician. A trained obstetrician, I'm just writing obst here. So a person who is like a consultant, a postgraduate may assist, but a second year, third year PG also is not senior enough to do a breech alone, always under supervision, because breech can cause more injuries. Of course, a shoulder presentation, when it comes in labor, I will do a cesarean section. So they can ask you shoulder presentation in labor, or they'll ask you transverse lie in labor. Answer obviously in both these. They're just same thing asked in 2 different ways. Answer in both of those would be a cesarean section. Now, this situation can present to you even when the patient is relaxed. Let's say uterus is relaxed at 36 weeks. The patient is not in labor. And what do you do for a cephalic? Obviously, let the pregnancy continue. Nothing to be done. But suppose at 36 weeks, patient is not in labor. It is having a relaxed uterus and the baby is by breech. I know at term, I can do a breech vaginal delivery. But even I, with my experience, I know that it's better that I do a cephalic delivery than a breech, because breech has almost double the chance of having more injuries. So that's why we say I can turn this baby under ultrasound guidance and do a external cephalic version and get a favorable head into the lower segment. And at term, there'll be a better chance of normal delivery without injuries. Even in a shoulder presentation, I can do the same. And that external cephalic version is successful in transverse lie in breech. If it is done under ultrasound guidance, we give some tocolytics also like Ritodrin, and by a senior obstetrician. Routinely in my hospital, we do external cephalic versions. All right. Now that is done at 36 weeks when the uterus is relaxed. And now the Liker is reducing because 32, 34 weeks the Liker is maximum, 36 weeks the Liker is reducing. So turning a baby, the chance of returning back are lesser, and the head of the baby is heavier, so the baby will stay turned. All right. So we have already discussed that in the Liker chapter, along with the antepartum surveillance chapter. We've already done that. Okay. Now let's move on and see where can you do internal podalic version. External cephalic version can be done in breech and in shoulder presentation. Internal podalic version is done for a transverse lie, but that also when it is a second of twin in transverse lie. Okay, so only indication of IPV, internal podalic version, second of twin in transverse lie. Why can you do in a second of twin? You want the uterus to be relaxed, and between two labors, first baby has come out and now the second baby is inside. For 10-15 minutes, the uterus is relaxed. You have all the time to go inside the body of the woman through the uterus. You can turn the baby by holding the legs and pulling the baby out. So, transverse lie, you can do internal podalic version and follow it up with a breech extraction. All right. You can write all of that. Now, let's move and see what you mean by a presenting part. So, the head or cephalic presentation may have three different parts which can be on the internal os. So what is presenting part? Part of the presentation at the internal os. So part of presentation at internal os. So depending on the attitude of the head, see if the head is flexed. If I show you this fetal head and if this head is flexed, so you see the vertex is the presenting part in this, and the lowest bone which you feel, if you do a PV in this patient, you will feel the occiput. Vertex is the presenting part and the lowest bone is the occiput. Now if the head is extended, then you see face is the presenting part and the lowest bone here is the mentum. All right. Now if the head is straight, not extended, if the head is straight like a military man, deflex head, so like a straight head, then brow is the presenting part and the lowest bone is the frontal bone, and the part which is felt when you do a vaginal examination in the brow is the supraorbital ridge of the frontal bone, which is also known as the glabella. Okay, the glabella. I'll be writing all of that, don't worry, that is all there in the list in the next few slides. So even better, I can show all of this on my head. So when the head is flexed, so you have the vertex and you see the lowest bone as the occiput. When the head is extended, it is the face and you feel mentum as the lowest bone through the vaginal examination. And when the head is straight, like a military man, straight, okay, deflex head, then you see the brow as the presenting part and the lowest bone is the glabella. Okay, so these are the presenting parts. Then what is the denominator? I already told you the lowest bone. So vertex in occiput, face it is mentum, and brow it's glabella. Already discussed that part. Let's move on. Denominator is important when we talk about positions in the pelvis. We'll come to that. Now, what are the diameters when the head is entering the pelvis? So when the head is entering in vertex, if you see the head is entering the pelvis in vertex, and if it is coming as occipito anterior or posterior, depending on that, what is the diameter of engagement? In vertex, the diameter of engagement is the occiput, suboccipitobregma. Okay, the anterior frontal suboccipitobregmatic. So this is the diameter. Okay, suboccipitobregmatic. So that is around 9.5. Now, when the head is extended in a face presentation, when the head is extended, so it is submentobregmatic. It is submentobregmatic. That is also 9.5. So tell me one thing, if the head is flexed, vertex is entering the pelvis, and you know this will deliver day in and day out, this delivers because the diameter is suboccipitobregmatic and that is 9.5. So this will deliver, you know, very well. Now when the head is extended, that is face presenting part, and submentobregmatic is the diameter. You know how much is submentobregmatic? 9.5. So remember, face also delivers. Face presenting part can have a normal vaginal delivery provided it is
The position is mento-anterior. We'll discuss about what is positions a little while later, but remember here itself that the face can deliver. Now, when the head is deflexed, when the head is in a straight position like a brow, this is the way the head is trying to enter the pelvis like a military man. I told you in the previous slide. And the diameter is mento-vertex. How much is mento-vertex? See this? Mento-vertex. The head is straight, deflexed. So, mento-vertex. From here, if you see, mentum to vertex, mento-vertical. So, mento-vertical is 14 centimeters. No diameter in the pelvis is 14 centimeters to accommodate. That is basically saying this head is trying to enter the pelvis like this. Okay, it will not even enter the pelvis. All right. So that is what is known as the mento-vertical diameter, and that is 14 centimeters. So for brow, you do a cesarean section. Classical MCQs. Okay, brow, you do a cesarean section. Now, whatever I told you, I said they're going to be a summary. So here it is once more for you. When the attitude is flexion, the presenting part is vertex, the denominator is occiput, and the diameter of engagement is suboccipitobregmatic, which is 9.5, and delivery shall happen. When the attitude of the head is extension, the presenting part is face, and the denominator is the mentum, and the submentobregmatic is 9.5. Delivery happens in here. Is normal, provided I told you it is mento-anterior. Okay, and then if it is deflexed head, then the presenting part is a brow, the lowest bone is the glabella, and the diameter is mento-vertical, 14 centimeters, and you do a cesarean section. So that's the summary of what all we discussed just now. Now, let us get into the cardinal movements of labor. So when we talk about the cardinal movements, we are talking about how a head gets into the pelvis and how it goes through the inlet, mid-pelvis and outlet, and what it does to align properly and get out of the pelvis without any problems, so that a baby is born without any injuries, and there are not any injuries to the mother also. So this wonderful process of normal vaginal delivery, you know, I have delivered babies as big as my personal biggest baby, which I have delivered, is 4.1 kgs, and that came out in an average sized woman. So this wonderful process of normal vaginal delivery, if you understand this, it gets extremely interesting. So let's go bit by bit. So what are the 7 movements, 7 cardinal movements? Often this question is asked in, you have to put all these 7 movements in the order of occurrence. So yes, first the head gets into the pelvis, that is engagement, then goes on getting deeper into the pelvis, that is descent. Flexion is always ongoing flexion in all these 7 movements. We say ongoing flexion, but if you want to put it somewhere in the list, then it is the third thing, the flexion. Then the head hits the pelvic floor where internal rotation happens. I'll explain you all of these individually. Then when the head comes out, it comes out with extension. See, the head is coming out with extension. See this? There is extension on the head. So head comes out by extension, and then when the head delivers, the correction of the internal rotation is known as the restitution, and then the head rotates externally because of the shoulders rotating in the pelvic floor. So that is the reason of the external rotation. We'll come to that once more. So let us see, for these movements to happen smoothly, all these 7 movements which I said, there should be a good alignment of the fetal head and the pelvic diameters. Then only this, there'll be engagement, there'll be descent, there'll be internal rotation, there'll be by extension, all that which I told you. So to understand the cardinal movements of labor and how it happens, let's go and understand the fetal head and the pelvis in some details and the diameters. So when we talk about engagement, the first cardinal movement, we say the rule of 5. The rule of 5 is that the fetal head is divided into 5 imaginary parts, and when most of it is inside the pelvis, if you see, this is the pelvic brim, the true pelvis, this is the false pelvis. The true pelvis is here, the lower arrows which I've drawn. So when the head is entering into the pelvis, we see the first diagram, we have divided the head into 5 parts. None of it is gone into the pelvis, so it is not engaged. Now you see in the second picture, only 1 part is gone and 4 parts are outside. But in the third picture, you can see that at the pelvic brim, if you see,
or if you feel the mother's abdomen through a antenatal checkup, then you'll see that more than 3 parts have gone inside and 2 parts are left outside. So when less than 2/5 head, when less than 2/5 head is palpable, when less than equal to 2/5 head is palpable per abdomen, we say engagement has occurred. Okay, that is what is engagement. So next is to understand what is descent. So when the head has to enter into the pelvis, engagement has to happen. Let us see this from a lateral view. So we are talking about the head of the baby which has to enter the pelvis. So this, let us say, is occipito-anterior. It has to enter into the pelvis here. So when the head is entering into the pelvis here, we will simply imagine, okay, this is a occipito-anterior. This is getting into the pelvis very easily, and this is a fairly, large pelvis for this small head of the baby. So now you see, this is the outlet. I'm showing you from the outlet wise. See, the head of the baby is entering the pelvis. See here, it's a occiput which is anterior, occipito-anterior. It is entering the pelvis like this. Now, when this is entering the pelvis, this is a flexed attitude, like I told you. And what is the diameter of engagement? It is suboccipito-bregmatic. How much is suboccipito-bregmatic? 9.5. Now, it is entering into the pelvis like this. So, when it is entering into the pelvis like this, what I'm trying to impress here, that this pelvis also should be accommodative of the fetal head diameter. The diameter which is getting into the pelvis is suboccipito-bregmatic. How much is that? 9.5. So this diameter from the top of the sacrum to the pubic symphysis should be more than 9.5, isn't it? So from the top of the sacrum to the top of the pubic symphysis, if the diameter is more than 9.5, the head will easily enter inside. So that's what I'm saying, that the fetal head parameters and the pelvic parameters should align or should be adaptive of each other for the baby's head to go into the pelvis and deliver out. So we are talking at the inlet, we are talking about the engagement right now, and we're talking about engagement. We spoke about the head diameters. Now let us see what is happening in the pelvis. So I'm trying to show you the pelvis from the top here. Now, to see these diameters, there is a slight problem. I said that from the top of the sacrum to the top of the pubic symphysis. Now, that is actually not the shortest. Try and understand. If the head has to go through the pelvic inlet, then the broadest part of the head should go through the narrowest part of the pelvis. Technically, the shortest part of the pelvis should allow the broadest part of the head to go through easily. Then only delivery will happen. So the diameter which is getting into the pelvis of the fetal head is suboccipito-bregmatic, which is 9.5. It has to enter into the pelvis. So the diameter of the pelvis should be more than 9.5. So which diameter are we talking? From the top of the sacrum to the top of the pubic symphysis? Not really. If you see this closely, at the back of the pubic symphysis, if you see this closely, there is a small elevation. That is the tubercle, the pubic tubercle on the back of the pubic symphysis. So from the top of the pubic symphysis to the top of the sacral promontory, it will be 1 diameter. But from the back of the pubic symphysis, once more, if you can see, there is an elevation. So it is very easy to understand that from the back of the pubic symphysis to the top of the sacrum, the diameter will be smaller. So yes, from the back of the pubic symphysis to the top of the sacrum will be lesser, and that diameter should be more than the 9.5 of the anteposterior diameter of the head, which is the suboccipito-bregmatic, which is entering the pelvis. All right. So now, all of that, let me show you here again once more. So I'm talking about the head of the baby, which is trying to enter into this pelvis and deliver. So this diameter, okay, I'm just not drawing in great detail here just to tell you. I'm just telling you it is suboccipito-bregmatic, which is the engaging diameter in vertex, and I told you it is 9.5. Now this diameter should be shorter than the narrowest diameter of the inlet. So which is the narrowest diameter at the inlet? So you can now make out that the narrowest diameter, yes, tell me the narrowest diameter, anybody? All of you. I mean, I can't ask you to give me answers on this forum. So yes, think and tell me which is the narrowest diameter here. So from the top of the
pubic symphysis to the top of the sacrum, the green diameter, is known as the true conjugate. But from the back of the pubic symphysis, you can see there's a tubercle here. If you can see, I'm drawing it in red now. So this diameter, the red diameter, is actually the shortest. So this diameter, okay, the fetal head which is entering the pelvis, that should be lesser than this red diameter, which is known as the obstetric conjugate. So obstetric conjugate is the narrowest anterior posterior diameter in the pelvic inlet, and from the lowest part of the pubic symphysis to the top of the sacrum, the sacral promontory, this in blue is the diagonal conjugate. Now, how can I show you this in the pelvis? What I'm trying to show you, I'm just going to tell you about this diagram once more, that this is what I was trying to show you from the top of the sacrum to the top of the pubic symphysis. Now, I've sliced the pelvis and I'm showing you from the left side. So yes, half of the pelvis from left side I'm showing you here in this picture. So the three diameters at the inlet, the true conjugate, the obstetric conjugate and the diagonal conjugate. These are the three diameters which you have to learn. Understand, we can measure only one of these. And which one of that? Yes, see, I'll show you here again. See, this is the pelvis, I'm showing you from the left. So, this cut half pelvis, I'm showing you from the left. So, which diameter can I measure in the OPD? So, this is the mother's pelvis. This is the mother's abdomen here. But we know we can get into the pelvis through the vaginal opening. So, when we get into the vagina, that is from the base of the pubic symphysis, I can put my finger and touch through the mother's pelvis. I can touch the top of the sacral promontory. So with my fingers, what diameter I can measure? Only the diagonal conjugate. I can measure the diagonal conjugate. So this is what is happening here. The diagonal conjugate, the blue one I can measure. So diagonal conjugate is mostly 12 centimeters in an average female pelvis. Now, what is the true or the anatomical? True or the anatomical conjugate is diagonal conjugate minus 1 centimeter to 11 centimeters. And what is the obstetric conjugate? It is diagonal conjugate minus 2 centimeters, and that is 10 centimeters. So now, which is the most important diameter at the inlet of the pelvis? It's the obstetric conjugate, the red one, and that in this calculation is coming out to be 10 centimeters. Now, this should be more than the anterior posterior diameter of the head which is entering the pelvis. What is that? Suboccipito-bregmatic. How much is that in the fetus? In vertex, it is 9.5. So 9.5 will go through this 10, and this inlet will allow the engagement. All right. So that is about the first part, the engagement, and I've discussed here with the pelvis also. Now, what do you mean by descent? The head should enter the pelvis and make its journey and come out also. So if you see the head, when it is entering, I'll try to show you again. See, this is the occipito anterior. It is entering into the pelvis like this. Now, it has to go inside and then it has to deliver by extension. So, engagement and then delivery by extension. So, this journey has gone through the inlet so far we have seen in the class. Now, it has to go to the mid pelvis and then come out of the outlet. So, now you see the mid pelvis, if you see from here, from the top, the mid pelvis is the narrowest part of the pelvis of the woman. So the narrowest part of the pelvis is the mid pelvis, and the narrowest diameter is between these two projections which you're seeing. These are the ischial spines. All right. The ischial spines. Now you can see here also the ischial spines. Ischial spines is this ischial spine is the shortest mid pelvic diameter, interspinous diameter, which is 10.5 centimeters. So yes, the descent of the head, we are talking about the descent of the head is seen in relation to the ischial spines. We always, when we do a per vaginal examination in the labor room, when we put our fingers, we feel the dilatation of the cervix, and we also feel how high or how low is the head in relation to this ischial spines. So when we put our fingers inside, my forefinger is feeling the head and my middle finger is feeling the ischial spines. So with that, I can make out the head is high, head is mid pelvis, or head is low. So ischial spine is the parameter of descent, and that is 0 station. Ischial spine is the parameter in
relation to this parameter, we say the head is very high or head is very low in relation to the ischial spine, the mid pelvis. Okay, so that's what we're trying to show you here about the descent, that when we are talking about the descent, the ischial spines will play the role. But before that, let us see around these ischial spines, there are two planes through which the head has to grow. There is a very roomy part of the pelvis, which is known as the plane of maximum pelvic dimensions. And then there is a plane below that, which is the plane of the least pelvic dimensions. So the head has to go through that. So let us see the planes of mid cavity. The plane of greatest pelvic dimension is from the mid part of the posterior symphysis pubis, from here, all right, to the junction between the second and the third sacral vertebrae, all right, and laterally it goes through the acetabulum and the upper part of the sciatic notch. So that is the plane of the maximum pelvic dimensions. Then below that is the plane of the least pelvic dimensions, which is from the base of the pubic symphysis, if you see here, to the tip of the sacrum, not the coccyx, okay, to the tip of the sacrum posteriorly, and laterally the ischial spines. So this is the plane of the least pelvic dimension. So I told you the narrowest part of the mid pelvis is the diameter, which is interspinous diameter, which also is the place where there is the plane of least pelvic dimension. So that's what I was trying to tell you in the pelvis in the previous slide, that the head has to go through this narrowest diameter, the interspinous diameter, and then, or also called the bispinous diameter. And then we know that the delivery chances are very good if the head goes through this. So these are the planes of the pelvis. And now let us see what happens when the head is trying to enter the pelvis and deliver. So now you can see the head is inside the pelvis and the ischial spines is 0 station. I told you this is the parameter in accordance to which we see the head is high or low. So how many stations are there? From the 0 station, you can see there are 5 stations above and 5 stations below. So these are the 11 stations for the fetal head, from -5 to +5. Now the spines is the 0 station, and above that there are 5, below that there are 5. So when the head is at +2 station, the lowest part of the head, that is in a vertex presentation, the lowest part is the occiput. When the occiput is at the +2 station, the broadest part of the head, what is the broadest transverse diameter of the head? See, if you look at me, my broadest part of the body, you will say are the shoulders, but that is because I'm a well-grown man. But when you talk about a fetus, in a fetus, the broadest transverse diameter of the body of the baby is the biparietal diameter. If you see the head of the baby here, you can easily make out, yes, you can see in a black background, see the biparietal diameter, okay, any way you see. The biparietal diameter is the broadest diameter of the fetal head. The narrowest transverse diameter is the bimastoid. The broadest is the biparietal. So if you imagine, if the head is coming down into the pelvis, occipito-anterior, and now when you feel the head with your fingers, so this is the occiput. Can you see? The biparietal diameter is here. The biparietal diameter, it will obviously be higher than the area of the occiput. The occiput will be the lowest, and the biparietal diameter will be higher, around 2 centimeters. So yes, when the occiput is at +2 station, this is the occiput is at the +2 station, the biparietal diameter, this diameter, the BPD, how much is that? 9.5 is at the 0 station. What is that? The interspinous diameter, ISD, also known as the bispinous diameter, which is 10.5 centimeters. This is 5, all right? 10.5 centimeters. So yes, when the head is at +2, the 9.5 broadest part of the baby is going through the 10.5 narrowest part of the mid pelvis. So in effect, what is the meaning? When I do a per vaginal examination of a lady when she's in labor and I feel that the head is at +2 station, then the broadest part of the baby has gone through the narrowest part of the pelvis. So after, at and beyond +2, at +2 and beyond +2 station, chance of delivery are very good. In fact, excellent chances that this woman will now have a normal vaginal delivery. All right. Now, after this, now let us see these diameters in detail. So when we talk about the inlet, I told you there are three major diameters, which is true, obstetric, and the diagonal. True is also known as the anatomical. It is 11 centimeters true, obstetric is 10, and diagonal is 12. And we know that we can only measure the diagonal and we derive the other two. So obstetric conjugate is the important one, and the pelvis is said to be contracted at the inlet if the pelvis has a obstetric conjugate of less than 10 centimeters. And it is supposed to be contracted if the diagonal conjugate measured is less than 11.5 centimeters. Now, at the mid pelvis level, I told you the interspinous diameter is the important parameter in relation to which we have these stations. So, interspinous diameter is 10.5 centimeters, and if it is less than 8 centimeters, we say it is contracted. Now, there's another diameter. What is that? From the interspinous diameter, which is 10.5, we also add the posterior sagittal diameter. Now, what is the posterior sagittal diameter? Posterior sagittal diameter is that this interspinous diameter, this 10.5, and from the midpoint, see, this is the interspinous diameter, and from the midpoint of this interspinous diameter to the tip of the sacrum, from the midpoint of the interspinous diameter to the tip of the sacrum should be at least 5 centimeters. So that is the posterior sagittal diameter. So the posterior sagittal diameter and the interspinous diameter together, if it is 15.5 and more, it is a good pelvis. But if it is less than 13.5, then it is a contracted pelvis. So after the mid pelvis, let's see the outlet. If you see the outlet of the pelvis, this is a diamond shaped outlet of the pelvis, and here we say the interischial, when we say it is the ischial tuberosities. The diameter between the ischial tuberosities should be at least 10.5 centimeters. So now, if this TDO, transverse diameter of the outlet, is less than 8 centimeters, again we say it is a contracted pelvis. All right. So these are some definitions which come in your exams. Now let's move and see what are the important fetal diameters. I told you from the head, I told you that there are three diameters which are 9.5. I said the suboccipitobregmatic. Suboccipitobregmatic is 9.5, this diameter. Then I told you that in a face, submentobregmatic, okay, submentobregmatic, this diameter, that is also 9.5. And then I told you the biparietal diameter, this from one parietal bone to the other parietal bone, this is also 9.5. So three diameters are 9.5. Now the shortest transverse diameter, if you see here, you will assume that the bitemporal diameter is the shortest. That is wrong actually. The bimastoid here, the bimastoid diameter is 7.5. Okay, and the bitemporal diameter is in fact 8 centimeters. So the shortest transverse diameter is the bimastoid diameter. Okay, so now we spoke about the engagement, the descent. Now what is internal rotation? Internal rotation happens at the level of the pelvic floor. So if I try to tell you that the uterus, if I show you with this remote here, that the uterus is organ in a big wide pelvis, and the uterus is exactly as broad as this remote. So this uterus has a big empty pelvis through which it can fall. So uterus, that's why has ligaments on the side, which we discussed in the chapter of prolapse, that there are these round ligaments, Mackinaud ligaments, and the uterosacral ligaments. There are three good ligaments which are supporting the uterus. But out of ligaments, the good ligament is the transverse cervical or the Mackinaud. It is a good ligament. But what about the base of the pelvis? Can you see? Although the ligaments are suspending the uterus in the pelvis, the base of the pelvis, can you see, it is such a big open wide pelvis outlet. So this pelvic outlet is so big through which any uterus is going to come out and have a prolapse. So that's why the outlet of the pelvis is covered by muscles like this. Now if you imagine my hand like this is the vaginal opening. I'm not showing you the anal opening now with this demonstration here. I'm trying to show you that this is the vaginal opening, which is actually a opening in the floor of the pelvis. So my hand, I'm trying to show you as the muscles, which are actually the floor of the pelvis. Can you see? Now this is the floor of the pelvis. The muscles, the levator ani. So the uterus is going to hit on this floor and not come out. So the best support of the uterus, is the pelvic floor. This pelvic floor, all right. Now that was quick anatomy revision. Now this is the pelvic floor, which is the best support of the uterus, we know. But what happens in labor? When this head comes and hits the pelvic floor, the law of pelvic floor is that whatever hits the pelvic floor, it will rotate. Why will it rotate? Because these pelvic floor muscles will contract. So whatever hits the pelvic floor, it rotates. So yes, suppose this head of the baby is in occipital anterior and the occiput is a little bit towards the left. We'll be discussing positions a little while later. So when the head is towards the left, see, the occiput is towards the left. So this is left occipital anterior. So when the left occipital anterior hits the pelvic floor, there is a internal rotation and the head becomes occipital anterior directly, and then it delivers by extension. All right. So that is what is internal rotation. Internal rotation happens at the level of the pelvic floor. The pelvic floor, also known as levator ani. So what are the muscles of the pelvic floor? From the pubis, see, this is the pubis, to the rectum, puborectalis. Then from the pubis to the sacrum, pubococcygeus. Okay, precisely the coccygeus. So we call it the pubococcygeus. And then from the ilium to the coccyx, iliococcygeus. So these three pairs of muscles give a support to the organs in the pelvis. That's why it is known as a pelvic floor. Now rotation happens at this pelvic floor. Okay. Now what is delivery by extension? I showed you many times that when the head comes out, it delivers by extension. But whatever happened, the internal rotation now has to be corrected. Let me explain you. Imagine my, I'll try and show you with my hand. This is the head of the baby. My hand is the, let's say, the shoulders of the baby. Now the head has entered the pelvis with occiput towards the left. So I said, when the head hits the pelvic floor, there is a rotation. So what is happening? Internal rotation. See, there's a rotation in the neck of the baby. There's a turn in the neck at the pelvic floor. Moment the head delivers by extension, this head will correct the internal rotation. See, it is gone back to its favorable position. Once more, the head enters the pelvis as left occipital anterior, hits the pelvic floor and rotates to become direct occipital anterior, delivers by extension. Now the turn in the neck which happened, that will be corrected. So this is known as restitution. Restitution. This is not external rotation yet. Now the shoulders will hit the pelvic floor. Look at my hand. I'm showing you my hand as the shoulder. Now the shoulders will hit the pelvic floor, and moment the shoulders hit, the shoulders are rotating on the pelvic floor. See, when the shoulders are rotating, there is rotation of the head outside. So that is known as external rotation. Once more, in a quick succession, we'll show you. The head comes as left occipital anterior, hits the pelvic floor, becomes direct occipital anterior by internal rotation at the pelvic floor. Delivery is by extension, and now the head will correct the turn in the neck, restitution, and now the shoulders will hit the pelvic floor. The shoulders will also rotate at the pelvic floor, which causes external rotation of the head of the baby. All right. So these are the movements which I was trying to tell you. We started our discussion with the cardinal movements of labor, and at every step, how these cardinal movements are brought about, I am trying to tell you about the pelvis and the head. So we are now at internal rotation, which happens at the level of the pelvic floor. Then the delivery is by extension, and after extension, I said restitution. Restitution is the correction. It is the correction of internal rotation. And then when the shoulders hit the pelvic floor, rotation of shoulders at pelvic floor, that causes the external rotation, and that is the last cardinal movement. Of course, after the external rotation, there is delivery of the anti-shoulder. Generally, you hold the head of the baby and give a downward tug to the neck of the baby, and with that, the anti-shoulder is delivered. So that is next, but the cardinal movements are till external rotation. Now, let us see what is the meaning of position. Now, position of the baby in the pelvis is dependent on the location of the denominator. So the denominator in face is the mentum. So mentum could be anterior in the pelvis or posterior in the pelvis, or it could be vertex. So what is the denominator in vertex? It is the occiput. So occiput could be anterior or posterior. So I have already showed you occiput or posterior partly in the previous slide. We'll see in more detail. See if the head is having a face presentation and the mentum is anterior. So this is what is mento anterior. This is what is mento posterior face. This is mento posterior. This is mento anterior. All right. So we are talking about occiput now. So position of presenting part. What is presenting part? It is the vertex. What is the position? Depends on the lowest bone of the presenting part. What is the lowest bone? This is the presenting part. It is the occiput. The lowest bone is the denominator. So lowest bone of the denominator, or lowest bone or the denominator, here is the occiput. Now let us see example number 1. Here it is showing that the head is having the occiput a little bit towards the left. Okay, see here the first picture here. Let me just name it first, second, third and fourth so that there is no confusion. First, second, third and fourth. Anterior part of the pelvis, posterior part, you can make out this is the sacrum, this is the pubic symphysis here, and this is the head of the baby. This is the occiput. How do you know it is the occiput? Because there are 3 bones. Here we can see the, why do I confidently say that is the occiput? You can see that there are 3 bones, the occiput and the 2 parietal bones. When they meet, there is a triangular fontanelle. It is known as the posterior fontanelle. So when I feel a triangular fontanelle, I know it is the posterior part of the head which is felt. So posterior part of the head, I go and feel this, I know it is the occiput. Sometimes when I feel 4 bones, see the 2 parietal bones and 2 frontal bones, they will meet and make a quadrilateral fontanelle, which is the anterior fontanelle. So anterior fontanelle is 4 bones. So when I feel a quadrilateral fontanelle, 4 parts, then I know it is the anterior part of the head which I am feeling through the vagina of the mother. So yes, now when I feel this occiput in the anterior part of the pelvis, what is the position? That's what I'm trying to teach here in this picture. So let us say picture number 1. In the picture number 1, you see this is the right. We are talking about the anatomical right and left. Okay, when you're looking at this screen, you will say my right is this. So we are not bothered about your right. We are bothered always in your life, make a principle, anatomical left and anatomical right. Whichever CT you see, whichever MRI you see, and whichever part of the body of a human you say, you always say the anatomical right and anatomical left. So yes, this is the right part of the pelvis and that is the left part of the pelvis. This is the anterior of the pelvis. Okay. So now if you got the orientation, let us see. In this first picture, you are seeing the occiput towards the left. So this is left occipito anterior, the first one. Now let's see the second one. You're seeing the occiput like this. Okay. So this is the occipito transverse towards the left. Left occipito transverse. Can you see picture number 3? Here you're seeing the occiput towards the right here. So this is right occipito anterior. Okay. And in the last picture, you're seeing the occiput towards the right, but in the posterior part of the pelvis. So that is the right occipito posterior. So these are the 4 positions which I wanted to show you here. So please remember this left occipito anterior is fairly common, but left occipito transverse, this is the most common position of vertex presenting part. Then the third one here is the right occipito anterior, and the fourth one is the right occipito posterior. It is the most common malposition. Please, this is what is solid exam question, especially for the MCI students. Yes, NEET people have been asked this many times, but MCI, I'm seeing every alternate exam this question coming, right occipito posterior. Please, occipito posterior is the most common malposition, but on which side? Towards the right side. Okay, so this is what is the meaning of positions. Now, let us move and see the left occipito anterior. This is the one of the common ones which I showed you, and I showed you the example also that this left occipital anterior which will hit the pelvic floor, have an internal rotation, delivery by extension, then restitution and external rotation. Okay. So let us put all of this information in a pelvis which we see in labor. So there are three major types of pelvis which we encounter, but yes, the fourth one is also rarely seen, the platyploid. Generally we see the gynecoid, anthropoid and the android. So platyploid is the rarest type of pelvis where you can see the pelvis is anteroposteriorly compressed. So yes, you see the force of contraction in this pelvis is anteroposteriorly, so it is anteroposteriorly flat. So in a flat pelvis you see face presentation, flat for face, and face will deliver with, if the face is mento anterior. I showed you a position just now, mento anterior face will deliver. Okay, mento posterior will not deliver till it rotates and becomes mento anterior. So mento anterior in flat pelvis, platyploid pelvis will deliver. I told you the diameter of engagement is submentobregmatic. Third time in this rapid revision itself, I am telling you that it is 9.5. Now, let us see a little bit more detail about these three common pelvis. The most common pelvis of women is the gynecoid, and the second most common MCQ is the anthropoid, and the third type is the android. Now, in all of these three, please see the peculiarities that the gynecoid pelvis is nice and round cavity. This is the female pelvis. Now, in the anthropoid, you can see the side walls are parallel. Okay, the anteposterior diameter is longer, but the side walls are parallel to each other. So yes, in this one, anthropoid, the second most common type, you will see a occipito-posterior position of the head. Now, android has the front walls, the anterior part of the pelvis is converging, male type of pelvis. So see the force of contraction in all these pelvis. A flat pelvis, anterior posterior contracted, so it's a flat pelvis. And anthropoid pelvis, side walls are parallel and they are long and parallel, so there is not much space to move around in this anthropoid pelvis. And android pelvis, the front part of the pelvis is converging. All right, so there's the force. Now, why am I telling you? Because in all of this, occipito-posterior becomes your most favorite malposition which is asked. So let us imagine that this arrow is the occiput. We are showing you three. This fourth type, flat pelvis, we've already discussed. Face presenting is the presenting part, and they can be a delivery. Now, gynecoid, suppose, has an occipito-posterior, anthropoid has occipito-posterior, and android has occipito-posterior. What all can happen? That's what we're going to see. In a gynecoid pelvis, you see, if I'm imagining that this is the posterior part of the pelvis, because this is the the sacral promontory, this is the posterior part of the pelvis, here in these three, and the arrow is the occiput. So if you say the arrow is the occiput, then this is occipito-posterior, occipito-posterior, occipito-posterior. If there is an occipito-posterior like this occipito-posterior. So if you see the occipito-posterior in the gynecoid pelvis, when it hits the pelvic floor, it can rotate and then rotate like this, and this is going to have a complete rotation, and a occipito-posterior will hit the pelvic floor and become anterior in 80% of occipito-posteriors. So yes, this is what happens in 80%. 80% will have rotation. Rotation is possible to occipito-anterior. All right. So if there's occipito-posterior, in a case of gynecoid pelvis, it will rotate to occipito-anterior and deliver normally. Now, let us see in a anthropoid pelvis. So the side walls are parallel, so there is not much place to move. So this rotation does not happen in a case of occipito-posterior. So please remember, in a occipito-posterior with anthropoid pelvis, there is no rotation possible. There is no rotation possible in a anthropoid pelvis. So the fetus persists as occipito-posterior.
which is around 15 to 16% cases of occipital posterior. It persists as occipital posterior. So if it is occipital posterior, then delivery is by phase 2 pubis. Delivery by phase 2 pubis. So phase 2 pubic or phase 2 pubis delivery. That's what I'm trying to say. Now look here. If you see, this is the occiput, and normally in occipital anterior, the head delivers like this. So obviously you can make out if the occiput is anterior, faces towards the back of the pelvis. Okay, it's towards the sacrum. Now, if there is a occipital posterior, that's what I was trying to show you. If this occipital posterior towards the right, the most common mal position. When there's an occipital posterior which is towards the right, it will hit the pelvic floor, the levator ani, and the law of the pelvic floor will make the head rotate 3/8 of a circle, and this will become occipital anterior and delivery will happen. But that will happen only in a gynecoid pelvis. So occipital posterior, the right occipital posterior hits the pelvic floor, becomes occipital anterior, delivery is possible. Now, sometimes this occipital posterior does not rotate. This occipital posterior does not rotate to anterior. It stays occipital posterior and it becomes directly facing the sacrum. It stays, becomes direct occipital posterior. Now, it's not that it will not rotate, so it will not deliver. It is not rotated, but it will go on delivering. It will go on coming out. So the head will deliver in this occipital posterior. It stays occipital posterior, but it will deliver, and it will again deliver by extension. But now can you see the occiput is posterior. So what is facing the symphysis pubis? You can see when the occiput is posterior, the face is facing the symphysis pubis. So where do you see face to pubis delivery? Where do you see face to pubis delivery? You see in a persistent occipito posterior. Okay. So it stays occipital posterior, also known as persistent occipital posterior, and delivery is by face to pubis method. Okay. Now the third method is the occipito posterior in a case of android. So android pelvis will rotate this much, and this baby will now become occipito transverse. Now, since the four walls are narrow, it will not rotate completely. So here I'm trying to show you, it's a case of occipito posterior and it has rotated to occipito transverse. See, it's a case of occipito posterior. I'm trying to show you without the pelvis. It's a case of occipito posterior. It's rotated to occipito transverse. Now it cannot rotate more because the pelvis is narrow. So now you will hold the head of the baby with your hand as a doctor, and you will rotate the head and make this head occipito anterior. So we do a manual rotation. Okay, a manual rotation, and then apply forceps and take the head out, because moment you do the manual rotation and leave it, it'll go back to occipito transverse. So you do a manual rotation towards anterior and deliver by forceps. So that is what is known as the manual rotation forceps extraction. So in a case of android pelvis, rotation to occipito transverse, then complete delivery by manual rotation forceps extraction, MRFE. But yes, if this when it rotates to occipito transverse, and if this is neglected, suppose if this is neglected, she was in a village in occipito transverse and she was not progressing in labor, and she is brought to your hospital after being 3 hours in the second stage, and you see now the pelvis is having a fetal head in occipito transverse, and the head is totally dry because the liquor being run out, and it is edematous, and you cannot hold the baby and turn because the head is deeply stuck in the pelvis in a transverse. So that now we call it a deep transverse arrest. So if it is neglected and it turns to be a deep transverse arrest, then do a cesarean section. Otherwise, if you see that it is occipito transverse after part rotation from occipito posterior, then you can complete the rotation with your hand, which is known as manual rotation and forceps extraction. So that is about occipito posterior, your most common mal position. Now, what is the most common mal presentation? Most common mal presentation.
3% of all pregnancies at term are breech, and that is the most common malpresentation. So be careful. Most common malposition, most common malpresentation. Malposition is occipito-posterior, malpresentation is breech. All right. So breech can be flexed legs. So this is known as a flexed breech or a complete breech. Now here the legs are extended. Can you see the legs are extended? So this is known as the extended breech, which is also known as the frank breech. And here you see one leg is outside the vagina and one leg is flexed inside. So this is known as a incomplete breech or a footling breech. All right. So most common breech, the most common breech is the frank breech, and the best for vaginal delivery, is this frank breech. So I'm the happiest when I want to do a breech vaginal delivery. I'm the happiest if I see a frank breech. Now flexed or the complete breech will also deliver. This will also deliver, but the frank breech or the extended breech is the best one. Remember, flex will also deliver. But when you see a footling breech, do a cesarean section. Footling will have many complications, especially of the cord. So don't do a normal delivery. So we do a cesarean section. Now, what is the method of these deliveries? When you're doing a flex or an extended breech, whichever breech vaginal delivery you want to do, the method is assisted breech vaginal delivery. That means do not touch the fetus till the breech and the legs are out and the abdomen has delivered till the level of the umbilicus. No touch till umbo. And then you start doing the maneuvers for the aftercoming head and the extended arms and the extended legs. I've not seen that coming in any exam, so I'm just skipping it in this rapid revision. Just remember, assisted breech vaginal delivery is the best, and you can do for the extended arms, you can do the love set. For the extended legs, you can do the pinards, and for the aftercoming head, you can do the Mauritius Mélivier, or you can use the Piper's forceps, or you can do the Bern-Marshall technique. So these techniques I have not seen coming in any exam, so I'm just skipping it for the time being. Of course, we can always read about them in the full section of the app. So let's move on and see what happens when the head is extended like this. It's a horrible picture which I've made, but I'm trying to show you the arms and the legs are flexed, but the head is extended like this. And if this extended head is there in a breech presentation, so please remember, I'm going back to the previous slide, that when I asked you which is the best for the vaginal delivery, the extended breech means legs are extended. So extended breech is best for the vaginal delivery. And this is also the most common type of breech. But I did not mean extended head. So on the ultrasound, if you see the extended head, this one, then when it is entering the pelvis, see, I'm trying to make a pelvis roughly like this. When it is entering the pelvis, see, pelvis has many diameters through which the head has to go. So when there is a breech, then these diameters will be encountered when the head is coming after the full body is gone through. So the buttocks and the legs are out, the back is out, the hands are out, the neck is now somewhere in the pelvis, and the head is at the brim. So in an extended head, you can imagine that this chin may get stuck into the symphysis and this head may get stuck in the sacrum. So that's what happens. You may pull the complete baby out, but the head will stay back above the pelvic brim. So extended head, you may lose the child. The baby may die because of a constant pulling and the head is extended. So if you see extended head in breech presentation, there is a breech presentation with the extended head. This is known as a stargazing sign. Stargazing sign, looking at the stars, looking up. So if you see this, please do a cesarean section. We are going to deliver a extended breech. This extended head in a breech presentation, do a cesarean section. All right. So let us see something about monitoring the progress of labor. The best method, best assessment of progress of labor is made by the partogram. Now, partogram by the WHO, the World Health Organization partogram, the modified partogram is the one which is used now. And this is the best assessment of progress of labor. It works as an early warning system that if all the parameters are in place. See, what are we doing when a patient is in labor. We're examining her every 2 hours. What is that examination? The per vaginal examination. But half hourly, we are seeing her pulse rate and her blood pressure. We are seeing the fetal heart rate every 15 minutes to 30 minutes. We are seeing the uterine contractions, and we are seeing if there is any molding of the head, and if there is any problem with the uterine contraction, we can increase the oxytocin. We are seeing the urine output of the pregnant patient, and also if she's having fever. So all of that is put into one chart. So when I go to the labor room as a consultant, I'm taking rounds, and my residents are, doing the examination of this patient very regularly, and they made a chart. Suppose there are 10 patients, they made a chart. One look at the charts, I can decide that, okay, this first patient, she's progressing well, continue. The second patient, the contraction is not looking good. The descent has not been very good. So I expect 1 centimeter dilatation and 1 centimeter descent with every 1 hour. So in 2 hours, this should be 2 centimeter dilatation and 2 centimeter descent. Very simple logic. I'm seeing this patient, it is not happening like that. Okay, increase oxytocin, the contraction is not very good. Other patient I see, they have very good contractions. The cervix is not dilating properly. The descent is the same. The head is at the same position for the last 2 hours. So descent is bad and the dilatation is not good in spite of good uterine contractions. This patient is probably having a cephalopelvic disproportion. Go ahead and do a cesarean section. So one look at the charts and I can make a decision. So it works as an early warning system, and we can take decisions of augmentation, transferring the patient to a higher center if required, or even doing a cesarean section. Remember, a partogram reduces the incidence of prolonged labor. That especially has a bearing on the incidence of PPH. Reduce PPH because of a good monitoring of the patient. Obstetric labor is reduced, and so is uterine rupture and puerperal sepsis. So when we see this WHO partogram, the modified partogram, the name and the gravida and the time of admission, rupture of membranes, all of that, hospital number and all is mentioned there. So in this partogram, we are going to see so many things: the fetal heart rate, the dilatation and the descent, and the contractions of the uterus, oxytocin given, the drugs given IV to the mother, and the pulse and the blood pressure of the mother, and the urine. But we have not seen the respiratory rate. So that one question came, which of the following is not in the partogram when we are doing this monitoring? So yes, the normal heart rate of a baby, all of us know, is 120 to 160. So see here, there is a darkened at 100 and 180. So anything less than 100 and more than 180 is distress. So let's say the heart rate is 140, and then another half an hour later 140, now it's gone to 150 like that. So this is the heart rate charting. And then we see the amniotic fluid. If it is clear, meconium, we see that. And we can see the molding. If it is 0, no molding, by the end it is grade 1, maybe it can go to grade 2 molding also. That is how much the head is trying to adapt into the pelvis. If it is the frontanels are wide separated, no molding. If they're touching each other, it is grade 1 molding. If they're overlapping, grade 2 molding. So grade 2 molding means the head is trying its best, it is overlapping the bones and it is gone into the pelvis. So that means the pelvis is a little small for this head. So maybe I may end up in a cesarean section because of the grade 2 molding. So that is the molding. Then we see the cervix, the cervical dilatation, and we see the station of the head. So cervix is plotted in this axis here, and the descent is also plotted in the same axis. So 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 is the cervical dilatation. Now at 5, look, I'm not saying when there is 5 centimeter dilatation, the head is at 0 station. I'm saying that the 0 station is plotted at 5. If there is 0 station, it is plotted where the 5 is in this 0 to 10. Where the 5 is, the 0 station is plotted there. Okay, what I tell my interns, there are 11 stations, and -5 to +5, just write them here on this side of the chart so that confusion is less. So -5, -4, -3, -2, -1, 0, +1, +2, +3, +4, +5. See, they are the 11 stations. So if you have any confusion, now you can see what I was saying. The 0 station is coinciding with the 5 here. See, that line is a little light in color also. So that is the station. So how do you mark the station and how you mark the dilatation? Dilatation is marked by an X and the station is marked by a 0. Okay, by a O actually. Then we see the contractions and we see how the contractions are. The contractions can be mild, moderate or severe. So it depends whether you want to put a dot in the contraction, or you want to shade, or you want to darken it. Darkening means, see, this is mild contractions, then these are moderate contractions, and these are strong contractions, like that. This whole thing is shaded. That means it is strong contractions, mild, moderate, and severe. So how many contractions are there? I told you 3 contractions are there every 10 minutes. So see, 3 contractions in 10 minutes. Contractions are mentioned every 10 minutes. And they can be 5 contractions in 10 minutes. I said 3 to 5 when I was discussing the labor definitions with you, the Friedman graph when I was discussing in rapid revision. More than 5 is tachysystole. So we stop the oxytocin and in fact give terbutaline so that there's no fetal distress. We relax the uterus temporarily. So tachysystole should not happen. So contractions are around 3 in this patient. So this is mild when it is dotted, moderate when it's shaded, and totally darkened is good contractions. Then oxytocin can be 8 drops, 16, 16, 32, whatever method of drops or whatever methods of units you are using, you can mark it there. And the IV drugs given to the mother, normal saline, she's getting dehydrated, give her dextrose 5%, like that. And then the pulse rate and the BP, 150 by, let's say, 90, 150 by 90, then 140 by 80, 140 by 80. So this is the graph of the blood pressure. And then we have the pulse rate also. The pulse rate also can be like this, 70, 70, 70, 90, 90, like that. So pulse rate will be like that. And then temperature and the urine protein, acetone, and volume of urine. All of that is plotted in this partogram. All right. So how can we see the progress of labor that is required? We will chart all of this with time. So suppose she comes to the labor room at 6 p.m. So 7, 8, 9, 10, 11, 12 a.m., 1 a.m., 2, 3, 4, 5. Can you see? Exactly 12 hours it is. So we start the plotting of the partogram only when she is at 4 centimeters here. That is known as the active phase of labor, 4 centimeters and beyond. And we are still staying at 4 centimeters. There is a controversy which we discussed earlier in the class that it can be 5 by the new WHO guidelines, it can be 7 by the American guidelines, but the government of India has not given any strong recommendations yet. No changes of monitoring have been described in the medical colleges so far. So we are staying at 4 centimeters as the active phase of labor. Now, let us see, at 6 p.m. she was having a cervical dilatation which was 4 centimeters. So we mark it like this. Then we do another PV at 8 o'clock and there it was 8 centimeters. Next PV I do at 10 o'clock, there it was 10 centimeters. So this is how the cervical dilatation progressed. Now, at the same time when I did the per vaginal examination, what was the station of the head? The station of the head at 6 o'clock was at 0 station, and then at 8 o'clock it was at +2 station, and at 10 o'clock there was delivery, so it obviously have to be +5 station. So this is how the station came down. So we can see the cervical dilatation has gone like that. The station has come down like this from 0 to +2 to +5. So this is how the partogram is plotted. This is a perfect progress of labor. Why? Because there is an alert line which is at 4 centimeters till the top of the graph, which is made. So the crossing of the dilatation and the descent is above this alert line. So this is a good graph. And then 4 hours later is the action line. That is, when is the alert? Where is the alert marked? From 4 centimeters to the top of the graph. And then 4 hours later is the action line. So all of that is, all the progress of labor of this patient has managed before the alert line was touched. Sometimes it may be a very delayed dilatation and a delayed descent and things are not working properly. So we increase the oxytocin. But here you see, if the oxytocin is given good and the contractions are very strong and still there is no dilatation, and there is, important ones are always the hematological and the cardiovascular changes. So let's start with the hematological changes. We know that in a pregnant patient, the hemoglobin drops. Let's say if she's 13 grams before pregnancy, she may become around 11 grams in pregnancy. Now, why does that happen? There's a simple illustration here.
all of us know the RBCs in pregnancies will increase, the fluids in pregnancy will also increase. But in proportion to the RBC increase, the fluid increase is much more. So that's why there is net hemodilution in pregnancy. That's why the HB drops. Now, when there is this net hemodilution, it is beneficial for two things. That it is good for the placental perfusion, because the placenta is going to be a very small organ in the early days of pregnancy, and through those thin vessels, thin blood will easily go through. And if the blood is thick, high hemoglobin, then there could be clumping of the RBCs. So that's why we say it's good to have thin blood in pregnancy for a proper placental perfusion. Also, when there is thin blood, whatever blood loss happens in delivery, look, even if you do a good management of and prevention of PPH, there'll be still some blood loss, isn't it? So it could be 200 ml or 300 ml of loss. That loss is more fluid than RBCs. So more fluid loss in labor, more fluid than RBC loss in delivery. All right. So there is a decrease in the red cell concentration. There's a decrease in the hemoglobin concentration. Hematocrit also reduces. Look, hematocrit is, 1/3 of hematocrit is hemoglobin value. So if somebody's hematocrit is, let's say 33, then divide by 3, the hemoglobin will come 11 gram %. So this is a very practical thing we keep using in the wards when we're working up patients. So all of these will reduce in pregnancy. What increases? The coagulation factors increase in pregnancy, like fibrinogen and total leukocyte count and the erythrocyte sedimentation rate. So all clotting factors increase in pregnancy except 11 and 13. NEET exam, EAMCET exam, both questions came. Now, non-pregnant women, the fibrinogen factor 1 is around 300 milligrams per deciliter, and in pregnant women, it will increase to around 450 milligrams per deciliter. Cardiovascular changes, all of us know that the cardiac outputs will increase in pregnancy. Now, remember this chart by heart. If you can't remember the whole thing, remember this. In the antenatal time, 7.1 liters per minute is the cardiac output at around 30-32 weeks. So when is the cardiac output maximum in the antenatal time? Around 30 to 32 weeks. All right. Now, in labor, in the second stage of labor, it is still more, 8.9 liters per minute. And after delivery, first 24 hours, it will be still higher than the labor and antenatal. It will be 9.3 liters. So please be careful of the questions which come in the exam. The language in the exam is always very clear. So when they ask you, when is the cardiac output maximum in the antenatal time? Around 30-32 weeks. When is it maximum throughout the pregnancy and delivery? It is in the postnatal time when it is most highest. That is 9.3 liters per minute. So related to this, they also ask you this question: when does a patient who's got a cardiac disease, when can she go into failure in the antenatal time? Again, 30-32 weeks. When can she go into failure? Most likely antenatal, during delivery or after delivery. Postnatal, when the cardiac output is still higher, 9.3. So that is actually increase of 70%. 70% increase in the cardiac output. And this is around 50% increase in the cardiac output. All right. So what else happens in the cardiac changes? There could be a loud and easily heard third sound. The third sound, the S3, is due to the rapid filling of the left ventricle. So that's the S3, which can be heard in pregnancy. Exaggerated splitting of the first sound, also normal physiological phenomena in pregnancy. Heart rate increases 10 to 20%, stroke volume increases 10%. What is reduced? The mean arterial blood pressure is reduced, and so is the peripheral resistance. NEET guys, please, NEET PG students, remember this one. This has come as a MCQ. Now, also one more thing. When does the heart rate come back to normal? See, all of us keep thinking about the increase. Yes, cardiac output increases. Yes, heart rate increases. When does both of these? Yes, we'll be discussing in pure parent some of these things. But remember, heart rate and cardiac output, when does it normalize? Normal values. When does it come to it? Normal values. Yes. When does it come back to its normal? Don't say 3 months. Don't say 6 weeks.
it is actually 10 days. It comes back to normal in 10 days after delivery. So, what happens in the respiratory system? Now, remember, there is no increase in the respiratory rate. Very important. Heart rate increases, cardiac output increases, but respiratory rate in pregnancy is the same. Now, there is reduction in the functional residual capacity. The FRC is reduced. So, that is FRC is the net reserve we people have, like when you are holding your breath and suppose you're underwater and you hold your breath for let's say 1 minute. Why are you still alive? Because of your FRC. So, that is the personal scuba tank of a person. Okay, so that human's personal scuba tank is now reduced in capacity in pregnancy, but the inspiratory capacity increases. So what is that? Inspiratory capacity will increase, FRC will reduce. So therefore, total lung capacity, that is the addition of FRC plus IC, FRC plus inspiratory capacity is the total lung capacity. So that total lung capacity in pregnancy is unchanged. That's why you can see pregnant mothers when they're walking, they look very tired, but they're not hypoxic. You do the pulse oximetry, they'll be 100% saturated or maximum, it'll be 99. So the inspiratory capacity is increased to compensate for the loss of the FRC. So total lung capacity is the same in pregnancy. Now vital capacity, there is no change and there is increase in the tidal volume by 40%. Then what happens to the gastrointestinal changes? Now see the gut overall. Remember small gut, large gut. We know that everything slows down in pregnancy because of progesterone. So yes, the large bowel motility is reduced. Patients are constipated in pregnancy, agreed. But the stomach gastric emptying time is unchanged. I've written William says so that you don't, contradict me much, because a lot of your books, and especially anesthesia books, say that gastric emptying time is increased in pregnancy. No, it is still 4 hours in pregnancy. And since it is in Williams, please remember in your exams, if it is anything related to pregnancy, the OBS books become the authority. So please, gastric emptying time is unchanged in pregnancy. Motility of the large bowel is diminished, so there is constipation. Also, the progesterone causes the reduction of the bile movement in the liver, so there could be cholestasis. So because of this intrahepatic cholestasis, there could be pruritus gravidarum. Why is there pruritus gravidarum? Because the retained bile salts under the skin, when they're there, they cause a lot of itching. Bile salts itch. That's my way of remembering. Bile salts itch. My Hindi speaking friends can at least remember bahut sari itching. I wish I had a Tamil expansion to that mnemonic, but remember bile salts itch. Okay, don't say bile pigments, don't say bile acids. In your exams you tend to get confused sometimes. Okay, bile salts itch. Now, what are the endocrine changes? The pituitary becomes bigger in size. It is the estrogen stimulator hypertrophy, and this increase in the pituitary is almost 135% in the comparison of a non-pregnant patient's pituitary. Now, TSH levels decline in pregnancy. Remember, 80% of women, the TSH levels will reduce. That is because the pregnancy itself starts to make TSH like alpha unit of HCG. So that alpha unit stimulates the thyroid to make the thyroxine. So naturally, there will be a good feedback to the brain and the brain will reduce the TSH. All right, I'll try to show that in a diagram to you guys. Let's see. Normally, we know the hypothalamus stimulates the pituitary by the thyrotropin releasing hormone, and that pituitary will release the thyrotropin. Now, thyrotropin is what is also known as TSH. So now let's see this in detail. Hypothalamus stimulates the pituitary by the thyrotropin releasing hormone. So thyrotropin releasing hormone will release what? Thyrotropin. So thyrotropin is what is in fact known as the TSH, thyroid stimulating hormone, or thyrotropin. Now TSH will be acting on the thyroid gland. This is the thyroid gland which I made like this, and that will release the thyroxine. So this is the normal production of thyroxine. Now what happens in pregnancy? The placenta is a unit which starts making the HCG. Now see here that the HCG has two subunits, the alpha HCG and the beta HCG. Alpha HCG has a common structure with so many other things. Alpha HCG is same as the alpha LH, and it is also the same as alpha TSH. So when the alpha subunit of pregnancy is alpha and beta both will increase, but the alpha subunit of HCG is the same as the alpha subunit of TSH. So this alpha HCG starts working as the TSH. So this alpha HCG will go directly stimulate the thyroid gland and start making more and more thyroxine. Now this will give a feedback to the brain. The brain will be satisfied that there is enough thyroxine in the circulation, so TRH will reduce and consequently TSH will reduce in early pregnancy. So that's the understanding of what I was telling you in the previous slide. What happens to the changes of the uterus in pregnancy? So if this is the pubic symphysis, the uterus comes out of the pelvis into the abdomen at 12 weeks. Then the uterus comes to the level of the umbilicus around 24 weeks, and after that it comes to the level of the xiphisternum at 36 weeks, and after that it will fill up the flanks and the height will actually drop. These flanks of the abdomen will start getting filled up, so that height will reduce at 40 weeks. So this is how the pregnancy is increasing normally, the uterine size in pregnancy. Now, this is how it increases in pregnancy. What happens after delivery? See, the uterus is so large and the uterus has contracted and the baby has come out. So this uterus here, the uterus will now suddenly will be without the baby. So uterus will contract and will come and rest around at the level of the umbilicus. So after delivery, in the puerperium time, so after delivery, you will see the uterus at or just below the level of the umbilicus. So this is at delivery. Now, this has always been a matter of very common MCQ exam, that when the uterus is at the level of the umbilicus, we can make an incision on the abdominal wall, and with this incision we can easily reach to the sides of the uterus and we can ligate both the tubes and do a tubectomy, because the uterus is an abdominal organ. So uterus is abdominal organ. Small mini laparotomy, a small mini laparotomy incision can be done, and through that we can get both the tubes and do an easy ligation, because uterus is an abdominal organ after delivery. Now, that's why they say, where is the uterus after delivery? At the level of the umbilicus. Then it becomes a pelvic organ. Please be careful. When does the uterus become a pelvic organ? Very common MCQ. When does it become a pelvic organ after delivery? It becomes a pelvic organ in 2 weeks. Don't say 6 weeks. In 2 weeks, it becomes a pelvic organ. And when does it become a normal organ? It becomes a normal organ in 6 weeks. 4 to 6 weeks, it becomes a normal pre-pregnant size of uterus. So why am I asking you this? When the uterus has just pushed the baby out, immediately after delivery, the uterus is at the level of the umbilicus. Tomorrow morning, if she has 2 children, you can post her in the postpartum OT, puerperal sterilization we can do, because uterus is an abdominal organ. How long can you do puerperal sterilization? You can do it only for 7 to 10 days, because in 2 weeks, 10 to 14 days, the uterus becomes a pelvic organ. That's why we cannot do it afterwards of this 7 to 10 days. Okay, it's based on this uterus involuting. How does the uterus involute? So this information is used for a tubectomy also. Tubectomy we've discussed in rapid revision. We can have a quick look at that also. Now, what are the important signs? Occasionally they come in the exam, so I've enumerated here. Jacquemus sign or the Chadwick sign is the bluish discoloration of the vagina and the cervix both. Osiander's sign, there's a single S. Okay, so we'll just take this off. Osiander's sign is pulsatility in the lateral fornix of the vagina around 8 weeks, you'll see. So this is the lateral fornix. These are 2 lateral fornices. When you put your fingers inside the vagina and put your fingers into the fornices, you'll see pulsatility 8 week. Then Goodell sign is the softening of the cervix 6 to 8 weeks, and Hagar sign is the softening of the isthmus. So softening of the isthmus is Hagar sign, and softening of the cervix is the Goodell sign. So these are the common signs which come in your exam. Then what else we can see as signs? Around 12th week and beyond, we can hear the fetal heart rate by a Doppler instrument. We can put it on the abdomen, and that that sound of the fetal heart rate can be made out. You must have seen in many OPDs. And after 24th week, we can hear it with a stent or with a Pinard fetoscope as well. Palpation of the fetal parts through the abdomen. When a doctor is palpating a pregnant lady, the doctor can feel the fetal parts from 24th weeks. Fetal movements can be felt by the mother 16 to 18 weeks in a multigravida and 20 weeks maybe in a primigravida, slightly later in a primigravida. Braxton Hicks, irregular painless contractions palpable around 16 to 18 weeks. This keeps coming in the exam. These are painless. These are painless uterine contractions. So these contractions come once in 20 minutes and they last for around 20 seconds. They're mild contractions and they don't give pain. But a lot of women keep telling us that they come to the OPD and say that my uterus becomes hard as a stone and then it relaxes. I'm very worried, doctor, what is it? Although it's not painful. So that's the Braxton Hicks contractions, and these contractions only become painful around term 37 weeks. That's when the patient goes into labor. Okay, so now let us see some changes of the puerperium, the relevant ones. Puerperium, as you know, is the time required for a lady to recover from the pregnancy. So the duration of puerperium is 42 days or 6 weeks. Traditionally also, Indian society, the major communities also have this either 42 days or 45 days of a restriction on a woman's or a mother's movements after delivery, because, she's immunocompromised, and if she goes out of the house, she may catch an infection. Since ages, we've been following that, and science also agrees that these first 42 days, the lady is immunocompromised. So what happens in this puerperium? The uterus, on the day of delivery, the uterus has a baby, and when the baby is pushed out, the uterus still is a large organ. It is around 1.1 kgs on the day of delivery. But within 1 week, it will become half of its size. It is around 500 grams at 1 week, and 2 weeks later, it is half of that 1 week size, around 300 grams. And then on the 4th week, it is half of the 2nd week size. Roughly, that's my way of remembering. So that will be around 100 grams. So 500 at 1st week, and at 2 weeks, it is 300 grams. This was a NEET exam question. How much is the size of the uterus at 2 weeks after delivery? 300 grams. And at 4 weeks to 6 weeks, that is the puerperium time when it completes, it comes back to 100 grams. But it doesn't go back to the pre-pregnant size. The pre-pregnant size was around 60 grams. So that size is not ever achieved. It is not ever achieved after a delivery. Okay. Then what is the lochia? Lochia is the blood discharge and the fluid discharge after delivery. So in the first few days, 3 to 4 days, it is lochia, which is red in color, lochia rubra. After 3 to 4 days, it is yellowish in color. And then after the 10th day, it is because of mixture of leukocytes that white color discharge. Lochia is now white in color. It is what is known as lochia alba. Okay, so rubra, serosa, alba in that order. Sometimes they'll give you MCQ to put this, in the right order. And remember, this is around 10 to 14, 15 days, but it can be normal up to 35, 36 days also. Lochia has been reported to be without any problems. So that is normal till 35 days. Then what happens to the breast? Breast starts secreting colostrum and highly nutrient-rich secretion from the breast, which is extremely important for the baby. That's why we say breastfeeding should start within 1 hour of delivery. And even after cesarean, we say that within 1 hour we should start. But yes, if because the mother is probably anesthetized, if CS was done in a GA, even then within 4 hours, even after a cesarean, the mother should start breastfeeding the child. But always we say as soon as possible within 1 hour. Okay. Now, colostrum is a lemon yellow fluid rich in IgA and factors like macrophages, lymphocytes, complement, lactoferrin, and lysozymes. Mature milk, which is after the first few days, this mature milk is around 600 ml per day. This is isotonic with the plasma. But remember that this milk is not very rich in vitamin D and vitamin K. So these supplements are given to a child who is on breast milk. Then what is the prolactin level in pregnancy? Remember, we all keep thinking that for breastfeeding, prolactin has to be high and then oxytocin has to be high for the milk let down. Yes, But what is the basal level of prolactin after delivery? Remember, in pregnancy, the prolactin is high. After delivery, the prolactin, in fact, is below normal. It is lower than the normal range of normal prolactin. Prolactin after delivery reduces. Now, when does it increase? Every time the child suckles on the breast, the prolactin will increase. So, for that matter, we have to understand that, see, prolactin levels with weeks in delivery, normal prolactin levels are 100 to 200 nanograms per ml in patients who have delivered in pregnancy rather. Now, what happens to the prolactin levels after delivery? Actually, prolactin levels after delivery, they fall. They are less than normal. See, during pregnancy, all of us know prolactin is high, but after delivery, the prolactin actually is much lower. But we've been thinking that prolactin is required for the breast milk production. Yes. Oxytocin is required for the milk letdown. Yes. So, how can prolactin be low? Look, the prolactin is always low after delivery, but every time the child suckles on the mother's breast, then the prolactin increases. So, for the prolactin to increase, constant suckling of the breast, that stimulus is required every 2 hours when the child is suckling, every 1 hourly also when mothers give. That will increase the prolactin, and that episodic increase in prolactin will cause the breast milk production. So yes, that's why it is episodic like this. The prolactin graph is not that it is constantly high. It is a episodic rise in the prolactin levels. So prolactin levels after delivery are low, and they increase every time the child is doing a suckling on the breast. So remember one thing. So remember this constant suckling, constant breastfeeding, let's say around 8 to 10 times when the child is being breastfed, this constant stimulus will go on increasing the prolactin, and that prolactin will cause breast milk production. But this high prolactin now, because of the constant suckling on the breast, the prolactin is high, and this prolactin will suppress the GnRH to suppress the LHFSH production and the ovulation suppression. So yes, to make sure that there is no ovulation, prolactin has to be high to reduce the GnRH. And for the prolactin to be high, the mother has to be very regularly feeding the child. So constant breastfeeding, remember breastfeeding very regularly. For 1 month the mother may do, but after that the regularity may reduce. The mother will sleep in the night. The child also gets into a routine and they may sleep in the night. So while the child is sleeping and the mother is sleeping, there is not much breastfeeding as the daytime. So that's why prolactin gets lower when these breaks happen. And that's why ovulations happen sometimes during the lactation time also. So my idea of telling you this story was, don't tell the patient to bank on lactational amenorrhea as the best method of conception in the lactation period. Please, it is dependent on the frequency of breastfeeding, and that frequent breastfeeding will keep the prolactin high, and no mother can breastfeed so regularly always. That's why it's not a very reliable method of conception. Okay. So now let's see what are the contraindication to breastfeeding. Look, when a mother is an alcoholic or a drug abuser, we will not breastfeed the child, and also when the mother has CA breast. Of course, galactosemia, that is also one condition where it is contraindicated. We know that well. When mothers are having HIV positive status, hepatitis B antigen positive status, and tuberculosis, these are also contraindications. But in developing countries, if you don't give breast milk for these reasons, the children will die for the loss of the only nutrition which they can get in poor countries. So yes, this is not an absolute contraindication in countries like us. The poor will continue to breastfeed their children. So if there is HIV positive patient, then we give nevirapine prophylaxis and allow the breastfeeding to be done. And if the mother is tuberculosis, we give INH syrup to the child. And if the mother is hepatitis B antigen positive, then we give active and passive antigen and antibody immunity to the baby. So that's why we say it is better we breastfeed these children, because they may die for the lack of breast milk rather than these diseases. So we take the risk, and this is not an absolute contraindication in developing countries, but those are definitely absolute contraindications. Then Mastitis, problem in puerperium. Most common cause of mastitis is Staphylococcus aureus, and it presents classic around third to the fourth week. There could be a tender breast with a fluctuant mass. It may become suppurative. It may make an abscess. So before an abscess happens, please give penicillin antibiotics. That is cloxacillin you can give. It's a perfect antibiotic for her. Please remember, can give breast milk when there is a case of mastitis. See, that breast is having enough milk, and that milk is not bad for the child. So please give her pain relief, give her hot fermentation, give her antibiotics, and the child can breastfeed. Yeah, sometimes what happens, since the breast is edematous because of the mastitis, and the nipple becomes a little bigger for the child to grasp. So let the child breastfeed from the normal breast, and once this milk letdown happens from the normal breast, then the other breast is also ready. By the time the child is finished this first breast, then he switches over to the next breast, and by that time this breast is ready to give milk immediately when the child suckles. So that way, even from a mastitis breast, you can make the child have breast milk. All right, please continue breastfeeding with mastitis. Now, what is puerperal fever? Fever in the first 10 days is puerperal pyrexia or puerperal fever. It should be more than 100.4 degree Fahrenheit to be called significant. 100.4 degree Fahrenheit. Remember one thing, we don't include the first 24 hours. Suppose the woman delivers at 10 a.m. and at 2 p.m. there is fever. Now this is only 4 hours after the delivery. So this could be because of some intrapartum or because of some antepartum cause. She could be having some viral fever. So this is not a puerperal cause of fever. She could be having some infections due to which she was having fever now immediately after delivery. So please, it should be 24 hours and later. After 24 hours, if there is high fever, then only we call it puerperal. There is some puerperal cause to this fever. So most common cause of this puerperal fever is the endometritis. Very important MCQ. And there is a standard treatment. The gold standard treatment is clindamycin and gentamicin, because mostly the cause is the group A, beta hemolytic streptococci. Okay, the beta hemolytic streptococci is the most common cause, and giving this clindamycin and gentamicin combination is going to give good relief in this endometritis. All right, basically because of prolonged labor, premature rupture of membranes, and too many examinations during labor, frequent PVs. Sometimes even doctors get a little, overcautious about patients, keep doing examinations to see if the head is coming down or not, and that can introduce. So that's why we say in active stage of labor, do a per-vaginal examination only once in 2 hours. Okay, only once in 2 hours, right? Another cause of puerperal fever is breast engorgement, and that can be a cause because a lot of children cannot start feeding on the breast immediately after delivery. So the breast keeps getting filled up because of that intermittent suckling. Also, the breast gets filled up with milk, and that retained milk can give a breast fever, like it is called. So that's one of the causes of puerperal fever. Mostly it is not an abscess or an infection every time. It just could be a retained breast milk. All right. Now there can be late endometritis, which is late puerperal sepsis. That is around 3 weeks after delivery, because the early sepsis, which I told you, is because of endometritis, and that was the group A beta hemolytic streptococci. And of course, there can be many other organisms, enteric bacteria, but mostly it is this group A beta hemolytic streptococci. Now, what is this late endometritis? Late endometritis around 3 weeks after delivery, and that is because of chlamydia. Yes, this is something which is rarely asked but has come in unique exam. Late puerperal sepsis or late endometritis because of chlamydia. And of course, the treatment of chlamydia here, when especially the mothers are breastfeeding the children, is to give azithromycin and not doxycycline as we generally give for PID. All right. Hi. So let us now see RH isoimmunization. Remember, when we talk about RH isoimmunization, we know because of the antibodies the mother makes, these antibodies go to the fetus, and the fetus has hemolysis. These are anti-RH antibodies or anti-D antibodies, which cause hemolysis in the fetus. Now, when there is hemolysis, there is anemia, and because of anemia, there will be fluid accumulation in the body, and there can be pleural effusion, pericardial effusion, and edema of the body. And we say the baby gets filled up, and there is hydrocephalus. Now, I want to tell you upfront itself that hydrocephalus, one of the causes is Rh isoimmunization, but this is not the only cause. So when they talk about hydrocephalus, please think about many other causes, not just this. One of the causes of hydrocephalus is Rh isoimmunization. So now, what is the Rh antigen? Let's start it from there. Now, what is this Rh antigen? Rh antigen is a group of 5 antigens on the chromosome 1, and these 5 antigens are the big C, small c, big D, big E, and small e. So these are the 5 antigens, 5 names given to different antigens of the Rh group. But yes, the D antigen, this is the most antigenic. So when we say a patient is Rh antigen positive, like we say he's A and Rh positive, so we say he's A positive. So he's basically A antigen along with D antigen positive. That means Rh and D antigen is the same. Nowadays, the new terminology is not Rh isoimmunization or Rh group. We say the CDE group. We don't call it Rh group anymore. We call it the CDE group. Okay. So yes, the Rh antigen is as good as the D antigen. We use them synonymously. Okay. Then what happens in Rh alloimmunization? What is alloimmunization? When there are antibodies against the antigens of the same species. So that is a alloimmunization. So what happens in Rh alloimmunization in a human? The mother who is Rh negative has a fetus who is Rh positive. Let's say, for example, mother is having a antigen and no Rh antigen on the RBC. So we say mother is A negative, and the fetus has the A antigen and also the Rh antigen. So we say this baby is A positive. So when the mother is A negative and the baby is A positive, what is that extra antigen in the baby? The Rh antigen or the D antigen. Now, basically, there is no mixing of blood. When the mother is giving blood to the fetus, we all know the mother's blood comes and the fetal villi goes into this blood lakes, and this fetal villi will take nutrition from this blood. Mother never gives blood to the fetus. We know the mother is just giving the blood in between the villi of the fetus, and the fetus has this blood supply through the villi, and because this current, the current which is made across this villi, this gradient which is made, this will take the oxygen and the carbohydrates and the proteins and the minerals from the mother, but there is no blood of the mother coming to the fetus. So yes, mixing of blood doesn't happen. But when can it happen? When the placenta, when there is a uterus and it is just not delivered and the placenta is still stuck to the uterus. And when the placenta is pulled away, then the blood vessels break, and then feto-maternal hemorrhage can happen at the time of delivery. What is the meaning of that? Some blood from the fetus can get into the circulation of the mother. So most commonly at the time of delivery, 5 to 30 ml feto-maternal hemorrhage can happen. That is 5 to 30 ml of fetal blood can go into the maternal circulation, but can also happen in abortion, molar pregnancy, ectopic pregnancy, can happen in abruptions, can happen in injuries to the abdomen, or while we're doing procedures like external cephalic version, chronic villus sampling, amniocentesis, and chordocentesis. These are the times when the mixing can happen. Now, what happens when there is mixing of blood? Try and understand this. I've written all of that here, but the basic meaning is that when the mother has delivered and the placenta is separated, some blood in the uterine cavity is fetal blood, and that blood can go into the circulation of the mother. When the uterus is contracting, some blood can enter into the circulation of the mother, and now the mother gets contaminated. See, mother does not have any Rh antigen. Mother is Rh negative. Now, this new antigen, the Rh antigen from the baby, has come to the mother's circulation. Mother is now contaminated by the Rh antigen, or simply called the D antigen. Moment these antigens enter, moment these D antigens enter the mother's circulation, mother starts making anti-Rh or anti-D antibodies, and she will lyse all these RBCs of the baby. So in her circulation, whatever RBCs come, mother makes anti-Rh or anti-D antibodies and destroys these RBCs of the baby. But in the process, she's got sensitized. She now knows that there is something called the Rh antigen in the circulation, and now I have made antibodies against it. Now she's progressively going to make antibodies against it. She's now loaded with anti-Rh antibodies, or simply called anti-Ds. So now the mother is loaded with anti-Ds. Next time when the mother is pregnant, suppose the baby is again Rh positive. Now the mother is already loaded with what antibodies? Anti-D antibodies. These antibodies from her circulation will go through the placenta and reach the fetal circulation. These are antibodies. Proteins can go through the placenta, not RBCs. Proteins can go through. Now these proteins, these anti-D antibodies have reached the fetal circulation. Fetus has Rh antigen or the D antigen on the RBC. Mother sends anti-D, and on the fetal RBC, antigen antibody reaction takes place, and there will be a hemolysis. So that is the reason why hemolysis happened, antigen antibody reaction on the fetal RBC. Now when antigen antibody reaction happens, there is a hemolysis. Hemolysis causes anemia, severe anemia at birth, and that hemolysis also causes jaundice. Jaundice, if it is more than 20 milligrams per deciliter, it gets fixed in the basal ganglia, which you have read in pediatrics, known as kernicterus. Also, there is pleural effusion, pericardial effusion, and ascites of the fetus, which is why we say the baby is full of fluids. We say the baby has hydrops fetalis. Okay, and the bone marrow responds by making more and more RBC series of cells. So in the peripheral circulation, you will see erythroblast. So that's why it is also known in this situation where there is hydrops fetalis. It is also known as erythroblastosis fetalis. So to prevent this, why we want to prevent this? Because all of this can cause a neonatal death also. So remember, because of all of these, when hydrops fetalis and erythroblastosis fetalis happens, we can also lose a neonate. There can be a neonatal death also. But very important to understand here that what I've told you is a typical scenario. The typical scenario was that a first baby at the time of delivery contaminates the mother. Mother makes anti-D antibodies. Next pregnancy, if the baby is Rh positive again or D antigen positive again, these anti-D antibodies from the mother will cause hemolysis of the second baby. So ideal presentation or the typical presentation which we generally know is that the first baby survives. But remember, let me make very clear here. The first baby mostly survives. Not always. Don't say this cannot happen in the first pregnancy. Sometimes a mother can get sensitized in the first pregnancy also. So yes, this mostly happens that the first baby survives, but not always. Remember this part. Now, what can we do to prevent this? Isoimmunization, that the mother has just not delivered and the baby has now been given to the nursery, and the placenta, when it was separated, some blood from the fetus is going to the circulation. So how can we prevent? So to prevent the severity of the fetal-metal hemorrhage, we say avoid methyl ergometrin. Avoid methyl ergometrin for PPH treatment or prevention, because methyl ergometrin causes sudden contraction of the uterus and more blood from the fetus can get into the uterine circulation. So we give oxytocin when a mother is Rh negative and delivering a fetus. Now, to prevent this Rh isoimmunization, when the baby is born, we give anti-D to the mother. Now, what is the principle behind this? Moment the baby is born and the fetal blood has gone to the mother's circulation, mother gets contaminated and the mother starts making anti-D antibodies. Because mother's got contaminated by the D antigen, mother starts making anti-D. Now, before she starts making anti-D, before she starts getting exposed to this D antigen, we neutralize this D antigen. Yes, it takes 3 days. It takes 3 days for the mother to recognize this D antigen. So now, once again, mother has delivered, the fetal blood has gone into the mother's circulation, mother's contaminated by the anti-D. Before the mother recognizes the D antigen, before the mother's immune system recognizes the antigen, you have made the anti-D already commercially enough and the injection is available in the pharmacy. Bring the injection from the pharmacy, give it to the mother immediately after delivery. So what happens now? Mother has been contaminated freshly by which antigen? D antigen. You give injection of what? Anti-D. So this D came to her circulation. You gave anti-D into her circulation and this anti-D found all these D antigen carrying fetal RBCs and they destroy the fetal RBCs carrying the D antigen. So moment this destruction happens, the D antigen threat is removed from the body of the mother. So mother does not even get to realize. Mother delivers, D antigen comes, you give anti-D from outside, and the Z antigen threat is removed. So mother's immune system does not even get to realize that there was something called D antigen which came into her circulation. So yes, give 300 micrograms at the time of birth, and that will neutralize 30 ml of fetal blood or 15 ml of fetal RBCs. And for abortions before 12 weeks and ectopic pregnancy before 12 weeks, you don't have to give 300 micrograms. Any dose between 50 to 120 micrograms is enough to prevent RH isomerization. All right. Now, when we have given this anti-D, how much does it neutralize? If the fetal blood which has gone to the mother is around 30 ml, then that can be neutralized by the 300 microgram injection which you've given. But sometimes the fetal-metal hemorrhage can be excess of this 30 ml. Suppose the fetal-metal hemorrhage, the blood from the fetus which has gone to the mother is 35 ml. 5 ml is extra, and that 5 ml will have all the time in the world because only 30 ml got neutralized by the 300 micrograms. So this 5 ml which was extra had all the time in the world to sensitize the mother, and the mother gets to know that there is a D antigen. So the mother will make anti-Ds. So to prevent the anti-D formation, total D antigen should be destroyed. So yes, we should do the calculation of the exact amount of fetal blood loss into maternal circulation. So this is known as the feto-maternal hemorrhage. Calculate exact amount of feto-maternal hemorrhage which has gone into the maternal circulation. So this test is known as the Klehoyer-Betke test. With this Klehoyer-Betke test, we can find out how much blood from the fetus has gone to the mother's circulation. So now, who has got contaminated? The mother has got contaminated. In her mother's circulation, there is fetal antigen, the D antigen. So from the mother's vein, you take out blood, plate it on a slide, and give this a acid bath, a citrated buffer bath you give. When you give this acid bath, then there is elution of hemoglobin from RBCs. The hemoglobin leaves the RBC. Elution means leaving. So when you give acid wash to the slide which is having maternal RBCs, the hemoglobin from the RBC is lost. So when the hemoglobin is lost, the RBCs become colorless. So yes, this elution of the hemoglobin from the RBCs makes this colorless RBCs. And these colorless RBCs are mother's RBCs. So when you give acid, the hemoglobin from the maternal RBC will leave this RBC. This hemoglobin will leave the RBC and the RBC will become colorless. And now we know that some fetal blood is there in this, and that fetal blood will not lose the hemoglobin. So yes, some cells are red. These are the nucleated fetal RBCs, and they will resist this acid elution. So moment you give acid, the hemoglobin from the maternal RBC is lost and the maternal RBCs become colorless, but the fetal RBCs will stay red. So now you see in this slide, you can count the number of RBCs and you can see how many RBCs are from the mother and how many which are red, how many RBCs which are red, which are from the fetus. So now we have a fraction of contamination. In this slide, you can see that there are 4 RBCs out of, let's say, 100 RBCs, which are maternal. So 4 RBCs are fetal RBCs. So we get a fraction of contamination, and we can use this fraction to calculate how much of fetal-maternal hemorrhage, how much of fetal blood has gone into the circulation of the mother. And then we can give the exact amount of anti-D. So to know the exact amount of fetal-maternal hemorrhage, we do the Klehoyer-Betke test. It is also known as the acid elution. It is known as the acid elution test. Alright, and we find out the exact amount of fetal-maternal hemorrhage, and then we neutralize the exact amount of fetal blood. So this is how this slide will look like. You'll see ghost RBCs, see the RBCs which are behind, they're not having color. Okay, they are colorless. And then you see these red dark RBCs. which are of the fetus. So this picture will come in the exam and they'll say, what is this test being done? Or this test is being done for which condition which can present in humans. Like that, this picture may come. Okay, this is a KB test, Kleha-Bethke test, or the acid elution test. All right. Now, what can you do for the management of Rh isomerization in pregnancy? So, moment a lady is pregnant and she's Rh negative pregnancy and the husband is Rh positive, then you check the indirect Coombs test. If the indirect Coombs test is negative, that means the mother is not exposed. In indirect Coombs test, we'll check antibodies. And if the ICT is positive, then we say there is some amount of hemolysis. So, yes, you check the mother's blood and there is no antibody. There is no antibody in the circulation because she is ICT negative. So, when the ICT is negative, continue the pregnancy. But be careful. The mother is pregnant for the first time, and first time when the baby may be Rh positive. The mother is pregnant for the first time. Mother is Rh negative. She is A negative. Baby could be positive, and some small injury may happen on the mother's abdomen, and some fetal blood in the first pregnancy. Some fetal blood in the first pregnancy itself can enter the maternal circulation, and the mother may start making antibodies even before the delivery has happened. So that's why I said first baby mostly survives, but not always. Once again, in a woman who is pregnant, check the ICT. If the ICT is negative, that means she's got no exposure to the D antigen so far, continue the pregnancy. But always keep in mind that later in pregnancy, some small injury can push positive blood into maternal circulation. So mother is negative and we act smart. At 28 weeks itself, we give prophylactic anti-D to the mother. There is no injury. There is no delivery. She's only 28 weeks. But we give some injection of anti-D to the mother. Now the mother's immune system is loaded with anti-D antibodies, which are made outside in a factory. Now the mother's body is loaded with what antibodies? Anti-D antibodies. Now suppose some transplasmal hemorrhage happens, some small injury happens, and the fetal antigen reaches the maternal circulation. Already the maternal circulation is loaded with anti-D. The moment the D antigen comes, mother is already loaded with the anti-Ds, and that anti-D is because of the injection, the prophylaxis which you've given. So that anti-D will neutralize the D antigen threat and there will be no harm in the first pregnancy. So please remember, mostly the first baby survives, but if there is a transplasmal hemorrhage and the mother makes antibodies in the first pregnancy itself, then the first pregnancy itself there can be hemolysis. To prevent that first baby from having a hemolysis, we can give prophylactic antibodies. Now this prophylactic anti-D, 300 micrograms anti-D is given at 28 weeks, and then at delivery, 40 weeks we do the delivery, then you repeat the anti-D. So this is the prophylactic anti-D schedule, and this is what is coming in exams. What is the time when you give prophylactic anti-D to prevent isomerization? So during pregnancy, 28 weeks, and then at delivery. All right. So that is the management in pregnancy when the ICT is negative. Now, if the ICT is positive, let us see this situation also. Mother is pregnant, she is Rh negative, and the father is Rh positive. And sometime later in pregnancy, let's say around 20 weeks, you do the ICT test, indirect Coombs test. Indirect Coombs test is positive. That means the mother is already exposed to which antigen? D antigen. What is she making? Anti-D. And this anti-D could be going to the fetus and causing what? Hemolysis. Don't get into panic already. Relax. Just think. Mother is pregnant, A negative. Father is positive. The baby can be positive in 50% cases to 100%. Now, if the baby is Rh positive and the mother is contaminated already and the mother is making ICT, that means if the ICT is positive in pregnancy, I know that some antibodies from the mother are going to the fetus and causing hemolysis, correct? So find out how many antibodies are there. Some antibodies from the mother are going to the fetus, causing what? Hemolysis. But the baby is making blood also, right? You and me also have hemolysis. what happens? Every day we have some hemolysis. So the baby is also having a RBC production factor in the bone marrow. He is making RBC. There is some hemolysis because of the anti-D. Find out how many anti-Ds are there. Find out what is the titer of this anti-D. So if the IC is positive, check the titer of the antibodies. And if the antibody is 1 ml positive, you dilate it into 1 ml, that is 1:2, it gets negative. Hardly any antibodies. There is some hemolysis, but the baby is making blood to compensate for the hemolysis. No harm done. 1 in 4, 1 in 8, 1 in 16, doubling titer we check. So if the antibody is positive, if you dilute 1 ml of blood of the mother and the antibodies are positive, even if you dilute it to 16 ml, still it is not very high in titer. It is not very high. You can continue the pregnancy. So antibody titer, if it is 1 in 16 or lesser, it is safe titer. That amount of hemolysis the baby can always compensate for by making more and more RBCs. So safe titer, continue the pregnancy. Now, if the antibody titer is more than 1 in 16, that means 1 in 32, 1 in 64, 1 in 128, like that. If the titer is increasing, that means there are more concentrated antibodies in the mother. That means there is more blood going to the fetus. That means the baby is having hemolysis. So yes, if the anti-D is high, find out how high it is. So it is 1:2, 1:4. Don't do anything. Continue the pregnancy and monitor the ICT once in a month only. No hurries. It's fine. Now, the antibodies titer is more than 1 in 16 dilution. Suppose 1 in 256. So 1 in 512. Doubling titer we are saying. If it is very high antibodies in the mother, so that high antibodies are going to the fetus and causing what? Hemolysis. So find out how much is the hemolysis. Once more, let us revise. I know it's a little tough topic. Remember, if the mother is positive, antibodies she is already making. These antibodies, how much they are? So they are 1 in 16 or lesser. There are not so many antibodies. When I dilute 1 ml to 16 ml, the antibodies are present. When I dilute it to 1 in 32 times, antibodies are negative. So if they are present in 1 in 16 dilution, it is a safe titer. There will be some hemolysis. Baby can take care of himself because of that hemolysis. Why he can take care of himself? Because he is making blood by his bone marrow. So safe titer, continue pregnancy. Now if the titer is more than 1 in 16, we know the hemolysis is happening in the baby. Check how much hemolysis is happening. So yes, we can do an amniocentesis and check the hemolysis, but that is considered invasive. What do we do these days? If there is hemolysis in the fetus, there will be anemia in the fetus. To overcome the anemia, the fetus will increase its cardiac contractility and increase the pulse rate and increase the flow of blood all over the body to compensate for the loss of hemoglobin because he's getting hemolyzed. So you and me get hemolysis, we'll have tachycardia. The baby is having hemolysis, he'll have tachycardia. So baby increases the flow in the body to overcome the loss of hemoglobin, and especially to the brain. Brain gets still more blood than any part of the body. So the fetus is trying to compensate for the loss of hemoglobin by increasing the flow in the body so that there is compensation for the loss of hemoglobin. Now, this flow is high, especially in the brain sparing effect. So brain gets more blood as compared to the body. So brain is preserved even till very high severe cases of hydros fetalis or hemolysis in a fetus. So more and more blood is going to the brain of the baby. So when that blood is going to the brain of the baby, because of what? Because of anemia in the baby. Because of this antigen antibody reaction in the pregnancy, there is hemolysis in the baby, and that anemia makes sure that there is more and more blood going to the brain sparing effect. Now, when more and more blood goes to the brain, we can measure the flow. We can measure the flow into the brain by a Doppler. So remember, if it is more than 1:16 dilution, then we'll do the middle cerebral artery Doppler. With the middle cerebral artery Doppler, we'll check the peak systolic velocity. Now, what is this peak systolic velocity? It is that systolic velocity of blood in the middle cerebral artery, and that is at a set median value. Let's say I have a Doppler done for a fetus which is 30 weeks, and I know the parameters. I know a computerized chart which is telling me that the peak systolic velocity median value is this. The median value of this at 30 weeks in a normal fetus is this. So now the baby is anemic, and baby is increasing the heart rate, and baby is increasing the flow of the blood. And if that peak systolic velocity is increasing, that means he's getting more and more anemic. So rather than doing an amniocentesis, now we do the peak systolic velocity, the PSV of the MCA, middle cerebral artery. So when we do that and we find that the peak systolic velocity is not increased, or the peak systolic velocity is increased, but it is less than 1.5 times increase than the median value. This is why it is known as multiples of median units. MOM is multiples of median units. So if the peak systolic velocity is at the median value which it has to be, then continue pregnancy. There is hemolysis, baby is compensated. If there is hemolysis which is much and the peak systolic velocity is 1.1, 1.2, 1.3 times, it is still safe. Continue pregnancy. So if it is less than 1.5, the baby is safe. But now, if the peak systolic velocity is more than 1.5 multiples of median, if it is more than 1.5 times of the median value, then we are worried because the hemolysis is severe. The baby can die in uterus. So now, if it is less than 28 weeks and if it is more than 28 weeks, we have to make a decision. So around 28 weeks and lesser, the baby's lungs are not mature and he's having severe hemolysis. You cannot deliver the baby. Baby is inside the mother, there is hemolysis and it is less than 28 weeks. So yes, this baby we cannot deliver. He's too preterm. In fact, he's in the stage of before 28 weeks, he's still a abortus if the baby is to come out. So yes, before 28 weeks, what is happening in this baby? There is hemolysis. So we can do a intrauterine transfusion. We can put this intrauterine transfusion to the baby into the umbilical vein, intrauterine transfusion, or into the peritoneum of the fetus. We can inject the blood through the maternal abdomen, go to the peritoneum of the baby and leave the blood. Blood gets absorbed through the lymphatics. Then we can give blood directly into the umbilical vein. So less than 28 weeks, if you want to continue the pregnancy, give intrauterine transfusion. Now after 28 weeks, we know that the baby is viable. So between 28 to 34 weeks, give steroids, buy a couple of days and then do delivery. But if the baby is beyond 34 weeks, when the lung is mature and there is severe hemolysis, then we will deliver the baby and do neonatal treatment, exchange transfusion and the phototherapy and whatever. Okay. So if it is beyond 34 weeks, lung maturity is achieved, then deliver. All right. So that's the management of RH negative pregnancy when the indirect Coombs test is positive. All right. Then let us see what other incompatibility can happen. Now, RH antigen is one of the antigens on the RBCs. RBCs have many more antigens which can cause problems, but severe hemolysis because of RH incompatibility. Now, suppose the mother is A negative and the baby is A positive. I've told you RH incompatibility and we've discussed the theory. Suppose the mother is B and the baby is A. That is ABO incompatibility. Now remember, ABO incompatibility is far more common than the RH incompatibility. But the ABO incompatibility, which is much more common than the RH incompatibility, is a most common cause of hemolytic disease of the newborn, but it is lesser severe hemolytic disease. Now that's what is the benefit. All of us know that so many of us have different blood groups than our mothers, but we're all doing fine, isn't it? Because the ABO incompatibility also makes antibodies against the other antigen, and that antibodies will cause hemolysis. But these antibodies are of IgM types. These antibodies are IgM types antibodies. So you know that this will not cross the placenta, it does not reach the placenta mostly. So that's why the hemolysis is very minimal and the baby is mostly fine in ABO incompatibility. This is indeed the most common cause of hemolytic disease of newborn, but this hemolysis is way lesser, much lesser severe as compared to the RH incompatibility, the ABO incompatibility. All right. Now, we were discussing the beginning of the chapter that there are many other causes of hydros fetalis apart from just RH isomerization. So yes, after having discussed that in brief, what is non-immune hydrops? Baby full of fluid is hydros fetalis, and mostly it is because of no RH isomerization. Non-immune hydrops, like we call it, is the most common cause of hydros fetalis, and most common cause of this is cardiac, and most common cardiac cause is congenital heart block. All right. Also, chromosomal causes like Turner syndrome and the trisomies may have fluid accumulation. Some people say that chromosomal might be more common than cardiac, but that is controversial. We are sticking with most common cardiac, and in most common in cardiac is the congenital heart block. All right. Then infections, most commonly the parvovirus infections. Yes, the slap cheek appearance, erythema infectiosum, you must have read about all of that. That is because of parvovirus, and that can also cause the baby to have hydros fetalis. They can be hematological cause like alpha thalassemia. Alpha thalassemia makes HB Barts. So baby has HB Barts. The baby is born with hydros fetalis and it is invariably fatal. That is alpha thalassemia. Now renal causes like polycystic kidney disease, genitourinary causes, things like posterior urethral valve, and gastrointestinal causes. So many causes of non-immune hydrops are there. There are metabolic causes also, and then there is something called the cystic hygroma. Cystic hygroma is also part of the, there's that cystic swelling. There's a cystic swelling next to the neck when a newborn is there. So that cystic swelling can cause a lot of respiratory discomfort to the newborn, and you may have to do a emergency surgery. So cystic hygroma is also a type of a non-immune hydrops. So yes, the most common cause of hydros fetalis is indeed the non-immune, but yes, it is not as bad as the RH topic, regular feature in your exams. So now, when we talk about the ectopic pregnancies, that means a pregnancy outside the uterus. It is mostly tubal ectopic, which all of us know well, and it can be rarely in sites like the ovary and the abdomen. But now, when it is in the ovary and the abdomen, it is probably what happens that the pregnancy from the tube, it ruptures from the tube and settles in the abdomen as a secondary abdominal, or from the tube, it comes and settles to the ovary, and it is a secondary ovarian ectopic pregnancy. But rarely what happens that the pregnancy starts in the abdomen or the pregnancy starts in the ovary. So primary abdominal and the primary ovarian pregnancies are need exam questions, and they keep asking you what is the criteria. So for primary abdominal, we say Studyford criteria, that the pregnancy has started in the abdomen de novo. It is not coming from the uterus or the tube into the abdomen. So the tubes and the ovaries are normal. There is no uteroplacental fistula, that the pregnancy is in the abdomen and that placentation is inside the abdomen, and from that placenta there is no connection to the uterus, no uteroplacental fistula, and pregnancy is related exclusively to the peritoneal surface. Now, what is primary ovarian pregnancy? Now, primary ovarian pregnancy is that the tube on this side where the ectopic is normal, and this ovary is replaced by a gestational sac. There is no connection between the pregnancy and the tube, or the pregnancy has not come out from the tube. That's what we're trying to say. So there's no connection. But yes, this ovary is replaced. Tube is intact and the ovary is replaced by the gestational sac. And now this ovary, which is actually connected to the uterus by the ovarian ligament. So now the gestational sac is connected to the uterus with the ovarian ligament. And when you take a cross section on the histopath of this ectopic, you will see around the gestational sac, you'll see ovarian tissue. So that is the Spiegelberg's criteria. So what they've asked you generally, what is the name of the criteria they've asked you? But I thought I'll enumerate the features. Now remember, apart from the tubal ectopic, The most common ectopic after that is the ovarian ectopic. But remember, none of these pregnancies are known to go till full term. All these ectopics which I have discussed, the tubal, abdominal, ovarian, most of these, or let me correct myself, none of these will go to full term pregnancy. Okay, if at all something can go till full term, very rarely, it is the abdominal ectopic. All right, now still rarer sites are the cesarean, that is, if there is a cesarean scar in the uterus, on this scar there might be an ectopic, or there might be a cervical ectopic. So the rarest ectopic is the cervical ectopic. Now, what are the tubal sites we should be talking about, which generally is the feature of exams? So most common site, please remember, most common site of the ectopic, 70% of the ectopics is the ampullary ectopic, and ischemic ectopic is only 11%, and much rarer, very rare, is the interstitial or the cornal ectopic. So ischemic ectopic, this will rupture at 4 to 6 weeks of gestation, and ampullary will rupture at 6 to 8 weeks of gestation, and interstitial cornal will rupture 12 to 18 weeks of gestation. So when we talk about the time of rupture, remember, when we talk about this time of rupture, the earliest to rupture is the ischemic, the commonest to rupture is the ampullary, and the last to rupture is the cornual. So please remember, the ischemic ectopic is 11%, and it is the earliest to rupture, and don't misunderstand saying that ischemic is the commonest. Commonest ectopic, 70% of ectopics is the ampullary. So that is what is going to rupture the maximum. So please, that's a very simple logic, and it is what is the data also. So most common and the most common to rupture is the ampullary ectopic. Now, interstitial or cornal ectopic, this is actually in the narrowest part of the fallopian tube. Okay, here at the narrowest part, interstitial or cornual. Now, why does it rupture the last? Because along with the growing gestation, this uterine muscle will also stretch for a long time, because the increasing estrogen causes hypertrophy of the uterus. So at this area, the uterus will go on increasing till it really stretches a lot and it ruptures. So this is the last to rupture because it's in the uterine muscle, although it's the narrowest part of the tube. All right. Now, what is heterotropic pregnancy? When there is a intrauterine pregnancy along with a ectopic pregnancy, that is a heterotropic. The incidence now, because of too much of in vitro fertilization, is 1 in 3,000 pregnancies. Now, what are the main causes of an ectopic pregnancy? The prevous ectopic is the most important cause. Most important cause, not the commonest cause. Don't do that mistake. Please don't say a lady that if she's just got married 3 months back and now she's come to you with a diagnosis of a ectopic pregnancy. You do the ultrasound and say that you have a ectopic, and she says, how did I get it? Don't tell her that you had an ectopic before and now you got an ectopic. Please, previous ectopic is not the commonest. It is the most important. So when a woman has an ectopic, one ectopic has a chance of becoming a second. I mean to say a second ectopic is likely in this patient, 15% second ectopic now. Because otherwise the incidence is 1 to 2% of all pregnancies. But if she's had one ectopic, next time it is 15% chance. If she's had 2 ectopic pregnancies, then there's a 30% chance that she'll have a third ectopic. A third ectopic pregnancy can happen to this patient. Now, needless to say, the most common cause of an ectopic is the PID. PID causes microdiverticulars. The small passages are made in the fallopian tube microscopically where the embryo can get lodged. Tubal surgeries like tubectomies and tuboplasties are the ones which can cause a patient to have an ectopic. And endometriosis, tuberculosis, because of increased adhesions in the tube, that will cause ectopic pregnancies. First of all, they cause infertility. But yes, if at all they get pregnant, these patients, they'll have more ectopics. Infertility treatment directly proportional to increased ectopic pregnancy. In my department, the reproductive medicine unit where I work, if a woman conceives with our treatment, whatever treatment we give, intrauterine insemination or ovulation induction or an IVF, if at all a lady conceives, we congratulate only after we do a scan and see a intrauterine gestation, because we get a lot of ectopics. It's not that we get more than any other IVF center. It's just that ectopic pregnancies are more in infertility treatment. Okay. Then IUCD users. Now that is one sore point in our discussions most of the times. Please remember, don't even think of saying that IUCDs increase ectopic pregnancies. Very simple logic. If you give IUCD to a lady, what is the number of pregnancies she's going to get? Lesser or more? She's going to get lesser pregnancies. So when the pregnancies are lesser, ectopic pregnancies also will be much lesser. Please, I'm not going to give an IUCD to a lady and tell her that, look, I've inserted an IUCD. Now, what is going to happen to you? You're going to get an ectopic, it's going to rupture, and you're going to die. So which lady is going to come and get an IUCD from me? Do not even think of saying that IUCDs increase in ectopic. And for God's sakes, don't say that ectopic pregnancy is a contraindication for an IUCD. That is also wrong. I know I'm a little controversial in whatever I say, but go ahead and see your books. You'll be very, very satisfied with what I'm saying. So please understand, IUCD users, they reduce pregnancies and reduce ectopic pregnancies. But yes, if at all she conceives, now that part is important. Let me draw a diagram and show you. Suppose a lady has an IUCD in situ, and now she has a failure. Suppose she conceives. Suppose there are 100 IUCD failures. Suppose this lady conceives. So where will the pregnancy be found? So when a lady conceives with an IUCD, then 95% the pregnancy will be in the uterus and 5 to 6% will be in the fallopian tube. Okay. So suppose they are IUCD users, and out of 1 lakh IUCD users, some 100 women conceives. Okay, 0.1 to 0.2% is a failure. 100 women with IUCDs have conceived. So where will be the pregnancy? 95 of those pregnancies will be actually inside the uterus, and 5 to 6% might be ectopic pregnancies. So yes, if at all a woman takes IUCD, first of all, she's not going to conceive. If at all she conceives, it will be in the uterus. Only a relatively higher chance of finding babies in the tube. So absolute number of ectopics will not increase the IUCD. It's just that if at all there's an IUCD failure, we say rule out an ectopic. We don't say there are more ectopics, slightly more chance of it being in the tube. So IUCD users reduce pregnancies, reduce ectopics. So if IUCD failure is seen, then rule out an ectopic pregnancy. All right. Now the same logic which I told you, that first of all pregnancies will be less and ectopics also will be less, and if at all she conceives, slightly more chance of it being in the tube. Still 95% pregnancies will be in the uterus. Now that logic, the same logic is also seen in progesterone only pill users. Absolutely same logic. All right. Then what happens to an ectopic pregnancy? Now this is that most important part of the chapter. What is the fate of an ectopic? The ectopic keeps growing and ruptures? Sorry, that's not the commonest fate. Most common fate of an ectopic is that this pregnancy, which is growing in the fallopian tube, first let us understand how it is persisting and growing in the tube. This pregnancy, which has got a placenta is making the human chorionic gonadotropin, which is supporting the corpus luteum to make the progesterone, and that progesterone is maintaining the pregnancy. In fact, the progesterone is going not directly into the fallopian tube, it's going into the circulation all over the body, and that progesterone is also acting on the uterus to make a bed, a lining in the uterus in which the embryo should have actually implanted, but the embryo stopped in the ampulla and made a ectopic pregnancy. So this is what happens in a ectopic pregnancy. How is the pregnancy maintained? By progesterone. What is maintaining the progesterone? Corpus luteum. And what is stimulating the corpus luteum to go on working? The HCG. We've discussed this in the initial chapter of rapid revision also. But we discussed about a pregnancy inside the uterus. But the same maintenance of pregnancy happens in an ectopic also. Now, as the ectopic pregnancy starts to increase in size, see, now the gestation sac will go on increasing in size. So with this increasing size of the gestation sac, the tube will get stretched. Please, I did not say rupture. the tube will get stretched, and a stretched tube will get blanched out, and the blood supply will reduce and eventually stop. So yes, the growing embryo outgrows the blood supply and dies. That is the most commonly a vascular insufficiency. Vascular insufficiency ensues, and that will cause the degeneration of pregnancy, and that means there will be loss of HCG and corpus luteum degeneration, which will cause the shedding of the endometrium. Shedding of the endometrium is because of the death of the corpus luteum or the degeneration of the corpus luteum. So yes, the pregnancy dies, the HCG reduces, corpus luteum dies, progesterone reduces, and this endometrium sheds and causes a vaginal bleeding. So yes, shedding on the endometrium causes the vaginal bleeding. So yes, sometimes when I ask students in the class, before I tell this, what is the cause of vaginal bleeding in an ectopic? Most people say, sir, there's a tube which ruptures and there's a lot of blood in the abdomen which goes through the fallopian tube and comes out and causes vaginal bleeding. Please, that's never the cause of the bleeding from the vagina. The bleeding from the vagina is because of the shedding of the endometrium. Why? Because there is degeneration of the embryo. All right. Now, what else can happen? This embryo may come out of the fallopian tube because of the peristalsis. So, there can be a tubal abortion, and there can also be a rupture of the tube. So, these are the termination event of an ectopic pregnancy, but the most common is vascular insufficiency. So, now we'll understand the signs and symptoms better. So, what are the symptoms? Most common, the clinical triad, which helps us to make a diagnosis in the emergency itself without doing an ultrasound most of the times, is that there is pain abdomen in a lady associated with vaginal bleeding with a history of amenorrhea of 2 to 3 months. So, this clinical trial tells us that the patient is probably having a ruptured ectopic pregnancy. Signs and symptoms will be obviously of a ruptured ectopic pregnancy. If a patient is having an unruptured ectopic, she'll not have any problems. Most of the time, she'll not have any problems. And at least when she comes with a history of a urine pregnancy test positive, we'll do an ultrasound. And if it is unruptured, you tell her that, oh, you got an ectopic. Okay. Till then, she did not even knew. She did not even know about it. So yes, ruptured ectopic. What are the signs? So, pain abdomen, vaginal bleeding, along with a history of amenorrhea is the classical clinical triad, and she'll also complain of syncopal attacks, blackouts. Okay, now those are symptoms. What are the signs? That she's in shock. There's a loss of blood pressure, there is tachycardia, increased pulse rate. So, we know that the woman is having shock. Then, there'll be abdominal distension, abdominal tenderness, and there'll be flank bruising. That is, there is intraperitoneal collection of blood. So, the flanks, they might be bruising. That is known as the Turner sign. Flank bruising is the Turner sign because of intraperitoneal collection of blood, or there can be periumbilical bruising. That is again intraperitoneal collection of blood, but that is known as the Cullen sign. Turner and Cullen sign. Then, when you do a per-vaginal examination in this patient and move the cervix, there will be cervical motion tenderness. Because of the blood, there is inflammation of the peritoneum. So, that will be painful. Same cervical motion tenderness is also seen in a pelvic inflammatory disease. Now, there is also bogginess in the pouch of Douglas. So, what do you mean by bogginess in the pouch of Douglas? Simple to understand that when there is rupture of the ectopic, the blood will first collect in the pouch of Douglas like this. So, this blood which is collected in the pouch of Douglas, when you do a per-vaginal examination, you will see fullness in the pouch of Douglas. So, that fullness or bogginess is felt. So, what do we generally do? When we are seeing this patient in the emergency, then a lot of people say that it is not a necessary test. You have so many ultrasounds. But yes, I am very traditional. I will put a needle into the pouch of Douglas and aspirate what is felt through the bogginess. So, when we aspirate blood, it tells me that there is a hemoperitoneum. And this blood, when you aspirate blood, when you do this culdocentesis, this area, can you see this bluish fold of peritoneum? This is known as the pouch of Douglas, which is also known as the cul-de-sac. Okay. So when we put a needle into the cul-de-sac or the pouch of Douglas, it is known as cultocentesis. It will aspirate blood, and this blood will be non-clotting. Why it is non-clotting? Because this blood, which is mixed with the peritoneal fluid has fibrinolysins. So this blood, which is collecting in the peritoneal cavity, will not clot, because the fibrinolysis will break the fibrin plugs, the fibrin clots, and that's why this blood is in fluid form. You can keep this blood for 2 minutes, 2 hours or 2 days, it will not clot. So that is diagnostic, that we know there is hemoperitoneum. So in this sitting, pain abdomen and vaginal bleeding, and the patient is having some history of amenorrhea, then there is syncopal attacks, there is bogginess, and this bogginess reveals non-clotting blood, more or less is enough for me to go ahead and do a laparotomy. So we say that is how we diagnose an ectopic clinically. But yes, now that we have ultrasounds, why not use them? So ultrasound is a very good help in diagnosing an ectopic. The best diagnosis of an ectopic, always, if that question comes, the best diagnosis of ectopic, go ahead and say laparoscopy. But mostly we do it with a transvaginal sonography. So that is about the bogginess. Let us see how do you do the treatment of a ruptured ectopic pregnancy. Now, this is that easy part of the discussion. Ruptured ectopic pregnancy, always treat the shock, that is resuscitation, and do the surgery. So treatment of shock, like in any emergency, in any clinical department, large bore IV cannulas in both the arms, and rush in fluids, arrange for blood, call for help, etc., etc. But this is obstetric class. What is the management of a ruptured ectopic pregnancy? Now, ruptured ectopic pregnancy, we understand that the tube is now damaged. It is damaged beyond repair. Please understand, this tube has ruptured, and because of this ruptured tube, there is a hemoperitoneum, which could be a stable patient or a patient in shock. But when there is a ruptured tube, it needs only one surgery, and that is to put a clamp here and remove the tube completely. Please, a total salpingectomy is the treatment. Yes, do not even think of saying partial. Salpingectomy, total, okay? No partial salpingectomy, no anastomosis and repair. If a tube is ruptured, this tube is worth only the dustbin. So when there is ruptured ectopic, treat the shock, do the surgery. And what is the surgery? Total salpingectomy. Of course, if the patient is stable, then I may think of doing a laparoscopy, but mostly I do a laparotomy. Yes, some of us have been doing a lot of laparoscopic work. So in unstable patients also laparoscopy can be done, but we are not discussing about rare surgeries. We're talking about common work. Common work is a patient has a ruptured tube and still the blood pressure and the pulse rate is maintained. You can do it laparoscopically. But if the patient is unstable and the patient is in shock, do a laparotomy. That is the method of entry. But I told you the main surgical procedure. See, obstetrics, please remember, tell the main obstetric management along with treatment of shock and how you enter the abdomen and how you clean the abdomen and what betadine spirit you use. That is not obstetrics. That is there in general surgery also, that is there in ENT also, that is there in gynecology and obstetrics also. But what is the specific obstetric management? Remember that in all obstetric work. So here, the specific management here is throw the tube in the dustbin, all right? And that is total salpingectomy, okay? So what are the other managements which I was trying to tell you? Very simple. This patient is not in any emergency. She is stable. She has come to the OPD and she's actually reading a magazine. I do an ultrasound and tell her that she's got a unruptured ectopic pregnancy. Now, when there is an unruptured ectopic pregnancy, how can I manage? First of all, tube is intact. It is not ruptured. Maybe I can do something different from a ruptured ectopic pregnancy. What did I do in a ruptured ectopic? I did a total salpingectomy. Here the tube is not ruptured. Maybe I can do something by which I can save the tube. Yes, so keep that in mind. Unruptured ectopic pregnancy, we're trying to save the tube. How can you save the tube? Why do you want to save the tube? She can use it for a normal pregnancy next time. How can you save the tube? You can medically save the tube. That is, you can do a medical management. We can give intramuscular methotrexate to the mother, and that IV or intramuscular both can be given. That is called systemically administered methotrexate, and that will take care of the pregnancy, that will degenerate the pregnancy. We can also give KCL, but KCL is given through a transvaginal route directly into the sac. So yes, KCL into the sac, and methotrexate can be given intramuscular or intravenous. There are many regimes. We can use 50 milligrams just directly one shot. That is also known to work. But if the pregnancy is bigger, then we give multiple dose methotrexate. That is day 1, day 3, day 5 and day 7. We give 50 milligrams. That is 1 mg per kg body weight is the dose of methotrexate. So for 4 days we give that, and alternate days, that is 2, 4, 6 and 8, we give the leucovorin rescue. So methotrexate can be given as a single dose or in a multiple dose regime, but that is medical management. But sometimes if the pregnancy is bigger, then we can do a surgical management. So what is the surgical management? We can make a hole in the fallopian tube like this, and we can push the baby out through this hole. So that is what is known as a linear salpingostomy. Linear, there's an A here, linear salpingostomy. So lengthwise, if you imagine my hand as a uterus and this is the fallopian tube, so you make a vertical incision on this fallopian tube like this. That vertical incision, and when you open this, the pregnancy is bulged out, it gets pushed out. We do a hydrodissection and push out the pregnancy, and then on the edges we just do a cautery so that the bleeding stops. So a lengthwise linear incision on the fallopian tube, linear salpingostomy. Now that is the best surgical procedure. You can also do a resection and reanastomosis of the fallopian tube. Now here you can do a repair because the tube is not ruptured. You give good surgical incisions and then reanastomose. So that's why we can do a surgical management or a medical management when it is a unruptured ectopic pregnancy. Now how do you decide that you want to do a medical or a surgical management? So this is the parameters. These are the parameters, that HCG value, if it is 5000 milli international units, so we can see if it is less than 5000, then we can do medical management. If it is more, then surgical management has better results. If the size of the ectopic is smaller than 4 centimeters, we can do medical. If it is bigger, then we have to do surgical. If the cardiac activity is absent, medical. If the cardiac activity is present, surgical. Now remember these parameters, even if one is towards this side, suppose the patient has a HCG value which is 4000 and the size is only 3 centimeters, but the cardiac activity is present, then I'll do a surgical management than a medical management. So this is how we decide. These are criteria which keep coming in exams. So all this management of an unruptured ectopic pregnancy to save the fallopian tube is based on an early diagnosis. That is, before the tube ruptures, we must diagnose an unruptured ectopic pregnancy. So early diagnosis is held by an ultrasonography. So if you do a transvaginal sonography, you can see a gestational sac as early as 4 weeks and 3-4 days, and a cardiac activity as early as 5 weeks and 2-3 days. Now, in a transabdominal sonography, the same can be seen at 5+ and 6+ weeks. So whatever you see in a transabdominal sonography, you see 1 week before in a transvaginal sonography. But sometimes there is a delayed ovulation, there's a delayed implantation. So sometimes the norms which we say that 4 weeks plus 3 days, you should be able to see a gestation sac. 4 weeks plus 3 days, by the way, is the 5th running week. So some books will give you some exams will give you 4 weeks and 3 days as the choice, or some exams will give you 5th week. So don't get confused. 4 weeks and 3 days, you see the gestation sac. In other words, in the 5th week, you see the gestation sac, and 5 weeks plus, that is in the 6th week, you see the cardiac activity. So don't get confused, okay? You must know this, and you must realize that 4 plus 3 days means the 5th week running. Suppose you are 24 years and 6 months. So which year is running? 25th year is running, all right? So same logic comes here also. Now, sometimes you see, if my hand is the uterus and this pen is the transvaginal probe of the ultrasound, in this TVS, the probe is right on the mouth of the cervix. So if there's a pregnancy in the uterus, I can see. If there's a pregnancy in the fallopian tube, I can get into the lateral fornix of the vagina with this ultrasound, and I'll see the pregnancy in the fallopian tube easily. So transvaginal sonography is actually the best sonography to find out a intrauterine or ectopic pregnancy. Now, even if you don't see with this transvaginal sonography, then your HCG values is helpful. Now HCG helps, don't say HCG is better. So what we do, we first ask the value of HCG. So do the HCG estimation and see the HCG is only 300. So you know the patient is pregnant, but it is too low sometimes for us to see the SAC, because if the HCG is low, that shows us an early pregnancy. So first of all, before using these values, let us know what is the discriminatory zone. Discriminatory zone of HCG. HCG values. So if it is more than 1500 international units of HCG, then transvaginal sonography will show you a SAC. If it is more than 6,500, 6,005, all right, 6,500 international units, then a trans-abdominal sonography will also show you a SAC. So if the HCG value is done, then that will be helpful. Now, how do I use this information? Suppose the patient who has early pregnancy, I do the scan, I cannot see the sac inside the uterus or in the tube. Then I do the HCG. HCG value comes 400. So I know it is too less to be seen by a TVS. So what do? I tell her, look, wherever the baby is, it is very small and it is not making enough HCG also. So wherever it is, even if it is in the tube, it is not going to rupture now. I cannot even see by the ultrasound. So don't get worried. Just we will keep you under close observation. So what we do? Suppose today is 1st of July 2023 and the HCG value is 400. Then on 3rd of July, it becomes 800. Then that is a doubling. So that is suggestive of a intrauterine pregnancy. Look, the value is still 800. More than 1500 you can see in the uterus or in the fallopian tube. So it is still 800. But since it has doubled in these 2 days, then we think it is an intrauterine pregnancy. So doubling takes place in 2 days. Okay, suppose it is 400 today and after 2 days it comes only around 530. So this is likely a ectopic pregnancy. So this relation is not true for 100%. This relation is true for 2/3 pregnancies, around 66% pregnancies they say. But that is helpful at least. So if it is double in 48 hours, it is intrauterine pregnancy. If it doesn't double in 48 hours, then it could be an ectopic, because doubling in ectopic pregnancy takes place 5 to 7 days. Now, why does it take 5 to 7 days in an ectopic and why does it take only 2 days in a intrauterine? Why this HCG relation is like this? Now, let's go back to the same diagram which we discussed early in the chapter, that this pregnancy which is in the tube, it is having the placenta which is maintaining the corpus luteum by the HCG, which is making the progesterone, which is maintaining the pregnancy and the endometrium also. But now, go back and remember what I told you. What is the fate of an ectopic? This ectopic which increases in size, it has vascular insufficiency. So when there is vascular insufficiency, the hydration of the placenta is lesser and the HCG produced by this placenta is lesser. The same pregnancy, if it is in the uterus, uterus is having a very good blood supply. It's a very vascular organ, 700 to 750 ml per minute, isn't it? The uteroplacental flow. So that kind of blood flow giving good hydration to the placenta, the HCG doubles every 2 days. But here there is vascular insufficiency. That's why the HCG doesn't double in 2 days. It takes 5, 7, 8, 9 days. So generally 5 to 7 days is what we give you as a level, as a mark, that in 5 to 7 days it will double. So please remember, that's the reason why the HCG does not double. Now you can also understand one more thing. If the HCG is not doubling in 2 days, why? Because there is vascular insufficiency. What does it mean? That the ectopic gestation makes lesser HCG versus a normal intrauterine pregnancy. It means that, so if the HCG is lesser, then the stimulation to the corpus luteum is lesser. So the progesterone values also are lesser in ectopic pregnancy. So yes, when we talk about
HCG levels, I already told you. If the serum progesterone level is more than 25 nanograms per ml, then it is likely to be a intrauterine pregnancy. And if it is less than 5 nanograms per ml, then it is likely to be a ectopic pregnancy or even a missed abortion. That can also be a conclusion because the progesterone is very low. All right. So what we did discuss here? We discussed that if it is an intrauterine pregnancy or ectopic pregnancy, we can make out that distinction by a early ultrasound like a TVS. But if that doesn't help, then the HCG values will help us. And HCG values, if they are less than 1500, then only we do the doubling titer. If they are more than 1500, let's say there are 3000, then a TVS will show the intrauterine or an ectopic. But if the HCG is less than 1500, discriminatory zone for a TVS, then we'll do the doubling titer. So it was 400, it doubled in 2 days, intrauterine. If it doesn't double in 2 days, likely an ectopic. Why? Because there is vascular insufficiency in a ectopic pregnancy. Also, because the vascular insufficiency, HCG values is less and the stimulation to the colpostridium is less, so the progesterone values are also. Now let us see something about molar pregnancy. So when we talk about normal fertilization, in normal fertilization, the oocyte which has dispersed genetic material, it gets fertilized with one sperm which is carrying 23X chromosome. Suppose sperm can carry 23X or 23Y also, but the oocyte always has a X chromosome. Now this genetic material in the oocyte is going to condense and give a 23X pronucleus, and that is from the female, and from the male it's going to be 23X or 23Y depending on what type of sperm is coming. So this is how normal fertilization takes place. The dispersed genetic material of the oocyte is going to condense and make a pronuclei. This is the pronuclei stage, and the sperm is also going to make a pronuclei, and then these are going to fuse and make a zygote, which in this case is 46XX, and then it's going to split into a 4-cell stage and then a 8-cell stage and then a morula, which is 16 to 32 cells, and then a blastocyst. So this blastocyst is day 5. This is day 5. This is morula, which is day 4, 16 to 32 cells, and 8-cell stage is the day 3, and 4-cell stage is a day 2, and this zygote is a day 1. Zygote and the pronuclear stage is on day 1. So this 4-cell stage, 8-cell stage, morula, blastocyst all come into exams. Now blastocyst, as we know, blastocyst is day 5, and in this you see this inner cell mass. This is the ICM. Inner cell mass is going to make the fetus, and here we see the TE, trophoectoderm. The trophoectoderm is going to make the placenta. All right. Now that's the normal sexual fertilization. Now let us see some variations. Sometimes what happens, there is one oocyte which has got its dispersed genetic material, and this one gets fertilized by not one but 2 sperms carrying 23X. Now what is going to happen? The oocyte's genetic material is going to condense and give a 23X as a pronucleus, but a 23X is coming from the male, another 23X is coming from the male. So this is going to make a 69 triple X. Now this is not a normal karyotype. This is a triploid. It's a triploid cell with 3 sets of chromosome. It's not a trisomy. Trisomy is one chromosome having an extra representation. This is a triploidy. Okay. Now this is not viable with life. This is not a viable pregnancy. The pregnancy aborts by itself in 12 to 16 weeks. What do you see? On the ultrasound, you'll see a fetus, apparently looks normal, but the karyotype is 69 triple X. You'll see a placenta, apparently looks normal, but on the microscopy, you'll see some villi. So when there is one egg in two sperms, this is what is a partial mole or the incomplete mole. And this partial or the incomplete mole, the most common karyotype, all right, the most common karyotype is the 69XXX. It can also be 69XXY. It can be 69XYY, but can never be 69YYY. That it cannot happen. So what happens in a partial mole? This partial mole has a 2 to 4% chance only of a choriocarcinoma. That's the good part about this. And it has got a focal degeneration of villi. Focal degeneration of villi means that's why it is a partial mole. Some villi are in the shape of vesicles. And interesting that there will be scalloping of villi. Scalloping of villi. Okay, so fetal products are seen and there is focal degeneration or partial degeneration of the villi versus the complete mole where there is diffuse degeneration. Now, this is going to have scalloping of villi. This is seen as the microscopic. When we send these tissues to the path lab, you'll see the villi looking like scallops. I'll try and explain that to you later. Now, what happens? Another variation of the sexual fertilization, there is a oocyte, but this oocyte is empty. This is an empty oocyte, no genetic material. It gets fertilized by a sperm carrying 23 eggs. So an empty oocyte, when it gets fertilized by a sperm carrying 23 eggs, the mother gives nothing. The female contribution is nothing, but the male contribution is 23 eggs. Now, what happens that this oocyte is not dead. This oocyte is empty. So this oocyte can trigger a endoduplication. Endoduplication of this and make a 46XX. Now, you may think that 46XX is the normal karyotype of all girls in this world. But yes, but this is not normal because both the X chromosomes are from the father. Both the X chromosomes are paternal in original. So that's why this MCQ came. Both X chromosomes are paternal in origin. So this does not make a normal fetus. In fact, this villi which are made, they are all degenerated. There is diffuse degeneration of villi and there is no fetal products. You will not see any fetal parts. Okay, so this has only vesicles all over the uterus. That's why it is the name given as a vesicular mole or the complete mole. Now this has diffuse degeneration of villi and it has up to 20% chance of a choriocarcinoma. Alright, and remember, this appearance on the ultrasound is known as the snowstorm appearance. It is somehow becoming a very often asked question both in INI-CT and MCI exams. So when we talk about the presentation of molar pregnancy, the partial mole, it has a fetus inside the uterus and it has a placenta. You may assume that it's a normal pregnancy. But when you repeat the ultrasound after a few days, you'll see the fetus is dead. And in between this, there was no, in between these two scans, there was no bleeding, there was no pain, there was nothing. So that is like a presentation of a missed abortion. We have discussed that in the rapid revision. What is the presentation of a missed abortion? Now, how does a complete mole present? Complete mole has some very peculiar presentations. That there might be passage of grape-like vesicles. That's very rare though. The most common is bleeding per vaginum. Now, what else is peculiar? Early onset of hypertension, uterine size more than the period of gestation. What is the meaning of this? You may have a pregnancy of 8 weeks and in an 8 weeks pregnancy, when you do a per vaginal examination, the uterus size is that of an orange. But here, the size of the uterus might be like 20 weeks, 28 weeks. It might be very big as compared to the duration of gestation. Then the uterus is empty to feel. It has a doughy feel. When you do a palpation, you will not see any fetal products. And then due to the high HCG, there might be a theca lutein cyst. Remember in ovarian tumors, we've discussed that. And then hyperemesis because of the high HCG. And this high HCG, the alpha subunit is similar to the alpha subunit of the thyroid stimulating hormone. So this alpha
subunit of HCG, which works like alpha unit of TSH. This goes and stimulates the thyroid gland and starts making more and more thyroxine, and the patient presents with thyrotoxicosis. All right. So that is the presentation. Remember, at the diagnosis of the vesicular mole, if the HCG is more than 10 to the power 5 and the uterus is very big and the theca lutein cyst is more than 6 centimeters, so all of this will cause more chance of choriocarcinoma later in this patient. Okay, so this came as MCQs many times. All of these are predisposing signs for a patient having choriocarcinoma when a molar evacuation was done. Like these questions have come in your exams. Now, I was saying diagnosis. So this, in a classical presentation of a molar pregnancy on the ultrasound, you'll see a snowstorm appearance that you can imagine opening a window in a dark night in, let's say, in a cold country, and where you'll see a blizzard and you'll see snowstorm. So that appearance is there. So that snowstorm appearance, very classical, coming in the exams all of a sudden once more. Then on the histopathology, you will see in a partial mole scalloping of villi. So here what I'm showing you are the scallops. You know, this is seafood, and all of you must have seen this, especially my friends who like seafood. So this scallops, you know, open them, there's some fleshy meat inside which people eat. So the villi looks something like this. I don't have my own PATH slide which is showing scalloping of villi. Let's see, maybe I can show that to you in some other forum. But this scalloping of villi, the margin of the villi will look like this, scalloping of villi. So I'm just showing you the scallops right now, not the histopathological view of the scalloping of villi. I'm sure my PATH friends will show you that. So let's move on and see how you do the final distinction. Look, when you're trying to see on the ultrasound, you may say a fetus with a placenta and there's a missed abortion, so you think it's a partial mole. In a case of a complete mole, you'll see a snowstorm appearance. Fairly, reliable diagnosis. But in a partial mole, the diagnosis is complete only after you do a histopathology. Now, when you do the histopathology and you see scalloping of villi, you're very sure that it's a partial mole. But sometimes you see none of these things. On the histopath, sometimes you may not be able to distinguish between a partial mole and a complete mole. So sometimes the last method by which we can distinguish whether it's a partial mole or complete mole is to do the immunohistochemistry. That's the final distinction. So how does that help? Immunohistochemistry of the P57 expression is utilized. P57 expression is contribution from the maternal genes. But remember, in a complete mole, there is an empty oocyte which is fertilized by a sperm. So there is paternal contribution and no maternal contribution. So yes, if there is a partial mole, you will see the P57 contribution because there is maternal genes there. But in a case of molar pregnancy, P57 is not seen. So yes, if there is no P57 on the immunohistochemistry, then you're very sure that the diagnosis is of a complete mole, right? So what is the treatment of a missed abortion? That, of course, depending on the period of gestation, the partial mole presence as missed abortion. So partial mole, depending on the period of gestation, the size, we can make a decision like we discussed in the chapter of abortions. But treatment of complete mole, this is what is coming in exams regularly. Partial mole works like missed abortion. Complete mole treatment is suction evacuation. Please do not forget this. Don't say DNC, don't say hysterectomy. We want to make you answer suction evacuation. We may scare you in the exam by asking you a very large uterus, 30-week size uterus, and such a big uterus, how will you do a management? Don't get scared at all. Whatever size we ask you in the exams, always the answer is suction evacuation. So I will write here, any size uterus, suction evacuation. Then this is done under oxytocin infusion. Oxytocin infusion will help evacuate these vesicles more easily. Now, the important part is the follow-up, because we are worried that there's up to 20% chance of a choriocarcinoma happening. So, what is, maybe I'll take a minute here, what is choriocarcinoma? Placenta is made up of syncytiotrophoblasts and cytotrophoblast, the villi. All right. Now, this is what is also known as a chorion. Placenta is known as a chorion. So, when you take out the placenta, complete placenta should come out after a delivery. Now, complete placental tissue should come out even after suction evacuation. You've done a suction evacuation, the bits which are there inside the uterus should all come out. Nothing should stay back. So, some bits, if they stay back, they will persist and grow again. So, that is going to be a placental cancer. Now, I don't call it placental cancer. I would like to call it choriocarcinoma. That's how we are. Terminology is very simple, but we keep it complicated by using synonyms in gynecology. So, placental cancer is basically known as a choriocarcinoma. So, after 1 week, in a case of a vesicular mole evacuation, do a check curettage to rule out retained bits and do a chest X-ray, because the most common site of metastasis is the lung. You'll get the cannonball secondaries if they are met, and beta HCG levels as a follow-up tool. So, HCG should be reducing after the molar evacuation always. Right. When we are seeing the HCG reducing, you'll do it weekly. You'll go on do it weekly till it is negative. So, 7 weeks it takes for the partial mole to come to negative levels, and 9 weeks it takes for the complete mole to come to the negative levels. Even after that, we'll do it once a week for 3 weeks, even when they are normal. Once a week for 3 weeks, and then we'll do once a month for a year. If not a year, at least for 6 months. And in this time, no pregnancy during follow-up. The 6 months when you're doing a follow-up, what are you trying to see? You're trying to see the HCG should go on reducing, and when it is 0, then it should not increase for the next 1 year, or at least for 6 months. Now, if it starts increasing, HCG starts increasing, maybe it's developing a choriocarcinoma. Now, your follow-up can get confusing or can get muddled up if she decides to get pregnant in this follow-up. If she is pregnant, then the HCG anyway will start increasing. So now the problem is you don't know whether it's an early pregnancy which you're seeing on the ultrasound, or it is a recurrence of disease and an early choriocarcinoma. So yes, for the best follow-up, tell the lady not to conceive. So give her contraception, and the best contraception here is combined oral contraceptive pill. All right. Then once we know that we are doing the follow-up, there should not be any choriocarcinoma. Now, what all possibilities are there? What all can happen in a case of molar pregnancy? Now, let us come to the most important part of the discussion of this molar pregnancy chapter. So, when we talk about the vesicular mole, it can persist the trophoblastic tissue, and that can become a choriocarcinoma. The follow-up of this choriocarcinoma, the marker is HCG, and the best treatment is chemotherapy. All right. Now, when we talk about a vesicular mole persisting and making a choriocarcinoma, what is wrong with a vesicular mole? Vesicular mole has placental tissues which have stayed back, and this placental tissues have become a cancer. It's a placental cancer, or we said a choriocarcinoma. But like we discussed, placental tissues can also be there in some other conditions apart from vesicular mole. Yes, placental tissues can be there in a normal pregnancy. They can be there in abortions also. Now, a normal pregnancy can persist its tissues and make a choriocarcinoma, and so can an abortion which can persist its trophoblastic tissues and make a choriocarcinoma. But the chance is very less. Vesicular mole becoming a choriocarcinoma is 20%, normal pregnancy is less than 1%, and abortion is less than 1%. That's why we don't follow normal pregnancy and abortions for the HCG levels, but we always follow for a vesicular mole, 20% chance of becoming a choriocarcinoma. Wait, it is not yet over. This can persist and start becoming a invasive mole, locally invasive, and no systemic secondaries. So, invasive mole, the follow-up is again by the HCG, but the treatment is surgery, generally a hysterectomy. This can persist and make a placental site trophoblastic tumor. A placental site trophoblastic tumor, and this is from the cytotrophoblast. When it is from the cytotrophoblast, the follow-up is by human placental lactogen. So that's the difference. this MCQ has come. What is the follow-up tool of a placental trophoblastic tumor? That is human placental lactogen, because this is from the cytotrophoblast. So needless to say, invasive mole and choriocarcinoma is from the syncytial trophoblast. All right. So the treatment of a placental trophoblastic tumor is also a surgery, mostly a hysterectomy. Okay. So this is the protocols. Now see here. All of this can become all of this. These are the benign trophoblastic conditions. Benign trophoblastic conditions. But these are the gestational trophoblastic neoplasms. Please, I want all of you to understand this. That's why I've not, typed it and kept it ready. You must understand this chart very well, because I'm trying to tell you placenta basically persists and makes a cancer. It is a placental cancer, choriocarcinoma, and placenta is there in vesicular mole, in normal pregnancy, and in abortions. Now, all of this can become all of this. Well, you are correct if you say that. A normal pregnancy, yes. Now you will be writing a PG entrance, and there they will ask you such questions, that a normal pregnancy can make a choriocarcinoma and a placental trophoblastic tumor, but it does not make a invasive mole. So invasive mole does not follow a normal pregnancy. So yes, all of this can become all of this. Mostly correct. Only exception is that a normal pregnancy does not make a invasive mole. All right. So let us summarize what all we discussed now, and choriocarcinoma is the summary which I want to tell you, because that is the one which is mostly coming in the exam. So choriocarcinoma can follow a vesicular mole. 20% vesicular mole can become choriocarcinoma. It can follow an abortion, less than 1% of these. It can follow a normal pregnancy, less than 1% of these. Now, this is what I've taught you. But if I ask you the incidence the other way around, how many choriocarcinomas follow a vesicular mole? Look, how many vesicular moles become a choriocarcinoma? 20% of vesicular moles. But how many choriocarcinomas follow a vesicular mole? 50% choriocarcinomas follow a vesicular mole, but 25% follow abortion, and 25% follow a normal pregnancy. And when choriocarcinomas follows a normal pregnancy, this is the worst prognosis. Now, this is what is solid MCQ information. Vesicular mole can become a choriocarcinoma, and so can an abortion and a normal pregnancy. But when normal pregnancy becomes a choriocarcinoma, is the worst choriocarcinoma to have. Okay, so please remember, this is one of the factors for which this class was done. And remember, this is one of the factors which is in the prognostic scoring system by the WHO. So the WHO prognostic scoring system, it's a very expansive system where we are having 9 factors which are having the bearing on the prognosis. You have to know all these 9. Maybe you don't have to know how to calculate the score, but you have to know all these 9s. So the age of the patient, when she had this choriocarcinoma and the HCG was high, what was the antecedent pregnancy? That is, if a person has choriocarcinoma, what was the event of pregnancy before? See, if it is a full-term pregnancy, the score is higher versus a vesicular mole having a choriocarcinoma. Then, what was the interval between the antecedent pregnancy? Suppose it was a vesicular mole. How long did you take before chemotherapy was started? If it was started very late, let's say more than 12 months, then it is going to be getting more higher scores and higher risks. Then HCG levels at the time of diagnosis, I told you, more than 10 to the power is bad news. ABO blood groups, B containing groups are bad news. And then largest tumors, if they are more than 5 centimeters tumors, that is bad prognosis. Smaller tumors are better prognosis. Number of metastases, 4 and less is good. More than 8 metastases is bad. And the site of metastasis, that is what is very important. Site of metastasis, brain and liver is the worst possible sites for metastasis. Poor prognosis, because all of that is giving more points and more higher the risk when it is cumulative score is higher. And what if a patient had chemotherapy by 1 drug, the score is 2. If it is more than 1 drug, then the score is higher. So these are the prognostic scoring system, and this is what is asked in your exams, because these 9, this can be asked. All of these have a bearing on the prognosis of choriocarcinoma. Like that they can ask. So remember these 9 if you don't know how to calculate this. But one peculiarity, this is a big chart which you have to remember. One peculiar thing which I want to tell you, in the site of metastasis, what did I tell you is the most common site? Yes, what is the most common site of spread of disease? Lung, isn't it? Lung is the most common site of metastasis. So do a chest X-ray. I told you in the follow-up. Can you see anywhere if lung is written here? Spleen and kidney 1 score, GI tract 2 score, brain and liver 4 score. But there is no mention of the lung. So yes, remember this when you're calculating high risk or low risk. There's a question in NEET exam, and most of the forums where I saw the answer got muddled up because people thought involvement of the lung is bad news. Yes, it is bad news, but when you're calculating the score based on lung metastasis, it is not even mentioned in this scoring system. Keep this in mind. All right, now let's move on and see what is the staging of choriocarcinoma. Stage 1 is limited to uterus. Stage 2 is in the pelvis. Even vaginal metastasis, if there's a vaginal node in a case of a choriocarcinoma, it is stage 2, okay? And stage 3 is the lung. There's a dedicated stage for the lung, stage 3. And stage 4 is distant metastasis. All right, so that is the staging of choriocarcinoma. Now, when we spoke about this WHO prognosis scoring system, I told you all about the score, and now I told you about the staging. Now, let us put together and give you a method of saying this person with this size tumor, with this site of metastasis is high risk or low risk. How do you term a patient high risk or low risk? That will help you manage your patients. So yes, when WHO scoring system is less than equal to 6, it is low risk. Or some books say less than 7, means the same. Less than 7 or less than equal to 6 means the same. And more than equal to 7 is high risk. Putting all these features, these 9 features together, you can keep this chart in your wards and you can find out if it is less than equal to 6, low risk, and more than equal to 7 is high risk. Now, let's move on and see the staging, which I already told you. Now, what is high risk and what is low risk? Please remember, stage 1 is always low risk. Stage 4 is always high risk. And stage 2 and 3 is high risk or low risk depending upon the scoring system. Yes. So if there is stage 2 disease, that is, it is involving the pelvis, and the score is less than equal to 6, then it is a low risk. If the score is more than equal to 7, it is high risk. So yes, this is how you give the risk allotment, and then based on the risk, you give the chemotherapy or the treatment. So we are talking mostly choriocarcinoma. So we are talking mostly chemotherapy as the best management. Although surgery can also be done. Let's talk about the outright basics first. So low risk, high risk, stage 1 and stage 4 respectively, and 2 and 3 depending on the scoring. Less than equal to 6 is low risk, more than equal to 7 is high risk. All right. Now, based on that information, now the chart of treatment. Don't get confused with the size of the chart. It is very simple. Stage 1, it is low risk. Give 1 chemotherapy. That's it. Stage 2 and stage 3, depending on the score, whether it is high risk or low risk. So, if it is low risk, again give single agent, because stage 1 is always low risk. And if it is stage 2 and 3 with less than equal to 6, it is still low risk. So give single agent chemo. Now, if it is high risk, that is more than equal to 7, give combination chemotherapy. So I've written the drugs here. Just remember, give the combination chemotherapy for the high risk. Now, if it is stage 4, what is stage 4? It is always high risk. So if it is always high risk, give combination chemotherapy. See, it has become so simple now. So stage 1 is low risk, give single agent. Stage 2, if it is low risk, stage 2 and 3 together, if it is low risk, less than equal to 6 score, then give single agent. If it is high risk, that is stage 2 and 3, if it is more than 7, give combination chemo. And if it is stage 4, which is always high risk, give combination chemo. So simple. All right. Now, there are some variations to this rule that initially you do this. If they are resistant, then go to the next step. So always, if it is single agent, the next step is combination chemo. If it is already combination chemo given, then second line chemo. So see here, the single agent which we are mostly liking is methotrexate, and if that doesn't work, the combination chemo which we always give first is the MAC regime: methotrexate, actinomycin D, and cyclophosphamide. Now, if that does not work, the second line combination therapies are, for example, E-MAC-O. MAC is the same, E is for etoposide, and O is for oncovin, also called vincristine. So this is the method. If you remember this chart, that question which came in the NEET exam, most of the places where I saw the answers, people have said give combination chemotherapy. But then the answer to that question, when there was a cancer patient of choriocarcinoma and there was no other information given, it is involving the lung. That's the only information given. What is the answer? Single agent chemotherapy, because lung is the most common site of metastasis and lung is not even part of the scoring.